Hi, good morning, everyone. I'm from backend team, technical team. Sir, we are ready to go live. Should we?
Yes, please go live. Give us a countdown on 10.
Okay. I'm from backend team, technical team. Sir, we are ready to. Sir, it's my request. If yes. Sir, I request if someone log in two devices at the same time. So please mute one device. Yes. Sir, I request if someone log in two devices at the same time. So please mute one device. Okay. Sir, no problem. Sir, Sir, I'm giving you a countdown.
Okay.
10, 9, 8. Sir, I'm giving you a countdown. 7, 6, 5, 4, 3, 2, 1. We are live.
Good afternoon, all. I welcome you all in Trauma 2020, the virtual conference on day 3. I hope that you have enjoyed the last 2 days filled with fun and lot of information and knowledge. And let me assure you that today will not be lesser than the last 2 days. I am quite sure that you will relish the exigencies and the extravagance of the knowledge and skillful demonstration. Without wasting much time, let me invite today's chairperson. I welcome Dr. Rajsekhar Mohan as a chairperson for this session. Dr. Rajsekhar Mohan is a professor and head of Department of Surgery at KS Hegde Medical Academy, Bangalore. Sir has a keen interest in demonstration and teaching. Welcome, sir, on board. Next is Dr. Anita Dhar ma'am. Ma'am is a professor of surgery at Department of Surgical Disciplines, AIIMS, New Delhi. Ma'am has a vested interest in vascular surgeries and lot many papers in her name. Welcome ma'am on board.
Hello, good afternoon.
Good afternoon ma'am. Next, Dr. Hemang Bhattacharjee. Sir is an additional professor of surgery at Department of Surgical Disciplines, AIIMS, New Delhi. Sir has a vested interest in general surgical procedures as well as minimal invasive surgeries. Welcome, sir, on board.
Hello, good afternoon.
Good afternoon, sir. Most welcome. Dr. Asuri Krishna is Associate Professor of Surgery at Department of Surgery, AIIMS, New Delhi. Sir has a vested interest in minimal invasive surgeries and lot more. Sir has a lot more papers in his name. Welcome, sir, on board.
Thank you, Narendra. Thank you. Good afternoon, everybody.
Dr. Akshay Kumar is an Assistant Professor in Department of Emergency Medicines, AIIMS, New Delhi. Sir is having the keen interest in acute care management and acute emergencies. Welcome, sir. Now I request Dr. Rajsekhar Mohan to...
Thank you so much.
Thank you, sir. I welcome Dr. Rajsekhar Mohan and request him to kindly introduce our moderator for this session, Professor Subodh Kumar.
Thank you, Dr. Narendra, for the nice introductions. It's my privilege to introduce Dr. Subodh Kumar, sir. Sir is Professor of Surgery at the JN Apex Trauma Institute at New Delhi. Sir has more than 25 years of teaching experience and is a well-known figure in the world of trauma surgery in India and overseas. And sir is going to be the moderator for this session and is going to take us through this entire session of lectures by eminent faculty members. Over to Dr. Subodh Kumar, sir, for continuing the session. Thank you, sir.
Very good afternoon, all the chairpersons and the speakers of this session. It's a privilege to moderate this session on a very important topic in trauma. So in trauma, the most common cause of shock is hemorrhage. The next most common cause of shock is hemorrhage, and so forth. And this ongoing bleeding in a trauma patient results in a trauma triad of death, which includes coagulopathy, hypothermia, and metabolic acidosis. But thing is not that bad. This process is reversible, provided you diagnose traumatic shock early and start resuscitation, which includes the most important management, that is stop the bleeding, and stop the bleeding. And there are many ways to stop the bleeding in trauma patients. And to discuss these procedures, hemostatic procedures, I invite the chairpersons, I request the chairpersons to start the proceedings of this session. Thank you very much. Ways to stop the bleeding in trauma patients.
Should I introduce the next speaker, sir?
I request Dr. Anita Dhar ma'am to introduce the next speaker. Let Dr. Asuri should introduce the next speaker. Sorry.
Yeah. Good afternoon, everybody. As usually the dictum goes, we always do a head-to-toe examination. I think the best way to start will be to how to deal with maxillofacial bleeding. For this, I'd like to invite Dr. Ruchi Pathak, who is presently pursuing her PhD course in Jayaprakash Narayan Apex Trauma Center. She has done an MBBS, and it will be a privilege to listen to her what she's going to talk about maxillofacial bleeding. Over to Dr. Ruchi Pathak, please. Thank you.
Thank you for the invitation, sir. I would like to share my screen. So now today we are on the third day of our Trauma Virtual 2020, and it has been a plethora of sessions, and there have been amazing sessions. as the stage has been said by Dr. Subodh regarding the 3 coagulopathy cycles, now regarding the cycle, and so now I will take it forward, speaking on maxillofacial bleeding. The agenda for this will be an overview of maxillofacial bleeding, algorithm for emergency management of maxillofacial bleeding, arterial supply of the nasal septum and lateral nasal wall, and a step-by-step process of placing a posterior nasal pack. Now, maxillofacial region, as we said, starts from the head, so is very prone to because of its rich blood supply, and the life-threatening maxillofacial hemorrhage can vary from 1.4 to 11%. And so 1 in every 10 fractures bleeds significantly. Major vessels involved in maxillofacial trauma are internal and external carotid arteries. If we look into the algorithm for the emergency management, the purpose of hemostasis here is basically 2-way. The first one is protect the airway. So according to the ATLS protocol, the A stands for this airway which we need to protect. And therefore, the first step is to identify the source of bleeding and then clear the airway with the process of suctioning. And the second step is to reduce the blood loss. Now, to reduce the blood loss, now we know that we need to identify the source of bleeding. In case of a maxillofacial injury, it is usually 3-way. It is either an extraoral source, an intraoral source, or nasal. In case of extraoral source, it could be a face or scalp. We can apply sutures or additional pressure to stop bleeding. But if it doesn't, then we go for angioembolization. Now coming to the next, which is intraoral, it could be either bony or soft tissue. If it is bony, because of fractures, we need to reduce these fractures, which usually stops the bleeding. If it does not, then we need to definitely go for angioembolization. In case of soft tissue, we need to apply sutures and then pressure, which again stops the bleeding usually. If it does not, then definitely we need to go for angioembolization. Now today I'm going to discuss more on the nasal aspect. The nasal bleeding is on the anterior end and on the posterior end. On the anterior side, we can go for pressure packing. But what is the cause of the anterior bleeding? So most of the time, it is the Kesselbeck area or the Little's area, which is a plexus which is formed by multiple arteries. And this area, if happens to rupture, causes severe bleeding, which can be controlled by pressure packing. If it does not, then we can go for an anterior nasal pack or balloon tamponade. Similarly, with the posterior region, we cannot pack this region. So now here we need to go for a posterior pack, and it becomes very important to know exactly how to place this posterior pack. I will take you through a journey where I will first take you through the arterial supply of nose so as to know the kind of epistaxis and the ways we can control it. Let's get on to the whiteboard. And as we see, that the blood supply of the nose can be divided into septum and lateral wall. If you look at the septum, the basic supply of the entire nasal cavity is either external carotid artery or internal carotid artery. If you look at the internal carotid artery has ophthalmic artery as its branch, which is further divided into anterior and posterior ethmoidal branches. Please see here, in the anterior portion, we only have anterior ethmoidal artery. The posterior ethmoidal artery is not there in the anterior region, therefore does not form the Little's area or the Kesselbeck plexus. This is very important. Next, we have the external carotid artery with its 3 branches. The superior labial dividing into septal branches to provide the Kesselbeck's area. The maxillary artery is divided into greater palatine and sphenopalatine. All the 4 arteries which join at the anterior region form the Little area, and this is 85% of the times the area which bleeds and causes anterior epistaxis. Now, if you look into the lateral area of the nose, the difference, the anatomical difference only lies in the fact that in the lateral nasal wall, we have the maxillary artery dividing into lesser palatine, greater palatine, and sphenopalatine. So that is the only difference. Otherwise, the anatomical region remains the same. Now, the posterior region bleeds because of 2 main arteries. The first one being the ophthalmic artery, the branch, posterior ethmoidal branch, and the second one being sphenopalatine artery. And therefore, if we have to go for angioembolization, these are the 2 areas we need to look into. Now, after this bit of an anatomy of the nose, let us get into the next, which is a demonstration of posterior nasal packing on a 3D printed model. So there are certain steps to take care of. The first step is suction and clear the passage. As I said, we need to have a clear airway before we start anything. So by suctioning and clearing that area, we need to clear the edge. Second step is checking the Foley's catheter and marking. So before we even insert the Foley's catheter, we need to check it. So we take a 12 or a 14 French Foley's catheter, insert 5 ml of saline and check that there is no leakage in the balloon out there. Once we check that, there are 2 steps that we do here. We not only check that there is leakage, but we also calibrate the length that has to be that has to go inside the nostril. Now, how do we do that? According to the literature, it has to be 8 centimeters. So what we do is we can place our finger. That is what I do. We place our finger, and the length of my finger is approximately 6 centimeters. I take another 2 centimeters. That goes to 8 centimeters. I can mark it on the catheter, and if I don't want to mark it, I can just hold it there. And then after this, we come to the next. But before we place it, we need to remove the saline that we had poured in, and now we can take this and insert the catheter along the floor of the bleeding nostril after we lubricate it with the jelly, with the lignocaine jelly. And but make sure that marking is clear. So just recheck that again if you haven't marked it, and then insert it inside. So 8 centimeters is a very safe length that we can take for this insertion into the nasal cavity. And once it is there, we can then insert 5 initially to begin with 6 ml of saline to actually block the posterior area so that the balloon can inflate initially and engage in that area. Once we've done that initial amount, which is 6 ml, we can apply a little traction over the catheter. Once you apply that traction, it actually engages well in the posterior region. Once you feel that you can actually feel it has engaged, you can then actually insert another 1.5 ml, which can increase up until 15 ml. So that is the maximum limit, but one should not go beyond 15 ml. And it can be less than 15 ml depending on the distress which is being experienced by the patient. Usually 15 ml is an amount which is sufficient to actually block the arteries and block the epistaxis. And then we place the gauze below the LR region, and then we need to clamp this. We need to clamp the catheter out there. After this, let us get a little bit behind the scenes of the nasal pack. What happens is that length between the anterior spine and the posterior nasal spine, in my case, was 5 centimeters. But generally, taking into consideration the soft tissue, we take it as 8 millimeters. And this was a study which was done by McGarry in 1991, where he said that 8 centimeters is the safe distance. Now, secondly, as you can see here, where the balloon engages initially. Now, if you know that the balloon engages here, now this 6 ml is initial amount which is taken. And the reason to that is with 6 ml, the engagement is very precise. With less than 5 ml, it is said in another study by Lee that this actually comes out. So therefore, the first insertion is amount of saline is 6 ml. And after this, as we can see, how much inflation is much. So as I explained, it is 6 ml initially according to the study. But as we go ahead, 1.5 ml we can insert sequentially till it is 15 ml. We have to check before we insert after 6 ml, after a little bit of time. So after a while, we have to check it again if the posterior nasal bleed has stopped or not. Now we can just watch a little video on the posterior nasal pack, which is a live video. This was done in our emergency department. So as you can see here, this is the Foley's catheter, which has been taken, being inserted into the nasal cavity. And after you've been inserted the amount that you need, this is the initial 6 ml that you insert so that it can engage in the nasopharynx. And once you do that, you can then create that traction to actually engage it. And then when you move it forward, and then you can clamp. Similar situation, if you need to pack the other nostril and it hasn't been done, you can repeat the same scenario on the other nostril. And once you place it, you can then tie both of them together, engage it on the gauze. And that's how we go for posterior nasal packing. These are the references. Thank you very much for the patient hearing.
Thank you, Dr. Ruchi. That was an excellent talk, and it was refreshing to see the whiteboard being used. And now I'd like to invite the other chairpersons to kindly introduce the next speaker. I think so we'll be taking the question and answers at the end of the session. Can we have the next chairperson introduce the next speaker, please?
Yeah, hello. Good afternoon, everyone. Can you hear me?
Yes, we can. We can hear you, ma'am.
Hello. May I invite Dr. Abhinav Kumar? Hello. May I invite Dr. Abhinav Kumar for the next talk? Dr. Abhinav Kumar, he is Assistant Professor in the Division of Trauma Surgery and Critical Care at JPN Trauma Center, AIIMS, New Delhi. Dr. Abhinav Kumar, kindly start the talk.
Yeah, good afternoon. Am I audible now?
Yes, you are audible.
Yeah, thank you, sir. And that's it. Thank you, ma'am, for your kind introduction. And I just, at the beginning, I just give my greetings from my institute and thankful to the organizer to giving me an opportunity to talk on this. So at the outset, I would like to say that then a trauma management is a management where it's a common platform, meaning either you are a trauma surgeon or a trauma physician or a trauma nurse, your motto is the same. And what sir has said, Dr. Subodh, that first and foremost is the stop the bleeding, stop the bleeding. That's the hemorrhage control. And that's the topic of which I'm going to discuss and how an ICD becomes an hemostatic intervention. And the second motto is the continuum of care, and that it is of prime importance, and it must not be, and it must be maintained at any cost during your treatment, right? Start from the resuscitation till your rehabilitation of the patients. So as a trauma physician, nurse, you must be passionate about it, and it matters. Coming to this, the ICD as a residence, when we were surgical residents, it was taken as one of the common invasive procedure which were being taught, and it still holds the true now in an acute trauma setting, that it's a life-saving tube when it is indicated. And you must remember when it is indicated is so important. And as we have gone through the lectures yesterday, which was on thoracic injuries, where in majority of patients with thoracic trauma, if you just a simple intervention, that is the ICD insertion, and what we call in a trauma management phase, there is a non-invasive management or non-invasive intervention, it becomes a definitive management in majority of the traumatic patients with hemothorax, pneumothorax, or hemopneumothorax. So the question comes to your mind, how a tube, which we have learned as a resident, is it a drainage tube only? Is it? So to understand this, let us understand how it works. What is its function? The basic physiology of a pleural cavity is that it has a negative intrapleural pressure, and this is what a negative is so important here. It keeps the lung inflated, and that is how, if the lung is inflated, it creates a good ventilation perfusion. So whenever there is a trauma, what will happen? There will be either accumulation of air, maybe parenchymal injury, or there will be a fluid. What is that in trauma? Fluid is blood. So where it comes from, the blood in chest, the main cause is the intercostal vessels. The second is the bleeding from the lung parenchyma, and the third from the major vessels. So, so when there is this negative pressure is attenuated, and the VCL cycles also, and the physiology gets deranged. But as a matter of concern, when we talk of stop the bleeding campaign, where you talk of compression. So here, if you just put a tube, what it does, it allows the lungs. First of all, it takes you to the normal hemostasis physiology. That is it maintains the negative intrapleural pressure. And what is it doing? This ICD insertion, what it does, it expands the lungs, and you will understand why expansion it helps. See, it expands the health, and it opposes the pleural cavity, and it gives the compressions to the intercostal vessels. When you talk of the bleeding from the parenchyma, it is a low pressure system. So when it expands, it acts as a tamponade, and the bleeding stops. And for the major vessels, the answer is surgery. You have to use your knife. So this tube, what we have said, that is it acts as a one-way valve, which only allows the passage of air or fluid. It doesn't do the other way reserves. So this is what it makes you understand that it becomes not only a drainage tube, but a hemostatic tube intervention in acute trauma setting. What are the factors which are concerned in trauma? In trauma, which have been very particular, everybody talks about right person in a right time and a right place. So here, if you have to understand, we'll be understanding in the three measures what is the timing when we should put it, the place where we are trying to put this tube, the person who is going to put, and the procedure how we are going to demonstrate in the video so that it becomes safe for the patient. So timing in trauma everywhere, the timing is critical. If you are on time, adequate timing, the outcome will changes. So it is critical. So as a trauma physician, when you are in a resuscitation bay, it is the interventions where you have to judge clinically patient on the basis of the physiological parameters, what is called the clinical parameters, which is the essence of the primary survey, where you have to just look on the primary measures and then you have to assess and intervene. The adjuncts, what you call the radiology, it's an adjunct. One should understand it is just a supplementary and essential. So whenever you are in doubt, that you should not wait for the radiology to come, because it's very difficult at a level 1 center where we just talk of point of care where the radiology comes to the patients, either be X-ray, ultrasound. Here, your interventions should not wait for the radiology. So you must be on the basis of your clinical and physiological, you must intervene. And whenever, keep it in mind, whenever you are in doubt, put a tube. So where should we be putting a tube? It's better that you put in a controlled environment. And the best control environment is the hospital. But it depends on if you go and take out the global scenario, where the patient depends on the trauma system of the country where you are having, you can put it into the pre-hospital setting also has been said. But it is, as the bottom line is, you have to put in a control environment, and best control environment is your resuscitation bay in the hospital. Who should be there? And the answer is this: the procedure any trained person can put. Don't make it a bottom line that a trauma surgeon should only be putting. Any person involved in the trauma care in the resuscitation bay should be trained and be competent enough to put a tube. And the motto should be that the patient safety is to be ensured, keeping in mind, do not harm, do no further harm to the patients. And literature has said, if you're not adequately trained and experienced enough, the complication rates are operator dependent. So training is a must. And next, we'll tell you how we are going to this one. Though simple, it is critical. At the outset, whenever you are dealing with trauma patients, all patients are this is a medico-legal case. So whenever you are doing any intervention in a patient, the informed written consent is a must. It should not be, except in cases of extremes where you don't require. But other than, you have to take consent. For this video presentation, which I'm going to demonstrate, prior consent of the patient was taken for the video demonstrations. I'm thankful for the patient which has given the consent for it. And before giving, a single shot of antibiotic is indicated prophylactically, and it depends on most of the institution, but single shot of antibiotic is preferred. Indicated. So to begin with, it is said that you should be prepared. Any trauma system, you should be prepared for yourself. So preparation begun is called half done. So preparation starts with the what you are there with the armamentarium. We should have a tray ready at in your resuscitation bay. That includes the artery forceps, scalpel, blade, suture material, needle holder, the local anesthetist, and the ball with the sponge gauges, and the 2 ICD tubes. and preferably you take around 28 French of the ICD and the ICD bottle. So just a word of caution here, the ICD bottle here. So, एक minute. The ICD bottle, एक minute पीछे क्यों नहीं जा रहा? Here, what you have to take, you have to just before when you're going for a procedure, just there is a marking here that you must fill the bottle with with the adequate marker, which forms the column movement for the ICD to be there. So you have to place the fluid there and be prepared for it. And in trauma setting, it is said that this ideal situation we have a very armamentarium of student, but in limited resources you also can do, and what you can do have is the artery forceps, scalpel blade for your forceps, needle holder, and a blade with the two tubes, and that also can suffice. So when you begin with it, is come to the marking. What we talk about the triangle of that every day, and here what we are talking about the triangle of safety, and this is how it is marked. It is the anteriorly, it is the lateral border of the pectoralis major. Posteriorly, it is the latissimus dorsi, and the line which is vertically drawn from the nipple area, that it forms the base of the triangle. And how to just go to spaces. One method is you corner the mid-clavicular line and count down the ribs when the first space is the second space, and come down and you go laterally. This is how we have to go about it. And in female patients, what is the best is we go around the inframammary fold, so that it becomes, and you are anterior to the this mid-axillary line, this anterior mid-axillary line. The positioning is so important here. You have to just keep the arm abducted as shown in this. They keep the arm abducted and place it behind the head so that it is stable. Doesn't hamper when you are just you're in a process of putting a tube. So next step is when you take it, then the proper aseptic technique is to be used to drape yourself with your gowns, use betadine, and surgically, as just like an eagle's eye, you must expose your area, what your concern is, so that the triangle of safety is your visualized. And before and when you are doing this, maintain the asepsis, means at no point of time, because this may get infected also. So again, when you are draped it, again reconfirm the positions. However, where is your angle of safety, triangle of safety? Why it is so important? The triangle of safety is fifth base, because here the muscle bulk is less. One. Second, it is said that the diaphragm may come up, so you are less likely to injure any diaphragm. So this procedure is painful. So local infiltration with 2% xylocaine is recommended, and you just have to infiltrate. And the doses is you have to calculate as per the less than 3 ml per kg body weight. So infiltrate the area, and you go till the periosteum, also infiltrate the pleura. And you should wait, when you have just created an area fan shepherd, you should wait the local anesthesia to act upon before you are putting your scalpel. So this is a must, because it takes time to act, and this is, as studies have shown, that this is painful. If it has said that they may VAS score, may go into 9 to 10. The incision is given at the pre-marked site, and its incision should be targeted according to the size of the tube which you are using. Generally, it is 28, I said in the beginning. So at 1 centimeter of is sufficient enough. And you start dissecting. And here I tell you, there are 2 ways you can dissect it. In the video, we are demonstrating how we are dissecting with the help of a finger, what you call the finger thoracostomy. Here you should be targeting just above the lower border, superior border of the lower rib. Why it is so? Because the upper border, because the neurovascular bundles are at the lower edge of the upper bundle. So you have to protect that one. So you enter with the finger, that becomes safe, and you should not be in a haste. And alternatively, you can use your curved hemostats for this purpose. But finger tracheostomy, if you are well enough, then it is that. And as soon as you enter the pleural cavity, there will be a sudden give way. And what next you have to do with the finger, just 1 minute. With the finger, rotate all around yourself so that any adhesions and all these are broken up. So you don't have, and you get the idea what you have there inside the, and it is very safe. Either you put with then mount the tube with the in the artery forceps and insert it in it. And when you are inserted, as shown here, when you are inserting the tube, the direction should be the apex, that is the superior, posterior, superior. And when you are entering, it should be to and fro motion. Why it is said so? Because it helps you to know whether the tube is kinked or not, and whether you are progressing in it. If the tube is kinked, you will not be progressed. So this is quite handy when you are entering into the pleural cavity and placing the tube posteriorly. So when you have placed the tube posteriorly, the second step comes out to be secure the tube. And this is how we secure, take a good suture with the silk and with this tie it so that it becomes an air seal type of things. So there is no air leak coming from entering into the from the outside to the. And to ensure the effective seal, take a sponge and cut up into between, just like you make a pan, and go across the side, both sides of the tube, place it and effectively and place the sponges and seal it. And this sealing is to be effective so that no air enters. And this is how we are just dressing tubes, and must see the tubes as what you have shown in this, so that there is a play and maintains an effective seal. At the end, when you have done with it, it is connected to the water seal bottle, which is just below this, and you look for the presence of air column in there. Is there an air column in the air column swing is there, and this this completes the procedure. This completes the procedure, but this is not the complete. As we said, the continuum is to maintain, and you should quickly reevaluate. Is a must. Get an X-ray to just have a post-procedure placement of the tube, document the procedure, and must document in your file the ICD care. So summarize, it's a life-saving procedure when indicated, done during the primary survey. It's an hemostatic, and what you say is tube in time saves life. And whenever you are in doubt, put a tube in a safe method. Thank you. Thank you for the patient hearing.
Thank you. Thank you, Dr. Abhinav, for demonstrating so beautifully the most important step which can save patient's life. Very aptly demonstrated through the video, and I'm sure everybody must have benefited through this video. Thank you so much.
Thank you.
Pass on the mic. Please stop sharing the presentation. Thank you. I request Dr. Hemanga to introduce the next speaker.
Thank you, ma'am. Thank you, the organizing team, to giving us the opportunity to share this auspicious session. Now, I welcome Dr. Narendra Chaudhary. He is an assistant professor in Department of Surgery, JPNA Trauma Center. He will speak about perihepatic packing as a hemostatic maneuver. With this, I welcome Dr. Narendra Chaudhary, please.
Thank you, sir, and good afternoon all. I welcome you all on board. Without wasting much time, I start my presentation. So next couple of minutes, I will take you through the salient features and minor details of perihepatic packing, which is a component of damage control surgery. So keeping in mind the limited time, I will not touch damage control surgery as a component, and I will directly go through the perihepatic packing. And I will also touch the points of controversies. What are the points of controversies in perihepatic packing, and the finer details of the packing. So damage control surgery is initially coined terms by the Stone and colleagues regarding the truncated laparotomy. Later on, Rotondo and colleagues coined the term DCS as a three-phase techniques in 1993, and they reported that by abbreviating this laparotomy, the survival rate is drastically increased. They initially introduced is a three-phase, but later on Johnson and Schwab has refined it to the 4 phases. This original term was originated from the US Navy warship, and their primary motto is when the damage occurred to a very high extent to a ship, their primary purpose is to keep the ship floating. So the same analogy will be applied to the damaged person, where his life should be, the patient should be keep alive by doing minimum things, whatever we can do to ensure the normal physiology. Basic purpose is to avoid the lethal triad. I will not go in detail. So I will directly jump to the principles of trauma laparotomy. Trauma laparotomy are slightly different from the laparotomy for the peritonitis or elective procedures. Open communication with fellow anesthetist and nurse is essential. The motto is never work in isolation. Always communicate your concerns with the anesthetist team, what the anticipated injuries you are anticipating in the patient, nature of injuries you are anticipating, and inform the anesthetist when entering the abdomen, because sometimes the sudden decompression of the abdomen, release of the hemoperitoneum may lead to collapse of the hemodynamics of the patient. So anesthetist should be warranted in front that we are decompressing the abdomen so that he can do the needful in the timely manner. Sometimes anesthetist also requires giving the inotrope support to maintain the hemodynamics. In such a conditions, we can give the manual compression over the aorta, or we can do the cross clamping of the aorta, and by time for the anesthetist to infuse the blood so that they can maintain the hemodynamics of the patient. Our primary purpose of the damage control surgery is to maintain the hemodynamics, is to maintain the normal physiology as long as possible by intervening minimally to the patients. And the two aim is the main: control the bleed, control the contamination. So our top priority is the control of the hemorrhage and contamination control. Then the next controversial question is arise during the management of the hemorrhage of the patient. Should we remove the damaged organ or should we repair the damaged organ? Again, this totally depends on the hemodynamics of the patient and the nature of injury that particular organ sustained. Say for example, spleen is there, spleen is having grade 4, grade 5 injury, actively bleeding, and patient's hemodynamic are crashing, then we left with the option of removing spleen rather than repairing that, because repair may take longer time, and that longer time has indirect effect of stress on the patients, and the lethal triad can set in, or the patient is already in the lethal triads and we are worsening by prolonging the surgical procedure. So our basic purpose is to truncate the laparotomy, truncate the procedure bare minimum so that we can restore the hemodynamics by arresting the hemorrhage. As Dr. Subodh rightly said, control the bleed, arrest the bleed. Next is damage control. Packing doesn't stop bleeding, doesn't terminate the operations. Re-explore the patient, never send the patient without control of the hemorrhage in the primary operation, in the view or in the optimism that this bleeding will stop by itself during the resuscitation in the ICU. No, if you are having the soakage of the perihepatic packing or any other packing, please don't shift the patient out of the OT. Again, repack, again, explore. There may be the surgical bleed that can be tackled with the surgery. So always re-explore whenever you find that there is recurrent shocking of the packing. The abdomen should always be left open using temporary closure techniques, because there are chances that because of the massive transfusion, patient develop abdominal compartment syndrome. So, and sometimes we need to again go back or re-explore the patient. To minimize the time of the re-exploration, we always keep the abdomen open and close it with Bogota bag or some other commercially available devices. So come to the position and the incision. The patient should be in the supine position with both the arms at the right angle. He should be panted and draped from chin to the pubic symphysis or mid-thigh, because you never know, sometimes you have to convert the laparotomy into thoracotomy to control the bleed or to have the aortic cross clamping. So always pant the patient from chin to the mid-thighs. Always give a midline incision and expose the midline, and just try to enter the midline from about 2 to 3 centimeters above the umbilicus, where the largest sheath is there. And once you cut the sheath, there will be the preperitoneal fat popping out. Just swipe it again and divide the peritoneum, and just with your finger you can enter inside the peritoneal cavity. So midline incision will leads to sometimes very limited exposure that may not be sufficient to cleanly see or cleanly observe the liver surfaces. So sometimes you have to extend the midline incision by adding one more subcostal incision toward the right side, about 2 to 3 inches below the costal margin, to improve the visibility of the damaged organ, as well as to improve the liver packing. So without wasting time, I will come to the video of the liver packing. Please be with me. It's taking time to open the video. So I will go through the video along with the procedure. So now the patient is panted draped and the midline incision has already been given. Are you able to see my video?
Dr. Narendra, we cannot see your video. I think you can open it separately.
You'll have to share the screen again, I think.
Okay, I will again share the video, no problem. So we will give the midline incision with panting and draping from chin to the middle of the thigh.
Have you optimized the video sharing? On the left, when you share on the screen, on the left, there's a prompt to optimize the video settings.
Yes, sir.
Just check it and then start the video.
Nine, I think you'll have to run the video, and on that video screen, you'll have to share the screen. Then you'll be able to see the video.
Yeah. So midline incision has been given. Patient is panted draped from the chin to the middle of the thigh. We just entered above the umbilicus. And now the incision is extended. We are in the midline and you will see a gush of the blood in the trauma laparotomy that is coming out. 2 wide bore sections are there to control the bleed. We are just eviscerated the small bowel so that we can see. This is the technique of packing. We will two-fold the laparotomy sponge, 1 fold and then the 2nd fold. For effective packing, these should be saline soap. Now we will do the 4-quadrant packing. 1 pack over the liver, 1 pack over the spleen, 1 pack over the each of the paracolic gutter, and 2 packs in the pelvis. But sometimes, because depending on the habitus of the patient, the pack may be required more. Rather than 6, we may require 8 or 9 packs depending on the habitus. So this is the pelvic packing. Look, once the packing has been started, we are very helpful to have the arrest of the bleed. So we are compressing the bleed, and after that we will remove the pack 1 by 1 from each quadrant to see the bleed from the specific organ. So packing has been done. Meanwhile, as I demonstrated, the communication with the anesthetist is always required during the opening or decompression. We have just seen the hemodynamics of the patient and had a communication with the anesthetist whether they are all right or we require some operative maneuvers to control the hemodynamic collapse. Now is the time for the hepatic packing. So here the controversy is that whether we should divide the falciform ligament during the hepatic packing or not. So the literature has a conflicting evidences. The most convincing one is that if the laceration or liver damage is on the anterior surface or superior surface, we can go ahead with the intact falciform ligament because it will helpful in the proper tamponade formation over the liver. So here we are doing perihepatic packing with the falciform ligament intact. We placed 2 pegs on each side of the falciform ligament over the anterior superior surface of the liver to have the local tamponade effect over the damaged area in order to arrest the bleed. So this is pegged. Then 2 pegs will be over the inferior surface of the liver for a proper tamponade effect. Meanwhile, you have to also inspect the anterior and the inferior surface of the liver, whether there is any laceration or direct laceration that can be tackled with the direct pressure or not. Here you can see the inferior surface having the laceration. So we have just placed a hemostatic sponge over there and applied direct pressure so that it can be controlled in a direct way. Sometimes even after all these measures, the bleeding is not stopped. Even after doing the Pringles maneuver, the bleeding is continuously going on. And in that case, the suspected bleeding may be from the IVC or from the posterior surface of the liver. In view of the proper visualization of the posterior surface, we have to divide the falciform ligament. So in that case, we have to divide the falciform ligament. Here it is the falciform ligament. Bleeding is suspected from the posterior surface or higher superior surface of the liver. So 2 hemostats are applied over the falciform ligament. And falciform ligament is divided in between up to the coronary ligament, and coronary ligament is also taken down. Now you can see the exposure of the superior surface is also very better, and you can see the superior surface up to the very highest point. And we can put the superior surface, we can pack the superior surface inferiorly and posteriorly so that the tamponade effect can be placed. Now you can appreciate that much higher number of pegs are required after dividing the falciform ligament for producing the same tamponade effect. I'm cutting short. Now it's packing has been done. Complete hemostasis has been achieved. There is no soakage of the packing pads. Now the patient is ready for temporary laparoscopy and to be shifted to ICU for further resuscitation and to bring him back after 48 hours to 72 hours, depending on the hemodynamics of the patients. Now the time is to temporarily close the abdomen with the Bogota's bag or the indigenously prepared Euro bag cutting along with mesh, polypropylene mesh in the form of mesh laparoscopy. Here it is packed and now it's the mesh laparoscopy. So with this, I end my session here. Thank you for giving me the opportunity to share my video on this platform.
Thank you, Narendra. It was a nice presentation. Also a very good video considering the fact that this is an emergency situation. Now I invite Dr. Akshay Kumar to welcome the next speaker.
Good afternoon, everybody. It's my pleasure to invite the next speaker, Dr. Dinesh Bagaria, who's an assistant professor in the Division of Trauma Surgery and Critical Care at the JPNX Apex Trauma Center at AIIMS, New Delhi. And Dr. Dinesh is going to talk about preperitoneal pelvic packing, another very important aspect in hemostasis control in the emergency department in the trauma center. Thank you. So Dr. Dinesh, over to you.
Thank you, respected chairperson. I think the screen is visible and I'm audible clearly. Hello.
Yes.
Thank you.
Yes, you are on.
Respected chairpersons, dear delegates. So let me take you from one important aspect of damage control for the pelvic hemorrhage. Traumatic, this is preperitoneal pelvic packing, rather unconventional and I would say uncomfortable part for a general surgeon. Most of the time, general surgeons don't come to see and do this kind of thing. So as we know, hemorrhage is the second most common killer in injured patient. And if you talk about the preventable injuries, 36% of the hemorrhage death post blunt trauma are preventable. And one of the most significant contributor among them is the pelvic hemorrhage. The mortality is quite high, 40 to 60% among the patients who are presenting with the shock, and up to the 90%. In fact, if it is more than thoracic acute aortic dissection patients who are presenting in the extremis. If you see the footprints around the pelvic bone, we can see that these hard pelvic bone, they are surrounded by many tiny, small and medium-sized blood vessels. So you can assume what kind of force needed to crack this pelvic bone, and that force, what it is going to do these poor vessels. So the most common injury we came across are road traffic crashes and fall from significant height, with leading to pelvic fracture. And the pelvic fracture, as I said, the force needed is quite significant. Again, will lead to significant injuries to the intra-abdominal, intrathoracic, and even head injuries, along with in few unfortunate patients bleeding into the pelvis, which most of the time in 85% patients is the venous in nature, and in 15% patients it is arterial in nature. So we have to do the management accordingly. The initial management is irrespective of mechanism, irrespective of status. It is the physiology correction. So we need to follow the ATLS protocol. If patient is bleeding significantly, we need to start massive transfusion protocol. And presently the tranexamic acid is an indispensable part. Now, as far as the pelvic management per se is concerned, there are 3 lines of defenses we use. The first line of defense is mechanical stabilization using pelvic compression devices or C-clamp or external fixator. Now, what is to be used is depend upon the sources availability and individual institute preference. We used pelvic compression devices, and in fact, even the literature also, it is shown that there is no significant difference in the stability when we are using external fixator vis-a-vis pelvic compression devices. The second line of defense and the crux of this talk is pelvic packing. So this we do for 85% of the patients who are bleeding because of venous bleed. So the venous bleed is one which we take care of by using pelvic packing. Approach, there are 2 approaches. One is total extraperitoneal approach. Second is intraperitoneal approach. Which to use, we will discuss later. First, let's have a look on the video. So this is total extraperitoneal approach. We do a midline skin incision, suprapubic. Some people also use Fenton steel incision. You give the skin incision, divide the subcutaneous tissue, and now you are on the rectus muscle. You separate the rectus muscle in midline, and you are entering into the preperitoneal space of the radius. If there is pelvic injury, this space already has been created by the pelvic hematoma for you. Just suck out the blood and then insert 2 or 3 lap pad on either side of the bladder. Now, one thing which we need to take care of is that most of the time the bleeding is from the posterior part of the pelvic bone and sacrum, and we have to approach that space anteriorly. So we have to push our lap pad along the curvature of the pelvis bone so that they lie as posteriorly as possible on either side of the pelvis. We don't want our lap pad to lie just behind, anterior pelvis, behind the pubic crust, pubic symphysis, or pubic rami. So we have to push them posteriorly as much as possible along the curvature of the pelvic bone. So this is the total extraperitoneal approach. Now, if our patient is having fast positive and we don't know whether it is bleeding intraperitoneal also, we use intraperitoneal approach. And for that, first we have to do laparotomy. We have ruled out the intraperitoneal source. After that, we will separate this retroperitoneum from the pubic bone anteriorly. Again, if there is hematoma, this work has already been done. You just need to shear the pelvis off, this retroperitoneum of the pelvis, and then on either side of bladder, put 2 or 3 pack on either side of the bladder, depend upon the space. Again, push the bladder hard along the curvature of the pelvis so that the final lie of the packing is posteriorly as much as possible. Like you can see this imaging taken after packing, and you can see that mass of the pelvic packs are lying posteriorly along the curvature of the pelvic bones. So which to use, again, as I told you, if your patient is reasonably stable, you has ruled out other intra-abdominal injury, you can use total extraperitoneal approach. Otherwise, if there is expected source of bleeding intraperitoneal also, we use intraperitoneal approach. Most of our patients, we use intraperitoneal approach only. Post-packing management, patient need to be shifted in the ICU, continue with the resuscitation. Ideal time to revisit OT is 48 hours if your patient is getting stabilized. If patient is not getting stabilized, you have to revisit before that, remove that pack, and assess. If there is need, you have to repack again. Otherwise, at 48 hours, you have to remove the pack, because keeping the pack longer than that, there are high risk of infection. Now, the third line of defense is to manage in 15% of patients where there is arterial bleeding. So we have option of Riboa, we have option of angioembolization, and the other option which we generally use is the bilateral ligation of internal artery. Riboa is more or less a resuscitation measure rather than a definite measure. Internal intervention radiology again is a time-consuming process, resource-constraining process, which as of now in most of the center in India we don't have. So we propose the procedure which we can use is the bilateral ligation of internal iliac arteries. Again, the approach are two: intraperitoneal approach and extraperitoneal approach. For the sake of limiting time, I am not going to play the intraperitoneal approach video. So what we use extraperitoneal approach, sometimes I will show you that. Sorry. So once you have do the packing in the pelvis, again you just shear this retroperitoneum from the lateral most edge of your laparostomach, and you shear it medially. Once you shear it medially, you will come across these vessels, external iliac vessels and internal iliac vessels. So here you need to take care of ureter, identify the ureter and push it medially so that you don't injure it. And then you take hook of the internal iliac vessel and ligate it. We recently revisited our experience of last 5 to 6 years, and we recently presented it also at the ACS Clinical Congress. So my take-home message that we need to promote more PCCD application in the pre-hospital and inter-hospital transfer, because that is more important part. Pelvic hemorrhage management is the responsibility of trauma and general surgeon. We need to take care of it, and we have to learn ourselves, and we have to teach our students that how to take care of pelvic hemorrhage management, and whatsoever available options as per our resources, all are them complementary rather than competitive. Thank you very much for the organizers giving me opportunity and patiently listening to the delegates. Thank you, sir.
Thank you, Dr. Dinesh. That was a wonderful talk on preperitoneal pelvic packing. May I now ask Dr. Asuri Krishna to introduce the next speaker.
Thank you, Dr. Akshay. Now we come to a very important topic. Actually, this is a topic which is indispensable to the management of hemorrhage in trauma. And there is no better person than Dr. Shivananda Gaunakbati to talk about this. He's a professor in Department of Radiology at All India Institute of Medical Sciences. And he has done a lot of work in saving patients' life from hemorrhage using interventional radiology. Now I request Dr. Shivananda sir to kindly proceed with this talk. Thank you, sir.
Thank you, Krishna. At the outset, I would like to thank the organizing team. So, can you see my slides, Krishna?
Yes, it is.
We can.
Yes, sir, it is seen, sir. We can see it, sir. We can see.
Yes.
So I will be showing some video presentation of the cases where the IR plays an important role in the control of bleeding in trauma setting. So main role of IR in trauma, we broadly divide them into therapeutic and the prophylactic. So amongst the therapeutic, where the IR plays an important role is the embolization of a vascular injury in the form of active extravasation or a pseudoaneurysm or AV fistula. That is the main bulk of our angioembolization in our trauma center. The other therapeutic role is the control of bleeding in especially anatomically stringent sites like pelvic fractures and the maxillofacial injuries. Third one is the rebleeding following any kind of packing, where be it is a perihepatic, nasal, or a pelvic packing. So that constitute a major bulk of our IR treatment in the trauma setting. The other setting is the prophylactic, where there is a high grade liver or splenic injuries. So in order to enhance the success of the non-operative management, we do prophylactic embolization mainly in the liver and the splenic. Before I show the angioembolization videos, important is we go close to the site of a vascular injury in order to prevent the non-target embolization. If at all we are not able to reach the site of bleed, then we reduce the perfusion pressure by putting a embolizing agents like either gel foam or a coil, and time is a money. So if at all you want to ask the help of the IR person, do it upfront. Don't wait for a coagulopathy or a metabolic acidosis to set in. If once the coagulopathy sets in, whatever we do, it's not going to help. So the first case is the hepatic injury case. So this is a case where the patient has a high grade the hepatic injury associated with the vascular injury in the form of pseudoaneurysm. If you see here, there's the contrast blob, not well appreciated in the arterial phase, but I will show it in the venous phase. If you see here, there is a large intraparenchymal hematoma with associated with gross hemoperitoneum. And as I scroll it down, we can see here there is a contrast, well-defined contrast blob, suggestive of a pseudoaneurysm. So this is an ideal situation where the IR plays an important role. So we took this patient for angioembolization. This is a celiac axis angiogram. We are not able to appreciate the actual site of the pseudoaneurysm. So for that reason, we have to go super selectively into the hepatic artery. So if you see here, there's a contrast blob. Again, we went more selectively, very close to the site of by looking at the angiogram as a road map. So we reached the site. Okay, this is the site of the pseudoaneurysm. Reach the site, and next step is the very simple. We just put a coil in the feeding artery. So this is after the putting a coil. This is the check angiogram that shows the complete obliteration of the pseudoaneurysm and sparing the posterior branch of the right hepatic artery and as well as the left hepatic artery. So this is the posterior division which is spared, and this is the left hepatic artery. Okay, that is the case. Next case is the role of embolization is the active extravasation. So I'm going to show this case. If you see here, there is an active extravasation of the contrast. That suggests there is ongoing bleed. Okay, and there is in addition, there are extensive lacerations involving almost all the segments of the right lobe. And this is the area of contrast extravasation, and there is a gross hemoperitoneum. So in this case, if you see here, the selective angiogram of the right hepatic artery confirms the finding of CT. There is active extravasation. And we reach the site of the active extravasation, cannulating selectively the feeding artery. So next is we put a coil here into the feeding artery, and the bleeding has stopped. And the final angiogram shows no filling of this or visualization of the active extravasation, sparing the entire adjacent liver parenchyma. So these are the two situations where pseudoaneurysm and the active extravasation that constitute the major bulk. The other role, as I said, after the packing, if you see here, this patient was taken up for damage control surgery. Hepatic packing has been done. And this patient continued to bleed even after the packing. So this patient was taken up for, although I don't have a video, I'm just showing a spot images. If you see here, there is an active extravasation as well as a pseudoaneurysm from the posterior sectoral artery, so which was embolized using a coil. So this is another situation. Coming to the anatomically stringent areas like maxillofacial injuries, majority of these patients are managed by nasal packing and putting up Foley's into the posterior nasopharynx and the nasal area. But even after nasal packing, this patient continue to bleed. So in such cases, IR help is taken. So this is case where there is a maxillary artery is showing active extravasation of the contrast. If you see here, into the maxillary sinus. So just we have to put a gel foam or a coil reaching the site. If there are multiple sites of a bleed, then we just put the gel foam. If it is a single vessel, we can go reach the site and put a coil. So in this case, we put a coil because this was a bleeding from the internal maxillary artery. This is another case. If you see here, the significant maxillofacial injury, nasal packing has been done with a Foley's. And if you see here, in this case, there is a bleeding from the anterior ethmoidal branches as well as the mentromaxillary branches and the ascending pharyngeal branches. Hello, disconnected. Hello,
Yes.
Yes, sir.
Yes, sir, you are audible.
and visible.
Yes.
Can you see the video?
Video नहीं आ रहा.
No.
It's not visible.
Video बंद हो गया है sir.
Wait.
Yes.
Okay.
Yeah, it is
Yes,
visible
we
now.
can. Yeah, visible.
So this is the bleeding from the multiple branches. Okay. So in such cases, what we do, we just put a gel foam into the external carotid artery branches, mainly in the intramaxillary and ascending pharyngeal, and the hemostasis is achieved. This case, if you see here, there is a active extravasation contrast from the intramaxillary artery into the maxillary sinus. So again, we put a coil followed by gel foam, and the hemostasis was achieved. The third case, the third setup is the pelvic fractures. Although our surgeon do pelvic packing and intra-iliac, there are certain situations where the IR help can be taken if the patient is hemodynamically stable, and we pick up a finding of any active extravasation or a pseudoaneurysm on the CT. So this was a case. Hello.
Yes, sir, audible and visible.
Audible and visible.
I'm getting some problem in the PowerPoint. Stop. Okay. Just hold on. This PowerPoint is stuck actually now. Okay. Can you see the video slide?
Yes.
So
Yes.
this was a case of a pelvic fracture involving the quadrilateral plate. If you see here, there is a bony spike of the fracture fragment. And this case was actively bleeding. Surgeon, the orthopedic surgeon, he was planning for fixation and he started bleeding. Okay. So this patient was immediately shifted. If you see here, there is an active pseudoaneurysm from the obturator artery of the internal iliac division. So this was selectively cannulated and embolized using a coil. So this is a post-embolization. The pseudoaneurysm is blocked and sparing the rest of the branches. The other kind of intervention, this is a pseudoaneurysm from the inferior gluteal artery. So again, this was showing a large pseudoaneurysm arising from the inferior gluteal artery. So we reached selectively that feeding artery and put a coil, and the pseudoaneurysm is blocked. Okay, coming to the peripheral vascular injury, there are the management of IR is mainly plays a role in the hemorrhagic form of peripheral vascular injury. Ischemic, we don't have any role to play. And in this case, there was a AV fistula between the superficial femoral artery and the superficial femoral vein. So in order to, the main intention is to save the superficial femoral artery and block the rent. So these are the angiograms. So that confirms the finding of AV fistula, if you see here. Okay, there's a large AV fistula communication, and we reached distal to the rent of the AV communication. Next is to close the rent by putting a stent graft. So this is a stent graft. So the stent graft has been placed across the AV fistula site, and the artery was saved and the flow was restored and blocking the AV communication. Suppose the bleeding vessel or is from the muscular branches. In this case, this patient also had an aneurysm from the profunda femoris artery, if you see here. So in these cases, we can sacrifice this vessel by putting a coil. So we sacrifice this vessel by putting a coil. So these are the main cases. I will just finish like last video by showing the splenic injury. This is a grade 4 splenic injury with a contrast blob, if you see here, suggestive of an active extraction contrast with a large perisplenic hematoma. So unlike the liver injury where we go selectively reach the site of bleed, in splenic injury, what we do is just we put a coil in the proximal splenic artery just before the splenic hilum. We don't reach the site of active bleed. We just want to reduce the perfusion pressure. So here we put a coil in the proximal splenic artery before the splenic hilum and reduce the perfusion pressure. Rest body will take care of it. So that is the difference between the liver injury management and the splenic injury management. So liver, we go selectively reach the site, whereas splenic, we just put a coil in the proximal segment to reduce the perfusion pressure. Thank you. Hello. Hello.
Thank you very much, sir, for excellent talk. Thank you very much, sir. They were very excellent videos, and I'd like to thank you for all the help that you have been providing to the Division of Trauma Center, along with Dr. Atin. He also needs a mention. You form a very excellent team. Now I'd like to invite Dr. Rajshekhar to invite the next speaker.
Hi, good afternoon. The next speaker is Dr. Krishna Kumar Govindarajan. Dr. Krishna Kumar is an additional professor of pediatric surgery at Chibmar, Pondicherry. And it's indeed our pleasure and privilege to have him here. Over to Dr. Krishna Kumar for his presentation. Dr. Krishna Kumar.
Thank you, sir. Hope I'm audible.
Yes, you are audible.
Yes, you are audible.
Yes, sir. Just wait for the screen sharing to.
Yes, sir. We can see you now. Yes, sir. We can see. We cannot see the screen yet.
Yeah, I think I'm going to make it full screen now. Yeah, I hope the screen is visible now.
Yes, sir.
Yes, it's visible.
Yeah.
It's visible and you are audible.
Greetings from Chibmar, Pondicherry. I think nice to join the Trauma 2020 virtual conference. And thanks for the organizing team, especially from Samir Gupta. As regards the topic of pediatric abdominal injury, what is different? What might mean is it may be dealing with what is different from the adult, as well as with regard to the pediatric injury itself, what is current as of now and what is different over the past few years. So this topic also will be touching upon some general aspects of pediatric injury, which is a little unavoidable. So I kindly request you to bear with me for that. Thank you. So this is the overview of the topic. Now, about 30% of visits of the children in the emergency department consists of trauma-related causes. If we take the blunt abdominal injury, that is the third most common cause of deaths in pediatric trauma. Especially if it is an unrecognized fatal injury, pediatric abdominal trauma is the most common cause. Now, as regards the serious abdominal injuries have non-specific or subtle external signs is very relevant as far as pediatric abdominal trauma is concerned. This slide shows the kind of mortality, and if it is an isolated liver or spleen injury, the mortality which is less than about 20% can markedly rise to more than 50% as the number of injuries gets added and when the vessels also get.
I'm sorry to interrupt you, Dr. Krishna Kumar. Your voice is not clear and clearly audible. Please.
Hello, is the voice?
Yes, now it is clear. Now it is clear.
Yeah. Oh,
now it is clear. Yeah. Yeah.
I'm sorry, I'll just keep on. Okay, with regard to the challenges as far as the child is concerned, it is not just the pediatric trauma school which is different in a child. The child as such is a misfit as far as the emergency room is concerned. So the main challenge being the communication issues. So which need to be looked into when a child comes into the emergency room. Now, as far as the mode of injury is concerned, self-fall, if not one of the common causes, it is as one of the very important causes as far as pediatric abdominal trauma is concerned. Now, we had done a study earlier which was published, even that showed that about 27% of the abdominal traumas were related to self-fall as far as children are concerned. So the same thing is echoed in the Western literature as well. I just showed the one, this was published in 2016. This is the data from the American College of Surgery. Now, if we look at a child who has had a trauma, the kinetic energy which gets transmitted to a small abdominal surface results in multiple injuries because the space for dissipation is quite less. Now, also, the ribs which are not ossified are quite flexible and they do not offer a very good protection. The diaphragm is also quite flat, which pushes down all the organs into the abdomen. And moreover, in a child, the abdomen is like a tightly packed showcase and exposing the liver, which is relatively large compared to the pediatric abdomen, it's much injury prone. Also, if you look at the other things, for example, the muscle, fat, and fascia are quite thin and not offer resistance for trauma and predispose the child to abdominal trauma.
Sir, sorry to interrupt. Your voice is still not clear.
Hello? Hello, is the voice better, sir?
Yeah, it is clear now, but in between it's not clear.
Okay, okay. Hello, I think the voice is clear now.
Yes, sir.
Please continue.
Yeah. Yeah, the physiology is also another different thing in a child as far as the child is concerned. The vitals are quite different. The heart rate, BPS, everything differs with the age. Now, very often when a child comes to the trauma because of swallowing affair or aerophagia, there is a lot of gastric dilatation which needs to be kept in mind because over a period of time, what might happen is that this might lead to risk of aspiration and can, because of the sequence of events as it keeps accumulating, and cause hypoventilation as well as hypovolemia. This needs to be kept in mind when we evaluate a child with abdominal trauma. Also, the presentation of shock in a child is very much different. It can be like a hypoventilation, skin muffling, and things like metabolic instability. Now, the thing to keep in mind that in a child, the physiological reserve is very good, so that almost 30 to 40% of blood loss is very much tolerated, and at some point of time, the child suddenly decompensates, maybe a point of no return. So again, this needs to be kept in mind when we are evaluating a child in the ER room for abdominal trauma. Also, associated conditions, for example, enlarged kidney because of pyelonephrosis, backbone bleeding disorders, all these things need to be kept in mind during the evaluation, which can color the picture differently. Shock index, which is adjusted for the pediatric age, is another thing which can be quite useful because they can predict the need for intervention. And what we know from the literature is that almost more than 90% of the time it is accurate, especially for grade 3 and brain injury. And these are the various signs which we need to look for when we are examining a child, which can indicate that there is an abdominal injury. Looking at this slide, it is easy to understand the various skin changes which are obvious, especially the one on the top, which we refer to as androgen skin pattern because of the androgen which hits the child. So that is very much linked to a pancreatic trauma or a injury. As far as imaging is concerned, what we understand is that we need to take the imaging a little gentler as far as the child is concerned. As far as radiation exposure is concerned, what is important is that
Hello, can you stop sharing? Yeah.
Yeah.
So thank you very much, Dr. Krishna Kumar Govindarajan, and I thank all the panelists and the chairperson, the speakers. I'll quickly just take up, there were two questions in the chat box. One, although it was answered by the respective speakers, but for the interest of the postgraduates, I'll just read the questions. So one question is that how long we can keep the nasal pack, the posterior nasal pack? The answer is very simple. Initially for 24 hours, see the status of the patient. If he becomes hemodynamically stable and there is no more bleeding, you can remove the packing, or you can keep, if there is ongoing bleeding, patient not stable, you can keep for 48 hours, but definitely after 48 hours, you must remove the packs and then check. If there is a continuous bleeding, then you repack. So this is the answer for the nasal packing. When do you apply external fixator along with the periperitoneal packing? The answer is very simple. If patient is a non-responder, you just pack, do the intra-annulus ligation, and apply a pelvic compression, circumferential compression device like pelvic binder. But if after the packing patient becomes stable, Then and if you have the facilities, if you know how to apply external fixator, or if you have a orthopedic colleague who can help you in the theater, then you can ask him to apply a fixator. Only in cases where there is a open root fracture or unstable pelvis, not in patients with the lateral compression. So there are broadly 3 types of pelvic fractures. One is the vertical shear, one is a anterior posterior compression where there is a pubic diastasis, and the third one is a lateral compression. So external fixator is not required in lateral compression injuries. I hope I have answered both the queries. If there is any pressing question to any speaker by the chairpersons or anybody.
Dr. Subodh,
Yeah, please.
am I allowed to pass a comment and also a question?
Absolutely. It's a pleasure. Please.
2 years back when I would do trauma, actually, when we would pack the liver, which is actually a life-saving procedure, and during unpacking, we would realize that the pack get stuck to the liver surface. And we had started putting a thin layer of non-sticking material before packing.
Yeah.
And that
you can cut the,
That helped a lot. I don't know whether you people are practicing something.
So it's a very, very, very valid point. So if there are 2 ways to do this. You can keep sheet, and usually it's a Eurobag sheet. You cut the Eurobag and keep over the laceration and then pack, or before removal. If you have not done that, you must put a lot of saline and soak all the packs before you take them out. That is the dictum. And warm saline you must put and soak the packs thoroughly and before you take it out. This is a very, very important point you raised. My only word of caution to all the postgraduate: do not pack inside the laceration. It should always be a perihepatic packing. So this is a very good comment, Dr. Anita. Any other pressing comment or question from any chairperson or comment? If none, then I take this pleasure to thank all the chairpersons and the speakers of this session. And I close the session and I hand over the mic to Dr. Sushma Sagar to introduce the next session.
Thank you for inviting.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you, Subodh. Thank you, Dr. Narendra.
We will have a break of around a minute, and we'll come back in the hall A. Can we, Shubhang, can you just stop the streaming?
Yes, sir. Sure, sure.
नहीं ब्रेक नहीं, वो तब तक हम पीछे प्रिपेयर कर लेंगे ना. अब वो लाइव स्ट्रीमिंग बंद कर रहा है, आई थिंक.
Done, sir.
Hello. Hello. I think we all are here. If the live streaming is I can still see the live streaming. It has not been stopped.
हेलो सर, शुभांग दिस साइड.
या
सर वो यहाँ पे शो हो रहा है, हमारे सेशंस में टेलीकास्ट नहीं हो रहा है, वहाँ पे स्लाइड चल रही है. जूम पे सर लाइव शो ही होगा यहाँ पे, मतलब ऐसे ही, उससे हमारे टेलीकास्ट में कोई दिक्कत नहीं है सर.
Okay, Mohit, then we'll go back to the count So they will say 10, 9, 8, 4, send. Then Dr. Sushma will introduce you and Harshit, and then you start the quiz. Okay?
सर सबने इंट्रोडक्शन में क्विज इसमें स्लाइड रखी हुई है अपनी हर्षित की
किसके
इसी में मैंने सेकंड स्लाइड रखी हुई है मुझे नहीं पता
इंट्रोडक्शन की
ठीक है हाँ सर
Then Dr. Sushma will introduce both of you and then you take over.
ठीक है सर तो सर स्क्रीन आ रहा है और सब आवाज आ रही है ना सर
We can start.
You can stop sharing this initially.
Should I stop this, sir? ठीक है सर
Shubhang, you can start the live count. 10, 9. और वो करेगा वो दबाएगा ना तो वो तो तुम कह रहे हो चली रही है बंद ही नहीं हुई
When do we start, Shubhang?
So we can go live after the countdown. If you want to give the countdown, we shall go live.
And sir, we have to wait for 5 minutes or so for other participants to join on Slido.
So good afternoon, everyone. And now we come to the most interesting session of this 3-day extravaganza, and that is the quiz for the participants. So all the participants and the delegates who have been just listening till now can now show their talent, can now show that how far they can think of answering these quizzes. And this trauma mindbender quiz will be conducted by our two very smart personalities, Dr. Mohit Joshi, who is a faculty in the Department of Surgery at All India Institute of Medical Sciences, and Dr. Harshit Agrawal, who has been a trainee MCH from Division of Trauma Surgery and Critical Care and currently faculty at Raebareli AIIMS. So I'm handing over this very live and very, I would say that all of you would enjoy this, to Dr. Mohit Joshi to run the quiz. Dr. Mohit.
Thank you, ma'am. And we start with trauma quiz. I think we wait for some time so that all the participants, they can log in on the Slido app. You had that information a day before, and we have been sending push notifications also that once you go in Hall A, you will have a caption of joining the quiz, and then you can join in the Slido app directly with a link. So we wait for a couple of minutes here so that more number of participants, they can join the quiz, and then we'll start. And I assure you that this will be an interesting part of this workshop.
Shubham, can you update that how many people?
$21 people right now.
Dr. Mohit, can you just explain the procedure to join to all the participants, please?
So for joining in this trauma quiz, you have to go in Hall A. In Hall A, we have the image of the hall completely, and on the left-hand side, you have an option of joining the quiz. Once you push in that option, then the quiz will be open for you. You have to log in initially by putting in your name and email ID on the Slido app. Now, this Slido app is meant for running this quiz. So we'll have the questions on the screen and you can record your responses on the Slido app. So okay, now we have 29 users, 30 users, the number of users, they are increasing. So we'll wait just for 2 more minutes and then we'll start the quiz. You can spread this information by the word of mouth. So you can ask your colleagues, your friends to join the quiz, and it's going to be an interesting one. So we have taken questions from like all the spectrum of trauma management. It's not only of the core text, it's like about the celebrities, about the other things which are all related to trauma, some interesting stuff about trauma, some abbreviations, and like we have the whole spectrum of it. So can I again request your people to tell your friends, your colleagues to join the trauma quiz. Right. So because time is of essence, and as we all being trauma people, the time is crucial. It is critical. So we start the trauma quiz now. So Madam has already introduced, we'll be 2 quiz masters. I'm Mohit Joshi, and with me is my friend, Dr. Harshit Agrawal. Now, before beginning, we should have some rules of the game, and we have set some ground rules. And these are that it's not a very serious activity. So we have added fun to this learning activity. So we all would be learning with fun. All the registered delegates, they can participate. They are residents, they are faculty, they all can participate. But then the prizes are only for the residents who have registered. So all of us can participate, but we'll award only the residents. We have 2 prizes, and they are very interesting cash prizes. The first one will get 5,000 rupees in cash, and the runner-up will get 3,000 rupees in cash. So at the end of the quiz, we'll take some time to prepare the results, and hopefully by the end of the day, we'll declare the results too. So there'll be 30 questions in this format. You have 30 seconds to respond to each question. I'll pose the question and the time will start as soon as the options they will appear on your screens. Now, as we have discussed earlier, you'll have one screen of the hall in front of you, and by the side of it, there will be a Slido app which will be open on your home screens. Now you have only 30 seconds to record your response. And as soon as this 30 seconds is over, the question will be blocked. So you cannot record your response beyond that time. In case we have a tie, the participant who has taken less time to respond will be declared the winner. So we have a facility in which you can see the time also, that how much time you have taken to record your responses. So let's begin, and let's begin by paying homage to the COVID warriors. So this is just first question, just to orient you about the quiz. So this will not be counted for scoring. It's just a warm-up thing and our way of paying tribute to the COVID warriors through this quiz. So here goes the question. In the Lancet, in the recent edition of it, the recent issue is only the last week, and there is a report of a tribute to some doctors who have died from COVID-19. Now your question is that among this list, name the trauma surgeon who has been mentioned in this report. And your options are this. Is it Sara Bravo Lopez, Jitendra Nath Pandey, R. Ronald Warrior, or Richard Kisser? So your time is over now. And then we have had responses and the votings are closed for this question. So this is the answer. So the trauma surgeon who died because of COVID is J. Ronald Warrior. He died on April 8th in 2020 in New York at the age of 59 years. So this is how we'll run the quiz. So you'll have questions, you'll have options, you'll have 30 seconds to respond to questions. Beyond that, you cannot record your responses, and then we'll move to the next question. After each question, definitely we'll be discussing the answer and we'll be discussing in little detail about it so that we keep on the interest. So are you ready for the quiz? I now hand over this to my friend, Dr. Harshit Agrawal, to carry this forward. Dr. Harshit?
Thank you, sir. Good afternoon, everyone. I welcome you to the quiz. And without wasting much time, I will start the quiz. So the first section, we have divided it into a few sections. The first section is of trauma and celebrities. So the first question is, this famous politician died due to gunshot injury. Which of the following procedures was performed on him? So this is the famous politician, the BJP politician, Mr. Pramod Mahajan. He died due to gunshot injury. And what procedure was performed on it? And the options are aortic repair, B, perihepatic packing, C, splenectomy, D, cardiac repair. And your time starts now. Okay, so we have received the responses. The correct answer is perihepatic packing. Mr. Pramod Mahajan was a noted BJP politician. He was shot by his younger brother at point blank range and he suffered gunshot wound to the lower chest and abdomen. His liver, pancreas, duodenum and IVC all were injured, and he had to underwent IVC repair and perihepatic packing. But unfortunately, he died 13 days later on 3rd May 2006. So the answer was B, perihepatic packing. Moving on to the next question. This cricketer died during a match when the ball hit him. He was a noted batsman, but a ball hit him and he died. What injury did he sustain, which led to his death? So the options are A, extradural hemorrhage, B, vascular injury, C, subdural hemorrhage, or D, myocardial contusion. And your time starts now. So the correct answer is C, vascular injury. He was Philip Hughes, Australian cricketer. He was an opening batsman. He suffered vertebral artery dissection when the ball hit him on the neck, which led to extensive subarachnoid hemorrhage. In this picture, we can see that the ball directly hit him beneath his helmet onto his neck, which led to vertebral artery dissection, which eventually led to changes in the manufacturing of the helmets. So initially, the helmets did not had a covering beneath the ear or in the mastoid region, but now the newer helmets have come up with additional covering so as to support or so as to protect this area and for protecting any further insult to the vertebral arteries. Coming on to the next question. The third question is, we all know her. She's a famous actress and Bharatanatyam dancer. However, in 1981, she suffered an injury to her leg, which eventually led to the amputation. So what was the cause of her injury? And your options are A, fall from height, B, firearm injury, C, road traffic injury, or was it D, stab injury? And your time starts now. So the time is up and the answer is C, road traffic injury. There's a very inspiring story behind her. In 1981, she was just 17 years old when she suffered injury to her leg due to road traffic injury. She was in a bus and the bus had a collision. She had to undergo amputation following the gangrene of her leg. But she became a renowned dancer even after this incident using a prosthetic limb, or we call it as Jaipur foot. So she does have a very inspiring story behind her. So coming on to the next section. The next section is on injury prevention. The first question, or the question number 4, is which car company first used a 3-point seat belt? So the options are A, Mercedes, B, BMW, C, Volvo, or was it D, Ford? And the time starts now. Remember, it's 3-point seat belt. And so the answer is C, Volvo. In 1959, it first used the 3-point seat belt. Although Nash and Ford were using the seat belt system before only, but they used 2-point seat belt system. And Volvo was the first one who introduced 3-point belt system. And I'm very happy to see that about 70% of the contestants answered it correctly. So coming on to the next question. The person who invented motorcycle helmet was A. And the options are, he was a sports person, was he a doctor, was he a laborer, or was he a pilot? And the options and the time starts now. And the answer is B, doctor. So he was Dr. Eric Gardner, a British physician who first created basic canvas and shellac helmets in 1914. But interestingly, it was not until 1941 that the importance of helmets were realized. It was a neurosurgeon, Sir Hugh William Bell Keynes, who was an Australian who lived in England, who first published his report in British Medical Journal. And in 1941, British Army made helmets mandatory for dispatch riders. So It was although invented in 1941, but it only came into the practice in 1941. So coming on to the next question. Which actor is the brand ambassador for government's road safety campaign? The government of India has appointed one of these actors as the brand ambassador for its road safety campaign. The options are A. Ranbir Kapoor, B. Akshay Kumar, C. Sunil Shetty, or is it D. Salman Khan? And the answer is B. Akshay Kumar in 2018 was appointed as the brand ambassador. And we must all have seen these ads, and in which he says that ye road kisi ke baat ki nahi hai. And this was a very famous advertisement. So coming on to the next question. This is question number 7. Land Rover is one of the safest SUVs and is a subsidiary of India's Tata Motors since 2008. The car is so safe that even our Prime Minister Shri Narendra Modi opted for an armored variant of this sports model. Now you have to tell us that who is the brand ambassador for this SUV, and the options are A. Tom Cruise, B. Chris Hemsworth, C. Robert Downey Jr., the Iron Man, or is it D. Bear Grylls? And the correct answer is D. Bear Grylls. He is a British adventurer known for his famous TV series and is the global ambassador for Land Rover. So coming on to the next question, question number 9. This section, we include trauma and movies. So a few questions will be placed in which the trauma concept has been utilized in the movies. So the question is, we all have seen this famous movie. We all are aware of this movie. But the question is, following traumatic head injury in this movie, the lead actor suffered from. And the options are A. Retrograde amnesia, B. Antegrade amnesia, C. Dyslexia, or is it D. Transient global amnesia? And your time starts now. And the answer is B. Antegrade amnesia. So we all know that Ghazni, it was made in 2008. It was a remake of the Tamil movie, again named Ghazni. It was released in 2005, which was again the remake of a Hollywood movie, Memento. Now this blockbuster movie was the highest grossing movie of the year. The mark on the head of the Amir Khan was due to traumatic injury with iron rod, which led to his condition of short-term memory loss, that is, which eventually led to antegrade amnesia. So coming on to the next question, the 9th question is, name the year in which this movie was released. And the movie is Trauma. So we all have studied trauma. Now we need to understand that there was a movie also. And the options are A. 2012, B. 2015, C. 2009, or is it D. 2017? And your time starts now. The correct answer is D, 2017. The movie was based on the story of 4 friends who were partying in a house in the middle of nowhere. They were brutally attacked by a man and his son, forcing the remaining women to take vengeance upon them. So this movie was released in 2017 and the correct answer is D. Coming on to the next question. Which of the following Bollywood movies based on the theme of organ donation? So the options are A, Anurag, B, Apna Asman, C, Kyunki, or is it D, Yaad Rakhegi Duniya? And your time starts now. The correct answer is A, Anurag. This film was released in 1972. Now, the movie is based on a story of a blind sculptor played by Maushmi Chatterjee, who stays in an ashram and befriends a small boy, Satyajit, who is suffering from cancer. Now, as a dying wish, Satyajit donates his eye to her, thus granting her eyesight for the first time in her whole life. So this movie was released in 1972, and way back, the concept of eye donation is still utilized in the movies. So coming on to the next question, I would like to hand over it to Mohit Joshi sir for the next session on the mystery of zones.
Thank you, Harshit. Now we'll move on to the mystery of zones. So we'll tell you some zones and you'll have to identify with regards to trauma, which zone these injuries they belong to. And the question is, this is question number 11. And the question is that in this thing, what you see that is that which zone this belongs to, like zone 1, zone 2, or zone 3 is blue, violet, green, green, violet, blue, green, or violet, green, blue. Your time starts now. The option which you see here may be wrong, may be right. You have to apply your own brain to see which zone is correctly mentioned. In the order of 1, 2, 3, is it blue, violet, green? Is it green, violet, blue, green, or violet, green, blue? So the correct answer is the green, violet, blue. So the zone which is green is zone 1, the violet is zone 2, and the blue one is zone 3. The next question on the zones is that in retroperitoneum also we have zones, and we have 3 colored areas here. You have to identify from this figure that which zone belongs to which color. So when we say zone 1, 2, 3 respectively, is it blue, violet, green? Is it green, violet, blue? Is it green, blue, violet? Or is it violet, blue, green? And your time starts now. So the correct answer is answer C. The zone 1 is green, zone 2 is blue, and zone 3 is violet. We have one more question on zones, and this is regarding the sacral fractures. Again, we have to answer which zone belongs to which color. So we have zone 1, 2, 3 in sacral fractures. The answer is like blue, red, green respectively for zone 1, 2, 3. Is it green, red, blue? Is it green, blue, red, or red, green, blue? And your time starts now. So the correct answer here is blue, red, green. The blue is zone 1, the red is zone 2, and the green is red zone 3. Coming to the next question, now we have some general questions as well. And in this section, the first question is, this is a very beautiful process, a very useful one, which is known as SACH food. Now you have to answer that what this SACH stands for. Is it solid ankle comfortable heel? Is it South Asian cushion heel? Is it solid ankle cushion heel? Or D, is it South American comfortable heel? And your time starts now. So the time is up, and the correct answer is solid ankle cushion heel, the option C. The next question is, the commonest ingredient of artificial blood is, so we know that there's something called as artificial blood. What is the component of artificial blood? Is it perfluorocarbons? Is it sheep hemoglobin? Is it pertechnate and perchlorate solution? Or is it globulin, which has been derived from monkeys? And your time starts now. So the time is up, and the correct answer is option A, perfluorocarbons. The perfluorocarbons, they are derived from synthetically from carbon and fluorine. They can dissolve about 50 times more oxygen than blood plasma. They are relatively inexpensive. They are biologically inert. And because of these qualities of perfluorocarbons, they are the main component of artificial blood. Still, the search for an ideal blood is on, but this is one of the commonest ingredient which has been used in research for making an artificial blood. The next question is, we all have heard this term, guillotine, in term of guillotine amputation. Now you have to tell that from where this term has been derived. Has it been derived from the name of a German scientist? Has it been derived from the name of the first amputee? Has it been derived from the apparatus which is used for killing? And is it from the Greek word meaning sharp? Your time starts now.
Sir? Sir? Yeah, I think, sir, there's some mismatch coming on the original screen. Sir?
Time is up.
Sir, hello, sir.
Yes, Arjun.
Sir, I think there is some mismatch coming on the screens of the delegates. In the app, the options are coming, supposedly, the options are coming in advance than the question.
Okay. So we have to ask whether we can fix that.
Yeah, we will. We need to ask to the technical team just to correct that.
So we just hold in for a while. Maybe there's some technical glitch, and I'll be back with you on this question. Just give me a few minutes. If there's some technical glitch,
No, Harshit, there is a lag time.
There is a lag time.
Harshit, there is a lag time between the your backend apparatus and what is coming on the screen. So
Yes,
it's
ma'am.
okay.
We have stopped the quiz as of now. We are talking to the technical team to clear this glitch.
Nice. We had that information from our technical team that the issue has been resolved. There was some mismatch between the options and the questions which are coming, but then this issue has been resolved and we move forward on this quiz. So this is the correct option here is option C, and the name guillotine has been derived by the name of a killing machine. So it was a tall frame with a heavy blade, which was used for execution by beheading during the French Revolution. Now, as we have rectified the technical glitch we are having in quiz, so we'll move on to the next question. And this question, question number 17, is based on a CT image. Now you have to see the CT image and you have to identify the surgical procedure which was performed. So this is your image. Look it carefully, and these are your options on your screen. Is it balloon tamponade for hepatic venous injury? Is it debridement for liver injury? Is it perihepatic packing? Is it angioembolization for massive liver injury? This is the image. These are the options. Your time starts now. The time is up, and the correct answer is option C, perihepatic packing. Here, if you see in this image, you can see this pack which is over the liver, and here you can see the liver injury. So we all know that's a damage control procedure in hemodynamically unstable patients with high-grade liver injury. So the correct option is C, perihepatic packing. Here is the next question. This is question number 18, and then you have to tell that while performing trauma laparotomy, hematoma in the lesser omentum is an indirect indicator of which injury. Again, I'm repeating that you are doing a trauma laparotomy and you find that there is a hematoma in the lesser omentum. What does this signify? Does it signify that there is an underlying splenic injury, or there is a pancreatic injury along with? Does it signify gallbladder injury, or does it signify a diaphragmatic injury? Your time starts now. So the correct answer is option B, pancreatic injury. This has been published recently from AIIMS New Delhi only, has been named as Mishra's sign by one of the professors here. And then we have found that if you find a hematoma in the lesser omentum while doing laparotomy for blunt abdominal trauma, and you find that there is hematoma in the lesser sac, it is an indirect or surrogate marker of underlying pancreatic injury. Moving on to the next question. This is regarding the CRASH 1 trial. And the question is that why this trial was performed? What was this looking at? So was it done to evaluate the role of steroids in traumatic brain injury? Or was it because to assess the role of tranexamic acid in hemorrhagic shock? Was it evaluating tranexamic acid in traumatic brain injury? Or was it meant to understand the role of steroids in hemorrhagic shock? And your time starts now. So the time is up, and the correct option is option A. CRASH 1 trial was performed in 2004 to look at the effect of intravenous corticosteroids on death of the person who had suffered traumatic brain injury. This was a randomized placebo-controlled trial. It was very famous, and based on this trial, the authors, they recommended that corticosteroids shouldn't be used to treat head injury, whatever the severity is. Although still the practice is kind of a mixed one, but this clearly said that there is no role of steroids in head injury, be whatever the severity is. So this is the correct option, option A, CRASH 1 trial. And of course, we know about CRASH 2 trial as well. The next question, question number 20, is on something called as modified shock index. Now you have to answer that how this modified shock index is calculated, what is the formula for that? And your options are, is it heart rate divided by systolic blood pressure? Is it respiratory rate divided by systolic blood pressure? Is it the ratio of heart rate and mean blood pressure? Or is it the ratio of systolic blood pressure with the mean blood pressure? So these are the options, and your time starts now. So the time is up, and the correct response is option C. This is the ratio of heart rate by mean blood pressure. So initially, shock index was devised for a bedside assessment of severity of shock, and thereby as a marker of mortality. And this is a ratio of heart rate and systolic blood pressure. But it was found that we are not calculating the diastolic blood pressure here, but it is as important. So a new shock index was created. It was devised, known as modified shock index. And here you see that this is not the ratio of heart rate and systolic blood pressure. It also includes diastolic blood pressure in the form of mean blood pressure. So the modified shock index is calculated as a ratio of heart rate to mean blood pressure and has been found as a better predictor of mortality in emergency patients. If the modified shock index is more than 1.3 or it is less than 0.7, it's a strong predictor of mortality. So with these 20 questions, we have completed 2/3 of our quiz. Hope you all are enjoying as much as I am enjoying. So for the rest of the questions, the last 10 questions, I again request and I welcome Dr. Harshit to take this quiz forward. Dr. Harshit.
Thank you, sir. Thank you, sir.
Okay, so
to continue with the quiz, coming on to the next question, question number 21. Asia classification is used for the grading of, and their options are A, splenic injury, B, spinal cord injury, C, pancreatic injury, or D, closed head injury. And your time starts now. And the answer is B, for assessment of spinal cord injury severity. So it is American Spinal Injury Association classification, and it depends on the motor and the sensory aspects of the spinal cord injury, and it helps to ascertain the neurological classification of spinal cord injury. So coming on to the next question, we very commonly use this scale, GCS. Now the question is, who actually devised GCS? Now your options are A, Norman Sweets, B, Richard Anderson, C, Graham Teasdale, or D, D.K. Chabra. And your time starts now. And the answer is C, Graham Teasdale. Now, this is a very simple score, and how it has modified the neurosurgical practice we all know. It was in 1974 when Graham Teasdale and Brian Jennett devised this scale, and it was devised actually in the beginning for nursing practice, but seeing the simplicity of the scale, this scale has been used worldwide and has modified the neurosurgical practice. Coming on to the next question, question number 23. The person who conceptualized ATLS was, and your options are A, he was an orthopedic surgeon, B, he was an emergency physician, was he a nurse, or was he a trauma surgeon? And your time starts now. And I think as a trauma fraternity, we all know the answer is A, orthopedic surgeon. In 1976, he was Dr. James K. Steiner. He was piloting a light aircraft which crashed nearby Nebraska. His wife, Charlene, was killed instantly, and 3 of his 4 children sustained critical injuries. But seeing the pathetic state of the trauma management, he devised this ATLS course, which we practice now in almost all the good level trauma centers. Coming on to the next question, question number 24. Name this maneuver. We have been using this maneuver in trauma laparotomies very extensively. This is the incision line which is being shown, and this is how the visceral organs have been rotated. And your options are A, Mattox maneuver, B, Kettlebrush maneuver, C, cockerization, or is it D, extended cockerization? And your time starts now. Well, the answer is A, Mattox maneuver. There's a very interesting story going behind this maneuver. So it is said that Dr. Mattox was being assisted by a second-year urology resident. They needed to mobilize the viscera and obtain access and control deep retroperitoneal bleeding, which was suspected to be coming from aorta or IVC. At the table itself, they developed this maneuver and they could save this patient together. This was published in 1980s, and fortunately, we also have a talk of this legendary trauma surgeon, and I request you all to kindly join at 6 p.m. today on 5th December for hearing his words of wisdom. Coming on to the next question. Which of the following is not a procedure for controlling hemorrhage in maxillofacial injuries? Remember, which of the following is not a procedure? So the options are A, anterior nasal packing, B, internal carotid artery ligation, C, posterior nasal packing, or D, external carotid artery ligation. And your time starts now. The answer is B, internal carotid artery ligation. We know that 3 of the maneuvers, the anterior nasal packing and the posterior nasal packing, helps in temporary control of the bleeding. Apart from that, as a damage control procedure, we can also go ahead and ligate the external carotid artery, because the majority of the bleeding occurs from the maxillary artery, which is a branch of external carotid artery. But we cannot ligate the bilateral internal carotid arteries as they supply the brain. We can also see in these pictures how to do an anterior and a posterior nasal packing. The Foley's tip is cut and it is inserted inside the nasal cavity, and the balloon is inflated, which provides tamponade to the posterior nasal cavity. The anterior nasal cavity is then stuffed with the gauze packs so as to control the anterior bleeding from the anterior nasal cavity. Coming on to the next question. Identify this man who envisaged an artificial blood vessel and in fact invented Dacron graft. So you will be shown a figure. He's a very noted surgeon who actually in fact invented Dacron graft. And your options are A. Setinsky, B. DeBakey, C. Cocker, or D. Harvey. And your time starts now. The answer is B. He is Michael E. DeBakey. Now, there's a very, very interesting story behind this. So this was published in the obituary in the Lancet that when he decided to experiment with material for arterial grafts, he went to a departmental store in Houston, Texas, to get some nylon. So unfortunately, the clerk informed me that they were out of nylon, but had a new fabric called Dacron. So DeBakey actually bought a yard of Dacron. A colleague had been able to buy nylon, but it deteriorated in the body when he tried to use it. And fortunately, DeBakey used Dacron, which did not deteriorate in the body. So after Dacron proved long-lasting in vascular grafts, DeBakey won the 1963 Lasker Award for the work. I wonder, had he got the nylon from the shop at that time, maybe we could never have seen Dacron at that time. So coming on to the next question. What is the sign and in which clinical condition is it found? You can see a sign. It is on the color Doppler. You have to name the sign and you have to tell the clinical condition in which it is found. And your options are, it is A, yin-yang sign in pseudoaneurysm. Is it with B, yin-yang sign in AV fistula? Or is it a Mickey Mouse sign in AV fistula or a Mickey Mouse sign in pseudoaneurysm? So the correct answer is A. It is yin-yang sign and it is found in pseudoaneurysm. This sign is seen in color Dopplers. It is based on a Chinese symbol called Tajitu. Now, in which the two halves signifies the wholeness and both halves chase each other to seek balance. So in the color Doppler study, we usually see in pseudoaneurysm when the blood goes inside and the blood comes out of this, when we apply the color Doppler, we see the yin-yang sign. Coming on to the next question, question number 28. When is World Trauma Day celebrated? And your options are A, 23rd January, B, 21st of July, C, 17th October, or D, 21st December. The correct answer is 17th October. Each year it is celebrated, and recently it has passed just in the 2 months back. Coming on to the next question, question number 29. Now name the explosive that caused blast in Beirut in 2020. It was a very infamous explosion which occurred few days back. So the question is, you need to answer the explosive that caused the blast. And your options are A, trinitrotoluene, TNT, B, pentaerythritol tetranitrate, PETN, or was it C, RDX, or D, ammonium nitrate? And your time starts now. The answer is B, ammonium nitrate. On 4th August 2020, large amount of ammonium nitrate stored at a port in Beirut exploded. It caused 204 deaths, more than 6,500 injuries, and left about 3 lakh people homeless. It was a very huge explosion, and we all must have seen the videos of this explosion. Coming on to the next question. This is the last question, and I think all trauma surgeons must be very much aware of it. It has been talked in the talks before also. Which of the following concept is derived from US Navy? Is it A, damage control surgery, B, massive transfusion protocols, C, do no further harm, or is it D, triage? And your time starts now. And I think all of us know the answer. It's A, damage control surgery. It relies on the fact that you have to do the bare minimum just to keep this ship afloat. And the concept of United States Navy is the capacity of the ship is to absorb damage and to maintain the mission integrity needs to be maintained. So with this, we come to the conclusion of this quiz. I hope you all enjoyed it. Even I enjoyed even preparing it and in making it. I would like to hand over to Dr. Mohit Joshi sir for further announcements.
Thank you, Harshad. So with this, we complete the quiz today. Hope you all have enjoyed. We are preparing the results shortly, and then we will be able to show the results maybe by the end of the day today. Be there to join us for the talk of Dr. Kenneth Mattox, and maybe after the talk, we will tell you the results. Thank you so much for joining in the quiz, for your participation. I wish you a very happy day ahead. Thank you.
Chairperson and panelists are waiting to be included in. Parameshwar.
Good afternoon, sir. Dr. Parameshwar here.
Good afternoon, all.
Good afternoon, sir. Shashank here.
Good afternoon, Dr. Shashank.
Just wanted to know who logged in as faculty 2020 as attendee.
So without delay,
Naren, there's somebody in the attendee waiting, logged in as faculty 2020. I can't identify him.
I did. हाँ अमित मैंने किया था अभी.
Oh.
Hi Amit, I had logged in a bit before तो वो quiz चल रहा था. I think maybe that must be the one.
Okay, Dr. Abhinav, you can start. Narendra, you can start the session. Yeah.
So without delaying much, now I welcome our chairpersons for the next session. The next session comprises of two sessions. One is extremity trauma and another one is ventilator for surgeons. So I welcome Dr. Kamran. Sir is a professor in Department of Orthopedics at AIIMS, New Delhi. Welcome, sir.
Thanks, Narendra. Thank you very much for this invitation.
Our next chairperson is Dr. Shashank Chauhan. Sir is assistant professor in Department of Plastic and PRS and Burn Surgery at AIIMS, New Delhi. Welcome, Dr. Shashank. Now our next chairperson is Dr. Babita Gupta. Madam is a professor in anesthesiology at AIIMS, New Delhi. Welcome, ma'am. And next chairperson is Dr. Nikki Sabharwal. Madam is a professor at Anesthesia, Safdarjung Hospital and Vardhan Medical Mahavir College, New Delhi. Welcome, ma'am, to the session. I now request...
I request all the chairpersons and the speakers to switch on their cameras, please.
I request Kamran sir to please introduce our first speaker, Dr. Parmeshwar G. Reddy, for his talk on planning extremity amputations. Sir.
Yeah, actually, sorry, did you, just give me a second, please. Just give me a second. Just give me a second. One second, yeah. So let me request Dr. Parmeshwar Reddy, who is assistant professor at Base Hospital and ACMS, to give his talk, the first talk on amputations. Yeah, Dr. Parmeshwar, you can start, please.
Good afternoon, sir. Can you see my screen there?
Yeah, it's visible very much.
Okay, good afternoon. Thanks for inviting me to the virtual conference. I'll be talking on the planning extremity amputations. I'm a prosthetic surgeon working at Base Hospital, Delhi Can, at the ALC, Artificial Limb Subcenter there. To start with, this is Dr. Ernest M. Burgess, the long posterior flap surgery we do in below knee amputations. He is the one who promoted it. He is the US orthopedic surgeon. His landmark paper in 1969 says that we need to create a dynamic and a sensory motor end organ, and we should stop all the atrophic wasted bony below knee amputations, which creates a problem in the rehabilitation of the patient. Most of these amputees were post World War II. They had a problem in making prostheses for them. That's when he promoted this. And amputation must be considered as a reconstructive surgery. That's the Seattle foot he's holding on his table, like our Jaipur foot. He also one of the pioneer who started the immediate post-operative prosthesis, the CAD/CAM system and all. Every talk on amputation, every patient where we think of amputating, we should first think about a limb salvage. The recent advances in the medical field in evaluation of a trauma patient or resuscitating, and in the wound care will help us in salvaging most of the trauma patients. We can use a lot of free flap and soft tissue transfers to convert a above knee amputation to a below knee amputations, and help us in salvaging some of the limbs, the interventional vascular procedures, and especially in bone tumors, the endo processes, which the latest ones which are available have salvage the limb. Limb salvage is the concept which evolved from the bone tumor surgeries. And the replantation of severed limbs also has to be considered before amputating. However, we should remember that a failed limb salvage or a salvaged useless limb can be devastating. So we should not delay the amputation sometimes, because as you see in this image, some reconstructive brilliant surgeon has salvaged the heel of this patient, but he will request you for an amputation when he cannot bear weight on his heel. Planning extremity amputations is a multidisciplinary. We should involve all the competent surgeons in our hospitals, the trauma surgeons, vascular surgeons, orthopedic surgeons, reconstructive surgeons. We should also involve the physicians, the endocrinologists, psychiatrists, to optimize the patient before and after the amputation. The rehab team, after the stump is created, is a patient-centric, holistic, multi-pronged, and a goal-oriented process. In our hospital, we all the people I mentioned here sit together with the patient and then plan the goals for the amputee patient. The prosthetic surgeon will be the center. He's the captain of the team, and the prosthetist is the heart of the rehabilitation process. So we should have along with the after a patient is amputated, we should have a good rehab team to put our patient back on road. Indications are amputation, all the 4 Ds. This most of us know. Is amputation is a surgical failure? Definitely not a failure. It is a reconstructive surgery. A well-planned and executed amputation can remove a painful or a dysfunctional limb and allow a rehabilitation of the patient. Coming to the goals of amputation surgery, this is a Kargil war veteran, Major D.P. Singh. He's a blade runner. He's a marathoner. The goals of amputation surgery are not only to remove the infected necrotic tissue, provide pain relief to the patient, or a successful wound healing. We also have to look after the stump maturation, the prosthetic fitting, ambulation training, and social integration of the amputee. Coming to the siting of amputation. Before World War II, most of the amputations were above knee because there was a problem about the healing of the stumps. In World War II, most of the amputations were below knee because they noticed that the stumps would heal in the below knee also. In 1960s and 70s, when Dr. Burgess and his colleagues promoted the long posterior flap, which we most commonly do as a Burgess technique, the below knee is the most common amputation performed now. So what are the major problem when you do amputation is whether the stump will heal or not. So what are the predictors of stump healing? Most commonly, most of those who do amputations will know the bleeding on the table, the bleeding from the margins on the table, the healthy muscle. That is what will predict the healing of the stump. Some of the other parameters can be a segmental pressures using Doppler and TCPO2, transcutaneous pulse oximetry. The TCPO2 levels of around 20 to 40 is enough for a stump to heal. TCPO2 is measured by a probe put on the skin. It measures the oxygen tension which is emanating from the skin of the stump. Now, about how much bone should be salvaged. As you can see in this slide, the energy expenditure increases when we do a proximal amputation. The unilateral SIMS is 15% more than what a normal guy would spend. And the unilateral transtibial, the standard amputation which we perform in most of the cases, is 10 to 40%. However, if it is a bilateral amputee, you can see the energy expenditure is 123%. And if you go transfemoral, then it is 60 and 300%. So we should try and salvage the length we should go and do as distal as possible. Coming to the individual amputations, below knee amputations, I want to promote the knee joint preservation here. Preservation of knee joint is very important. The standard 12 centimeter below knee stump is what we promote for an ideal stump. But with the advanced prosthetics available and the advanced the suspension sockets and the silicone liner with a shuttle lock available, we can salvage the knee with 3 centimeter below the tibial tubercle also. That is 7.5 to 5 centimeters from the joint line. Saving the knee is economical for the patient, and it is a less energy consuming also. Though it is a short lever arm, but still it is much better than going above knee. Save the joint whenever it is possible. Coming to the above knee amputation, the most important thing here is the flexors of the hip, flexors of the thigh, the iliopsoas is intact. Even when you do a above knee amputation, the abductors are intact, but the adductors are gone. The adductor magnus will be cut if you don't do a myodesis. So the most important step in a above knee amputation is doing a adductor magnus myodesis. Myodesis is done by drilling 4 holes in the distal femur, the anterior and 3 more laterally. And we have to suture the adductor magnus. We have to keep the adductor magnus little longer than the at the amputation level, so that we can suture it to the bone under appropriate tension, so that the adductor magnus works and keeps the limb in adducted position. Otherwise, the patient after amputation will have a circumduction gait with the prosthesis. Knee disarticulation, which went into disrepute after it was done in 1960s, is restarted again in modified Maget's technique. You can see in the image, it produces a bulbous stump. That was the problem with this, and the knee joints were also an issue. So it went into disrepute. Now with the advanced prosthetics again, what is recommended is a modified Maget's technique. In the modified Maget's technique, what they do is we had to shave the condyles using an osteotome or a oscillating saw, and shave the patella from the quadriceps tendon, and the quadriceps tendon is sutured either to the hamstrings or to the posterior cruciate ligament. And the knee disarticulation is a end weight bearing, so it helps the patient in having a end weight bearing prosthesis. And one of the advantages of a knee disarticulation is the patient can perform his sexual activity because it's a end weight bearing also. Coming to the foot amputation, the minor amputations in the foot and in the midfoot and hindfoot amputation, this transmetatarsal is one of the best amputations because we have the dorsiflexors intact in a transmetatarsal amputation. However, in the Lisfranc and Chopard, your dorsiflexors are, if they are not reinserted, then we have a lot of problems. In a transmetatarsal amputation, we should keep the basis of the metatarsals intact, because that is where our tibialis anterior peroneus or peroneae are inserted. Some of the bad amputations, the Lisfranc amputation, in which the procedures are not done, here the dorsiflexors are lost. So the surgeon who plans to do a Lisfranc amputation should lengthen the tendo Achilles, should plan a tibialis anterior insertion to either the navicular and the talus. Otherwise, if the dorsiflexion is lost, there is a equinus deformity and the patient will be walking on the scar, and it leads to ulceration and it will be a bad amputation. So your peroneal and tibialis anterior has to be inserted, and even you can do a ankle arthrodesis in these patients. That will also help the patients. The Chopart amputation, again, the problems is there is no tendo Achilles lengthening here. There is no arthrodesis of the ankle. So the axis of the movement will be a problem. The tibia will be jetting out of the scar, and the patient will have a problem in rehabilitation. So here ankle arthrodesis should have been done, or he should have gone for a proximal amputation. Symes, one of the best foot amputation, though ankle is lost, it's a end weight bearing prosthesis with a simple prosthesis, which is shown here is an elephant boot. The patient can walk short distances without even a prosthesis here. It's one of the best for amputations for Indian settings, especially the rural ones. Coming to the foot amputations, if you are amputating a great toe for a gangrene, then try and salvage the proximal centimeter of the bone where the plantar fascia and the flexor hallucis is inserted. It helps in preventing the ulcer formation and further amputations. If you cannot salvage, then do a ray amputations. Ray resections are more durable than the transmetatarsal amputation, but there are certain rules in doing a ray amputation. The rule is hallux plus 1 lesser toe, or a lesser toe plus 2. If they had to be done, then plan for a transmetatarsal amputation. As shown in this slide here, again the reconstructive brilliance. Somebody has just salvaged a great toe here. The patient is going to break it, and we'll have to do a revision surgery or a proximal amputation in this first slide, which I've shown here, where we're planning to give him a A4, and it's a difficult rehabilitation for this patient. Again, here only one digit is salvage. It's better to do a transmetatarsal. Again, this third photo, 3 ray amputations have been performed. It is not a viable option. We have to do transmetatarsal at a later time. Coming to the post-operative dressings, the amputation stump should be splinted with a well-padded rigid dressings to prevent joint contractions, which we've been doing in all the below-knee amputation. However, the latest things are the removable rigid dressings. This is one of my patients in the right side, where I applied a removable rigid dressings. It costs around 80,000 bucks. I am reusing it for my patient. It's just easy to apply and remove. The problem with the rigid dressing is difficult to inspect your wound, because it is difficult to remove your rigid dressing and reapply it. However, there are removable rigid dressings are also available, in which we can, the advantages of these dressings are decreased edema, less pain, and early prosthetic ambulation. I found a lot of advantages with the removable rigid dressings. Most of my patients' stumps mature within a month. This is the patient here. I used my early post-operative prosthesis. He had a mangled extremity. He's a paramedic. So we had to do above knee amputation in this patient. This prosthesis is wearing is a early post-operative prosthesis. The immediate post-operative prosthesis which Dr. Burgess promoted was applied on the table itself. It's a little difficult for the patients to bear weight on the third day and further ambulate on it. I found early post-operative prosthesis midway, where this patient, 13th day, I made him stand on this prosthesis. By 1 month, I sent him home with a temporary prosthesis. When he came back after 4 weeks, what he told me was that I didn't feel like I was amputated, because otherwise, if I sent him home with a stump, call him back after 3 months after a stump maturation, his problems would have been, all his relatives would have been crying on his stump, and the patient would have gone into some amount of depression, and I had to counsel him and then retrain him on all that. So it was a big advantage when I gave him a EPOP. I conclude by saying you're not disabled by the disabilities. You are able by the abilities you have. So that's where I conclude my talks.
Yeah, thanks very much. Actually, it was a very nice talk. I would say a very exhaustive, comprehensive coverage of all the levels of amputation. But you're not mentioned about forearm, anything in the upper limb. You don't get any patients about upper limbs.
So most of the upper limb ones goes to the plastic
Reddy?
surgeons. I just joined the prosthetic surgery 1 year back. So
Okay.
So that's the problem. So most of them go to a plastic surgeon or a hand
Okay.
surgeon.
Mhm.
So I'm not an expert in the upper limb. Please excuse me. I didn't even put some slides about that. I wanted to cover, the key points in the lower limb amputations because most of the PGs were attending it.
Yeah. But I think in the lower limb amputations, you have brought out the more significant and important points, the ones we should keep in mind. Good lecture. Thank you.
Thank you, sir.
If there are any questions, can we open the questions, please, now?
I think let's first
I didn't get
finish the
anything on
talk
the
and
chat.
then take the questions.
I haven't got any questions on the chat box yet, but I think maybe if anything comes up, we'll let you know. Thank you, Dr. Reddy. Nice lecture.
Thank you, sir. Thank you for having me.
Actually, Dr. Kamran sir also told what I was trying to.
I think Narendra, the next speaker is Dr. Captain Satish. Shashank, are you there?
Yes, sir, I'm here.
Shashank.
Yes, sir, I'm here. Can you hear me?
Yes, sir. Dr. Shashank, you are clear and loud. Please go ahead.
Okay. Because I was also expecting some prosthesis for the upper limb because I'm a plastic surgeon, and now because the things are going towards hand rehabilitation and then hand transplant has been done in the country. So I was hoping that we may be able to see some upper limb prosthesis, but a very good presentation regarding the lower limb prosthesis.
Thank you, sir. Group Captain Satish is expert in this prosthetic surgery. He's the senior most in the armed forces. He'll be showing you a lot of, we are using iLimbs and all in Artificial Limb Center, Pune.
Sorry to interrupt. We are already losing the time. So I request Dr. Shashank to invite next speaker.
So our next speaker is Group Captain Dr. C.N. Satish. He's the senior advisor of surgery and specializes in prosthetic surgery. And he's also associated with Artificial Limb Center, Pune, 5 Air Force Hospital and Base Hospital, Lucknow. Dr. Satish, please.
Yeah, thank you, Shashank, and I thank all the organizers to invite me. I hope I am audible, please. Can someone confirm?
Yes, you're audible.
Yes, thanks a lot, ma'am. And a very good afternoon to all ladies and gentlemen. And greetings from Base Hospital, Lucknow, where I am heading the Artificial Limb Subcenter there. In this talk, I will clarify Dr. Shashank's doubts on the upper limb prosthesis also. How does this? Yeah. So I have been asked to speak on prosthetic considerations for amputees. And what Parmeshwar just before me had mentioned, a very unique thing that I'll point out is amputation is actually a reconstruction. Amputation is not end of the treatment for the patient, and the treatment continues, and the prosthetics is what comes next. And so I will start off saying that prosthetics is actually an art. What a very famous American athlete, actress, and model said that an amputation is actually creating a blank canvas where we can put in anything we want and we can do anything that we want. Amy Mullins is a bilateral lower limb amputee. She is a proud owner of 12 pairs of legs. You can see there are 5 of them here, and she's got much more after this. And what's really unique is that she can choose whatever height she wants to be. Imagine this, I mean, she can be 5'6" someday, or if she wants to attend a party, she decides she's going to be 6'2". I mean, how lucky they are. I'll give a very brief overview of the amputee rehabilitation, some general principles in prosthetics, cover lower limb and upper limb prosthetics briefly, some special conditions, and if time permits, something about the future of prosthetics. We in the Indian Army have been managing amputations, I would say, since more than 2,000 to 3,000 years. Just taking the credit from the Ashwini brothers, actually, who were the first combat prosthetists who had fitted Queen Vishpla with an iron leg when she lost her leg in the battle. But coming to more recent times, we have been dealing with prosthetics since early last century. In 1920s and 30s, our military patients used to be going through the civil to get their prosthetics done. And these are some of the bills dating from 1920s, 30s, and 40s. And you can see this, there was a shaped leg used to cost 115 rupees in 1940. And that translates to nearly a lakh now, I think. So anyhow, the armed forces has been at the forefront in organized prosthetic care with the Artificial Limb Center Pune established in 1944 and 5 sub-centers established all over the country. And the way we do it is that the primary care, that is immediately after trauma or the amputation, is given at the respective military hospital, followed by the follow-up care at the 5 artificial limb sub-centers distributed at Chandigarh, Delhi, Lucknow, Guwahati, and Bangalore. And the tertiary care is given by Artificial Limb Center Pune, which is the largest limb center in armed forces. So though my talk is on prosthetics, so I put in the slide just to say that prosthetics is not just the treatment for amputations. It forms just one small part of the treatment. What starts off with is proper surgery, then physical therapy, psychological support, and other things is more important than only prosthetics. So what is a prosthesis? I mean, if someone asks a PG student for definition, so this is a simple definition that one can give: an artificial appliance that replaces or compensates an anatomical loss. So basically, any part of body which is lost, we are replacing or compensating for it in either a functional and or a cosmetic manner. Some of you may be familiar with Edward Scissorhands and the very famous Swiss Army hook, a totally functional prosthetic. Or you can have something that is very cosmetic but has no function. Or we can have something that has got both form as well as function, that is looks as well as functions, like a prosthesis. So what goes into making a prosthetic? To just break it down, the parts of a prosthesis, we said that we are replacing a lost body part. So if the foot is amputated, we replace the foot with the prosthetic foot. The leg is amputated, so we put in a shank. And in case the knee joint is gone, say in a through knee or an above knee, then we put in a knee joint. And all this is held on to the body with what called a socket. So the way we wear shoes, the amputee wears a socket, and socket is the custom made part in any prosthetics, and that is made with measurements of the patient. And then comes the suspension. Suspension is something that holds on the prosthesis to the body. So here we have shown one type of suspension. There are several types of suspension available, which is used for the patient to tie the prosthesis to his body so that it doesn't feel like a dead weight. This entire thing can be covered cosmetically to give it look like a normal leg, so that cosmesis can come in. And sometimes we use special components such as a rotation adapter, etc., for specific needs of the patient. So these prosthetic components are classified according to various activity levels. So there are 5 different activity levels. You don't have to read the entire thing. Level 0 is a patient who will not benefit from a prosthesis. So basically, at best, he may have a cosmetic prosthesis. Suppose there's a patient who cannot get out of a wheelchair. He cannot use a prosthesis. So he may benefit only with a cosmetic prosthesis. A level 1 is a household ambulator. He is restricted within the house. He is not going to get out of the house. Level 2 gets out of the house, but for limited activity. Level 3 is a normal person, a community ambulator, and he goes to work, he goes shopping, etc. Level 4 is a highly active amputee, like a child or an adult or an athlete. So based on these levels of activity, there are a variety of components available in the market, ranging from a very simple knee joint, which has got a lock, or a knee joint with a brake, or going up to knee joints which have got hydraulics and pneumatics, and Now you get even microprocessor controlled knee joints. So these joints have been classified according to various activity levels, and I'll come to the prescription in a short bit. Similarly, we have various types of prosthetic feet. Parmeshwar had shown one Seattle foot, which is a very cosmetic and a very nice looking foot, which is a solid ankle cushion heel foot. And so that could be used for a level 0 or 1 or 2 activity. And as the patient becomes more active, we can go for things like carbon fiber feet, which are actually energy storing feet. The point to note here is that the taller the foot, the more the energy it will be able to store. And this will come subsequently when we talk of the prosthetic fitment. In level 4 feet, ALC Pune was the pioneer in fitting the first blade in India. Some of you might be familiar with Major DP Singh, who is a marathoner. And this person on the right is Subedara Anandan, who is an Asian gold medalist in 200 meters. Sometimes we use rotation adapters, which can allow rotation. I'm sorry, the video is not working. Some last things. And we also have a teletorsion adapter. This is somewhat like a bike's shock absorber. And so whenever there is an impact, this picture is of a patient whom we wanted to do para jumps, and it did not happen, but we had fitted these shock absorbers so that when he landed on the ground after a para jump, the shock absorbers would have taken the shock absorbed in that. So based on these components, we have basically two types of designs. One is exoskeletal and other is called an endoskeletal design. The endoskeletal prosthesis, you will note here, the socket is mated to the foot through a tube. So this is a skeleton that is contained within the prosthesis once it is covered by the cosmesis, hence called as endoskeletal. So the point to note is that fitting this tube will require some amount of space. And so this amount of space has to be made available to the prosthetist so that he can fit these kind of feet to it. If this amount of space is not available, it will not be possible to fit any of these high activity feet. The exoskeletal prosthesis here, instead of that tube, we have a piece of wood or we have plastic. So these can be fitted even to long stumps. In case there's a very long stump where an endoskeletal cannot be fitted, then we can fit an exoprosthesis. But the issue is that none of the feet in the high activity types, such as the carbon fiber feet, can be fitted to exo design. So exo is not suitable for young patients who they want to do actually higher activity. So how do we decide on how to give a prosthetic prescription? When a patient comes, obviously he wants the best, and in his mind, the most expensive is considered the best. But it is not so. We do a thorough assessment. What is his patient's activity level before the amputation? Post amputation, what will he get back into, such as his vocation and recreation? What are the stump condition, the length, shape, etc.? Whether there is any joint contracture, if there is any joint stability in the proximal joint, how dexterous the patient's hands are, because he has to be able to wear the suspension, take it off, and wear it safely. Is the patient cognitively good enough to understand, and is he motivated enough to get into this rehab? What is his medical condition? What are the tech resources, and that is in terms of manpower and equipment available in the limb center, and affordability. In our case, the limbs are sponsored by the government, so affordability is not a major issue, but we still use those 4 or 5 activity levels to classify and make sure that the patient gets what he wants and not necessarily gets what he deserves, not necessarily what he wants. Okay, coming to the level specific prosthetics, when we talk of 4-foot amputation, that is amputations of the toes and say transmetatarsal, we cannot have any of these carbon fiber prosthetics, etc. fitted, because that becomes very bulky. So we may go in for only toe filler, or we can go in for something made of silicone and a cosmetic prosthetics here. Coming a little more proximal, when it comes to hindfoot amputations, these are not very good for prosthetic rehab, because when we do this hindfoot amputation and the level of the heel is still maintained, that is the level of the sole is still maintained, and the prosthetic has to be fitted below that. So that takes up another 1 inch or 2 inches. And the patient then has to wear a shoe that is another 1 inch. So this becomes a limb length discrepancy vis-a-vis the opposite side, the normal side. So on the normal side, the patient will need a shoe raise to compensate for this. So that's why this kind of things are not good. And also this tends to go into equinus very often. So this is another reason why I personally avoid doing hindfoot amputations. A cheaper option is surgical boot, but that also has the same problem that the normal side will have to be raised to compensate for it. Some very enthusiastic surgeons have sent us such cases wherein they preserved the part of the calcaneum, did a Pirogov. Pirogov, etc. was all right for the bygone eras when prosthetics were not good, but nowadays the prosthetics are much better. So I personally, in such a case where the ankle amputation has to be done, instead of saving the calcaneum, it is better to remove the calcaneum and do a Symes. Symes is technically more difficult, but you can see that good carbon fiber prosthetics are available for Symes, and good function is possible with Symes. And the Symes gives a very good advantage that the patient can ambulate within the house with having a weight bearing, without having to use a prosthesis within the house. Transtibial is one of the best amputations that one can do if one can manage that. Because a transtibial amputee has a near normal function. It is, I mean, that 10% energy expenditure that they have to do excess, that is very easily compensated, especially when you see the transtibial patients running. And I mean, I have patients who are even running full marathons, transtibial patients. Ideally, we recommend the stump length to be around 10% of patient side. So this allows us to put in this adapter here. So this adapter, if it can be fitted, then it is possible for us to fit any type of high activity prosthetics. Shortest, as Reddy has mentioned, distal to the insertion of patellar tendon. In the knee disarticulation prosthetics, the issue comes up is if the knee is disarticulated at the exact joint level, the prosthetics will jut out before that, in front of that. So what happens is, I mean, traveling in nowadays in the airlines, you can see even normal we people have so much of difficulty with those closely spaced seats. So traveling in a bus and airlines, etc., becomes very difficult for the amputees. And also, because this is jutting out so much, the lower portion will be smaller. That is, the shank portion will become smaller. In these cases, we prefer that a transcondylar be done so that this discrepancy is taken care of.
Dr. Satish, can I just interrupt and just ask you to conclude it in a few more slides, please?
Okay, then I'll just rush through it. Then in the transfemoral, again, what I'll say is we have various options from locked knee going on to pneumatic knees and hydraulic knees. This one is the transfemoral with a hydraulic knee, and you can see a very good function is possible. Okay, Shashank, for you, upper limb, there's always severe functional issues with upper limb. And the aim should be, I mean, the take-home message for the upper limb prosthetics is restore function, not form. I mean, don't look at prosthetic options to get him to do things. Sometimes you have very simple intervention, such as a clip here. This is a bilateral amputee, and a clip with a spoon made him independent within 5 minutes at a cost of 20 rupees. So in prosthetics, you have body-powered prosthesis available. You have you have myoelectric prosthetics available. We are using both of these. And this is a video of a myoelectric chap who's drinking water. But most important, irrespective of any prosthetics, is the training. Okay, so we give them a proper charted training and a graded training so that they become independent and productive members of the society. Okay, I'll rush through this also. This is the post amputation mobility aid. So early prosthetic rehab should be done within 3 to 5 days of the surgery. One should fit the early prosthesis. Cosmetic rehab is possible where functional is not possible. A very important thing for surgeons is that don't hesitate to do a skin graft. Even 100% skin grafted transtibial stump can be fitted with a good prosthesis and achieve a good outcome. So don't cut down on that stump length because of that. The shortest can be fitted with a shuttle lock. Sometimes innovative designs we have to do for congenital deficiencies. Most of the recreational sports can be taken part with normal prosthetics. But when it comes to competitive sports, then specialized prosthetics such as these blades are needed. And we are routinely doing them. And a word about non-prosthetic rehab. Sometimes prosthetics is not really essential for doing their function. So a person can achieve good function even without having a prosthetics. For in case this person, we did a Krukenberg and he had a good function that he was able to even feed himself normally. What's coming in the future? 3D printing, bionics, shape memory alloys, osseointegration. Okay, I have completed. Thank you.
Thank you, Dr. Satish, sir. It was a very good, it was a great presentation, and I hope and I'm sure all of the listeners would have got a great message from the presentation. But yes, the last part, the last slide was the best. That training is very important in rehabilitation of all these patients with prosthesis.
Yeah.
Yeah, can you?
Professor, Satish, can you close this session if there is no more questions? The next, over to you, Dr. Narendra, please.
I request Dr. Nikki Sabharwal ma'am to introduce the next speaker, Dr. Kapil.
A very good afternoon to one and all. I thank the organizers for having me as part of this wonderful Trauma 2020, and I congratulate them on organizing this virtual trauma conference. I also applaud them for including this very, very important session, ventilation for surgeons, in this trauma conference. This is very important and pertinent, especially because a lot of surgical patients require ventilatory support, and this has become more pertinent in the COVID era. The oxygen therapy and ventilatory management has become the mainstay, and it is a requirement that all the medical professionals who are working with these patients should know something about this. So it is my pleasure to introduce Dr. Kapil Dev Soni, additional professor in the Department of Anesthesia and Critical and Intensive Care at JPN Apex Trauma Center, AIIMS. And he shall be speaking on basics of mechanical ventilation for surgeons. Dr. Kapil, please.
Thank you, ma'am. First of all, good evening, everyone. And thank you, organizers, giving me an opportunity to speak on mechanical ventilation for surgeons. So what I would be covering in this would be the basics of mechanical ventilation. I will not be going or giving very advanced information about ventilation. So what I aspire is that specifically this talk is focusing mainly on the registrars, residents who are dealing with critical ill patients of trauma or other specialties, and those patients, they are put on mechanical ventilation, right? So mechanical ventilation is one of the ubiquitous interventions these days, specifically in the era of COVID. It's been put left and right on the patients who are developing respiratory failure. In intensive care unit, this is one of the most common therapy which is employed on critical ill patients. So I start with a case, a 20-year-old case of multiple rib fracture getting treated in ward, suddenly becomes short of breath. He's tachypneic with fall of oxygen sets. He gets intubated and he requires to be connected to a ventilator. So the first thought which arises in a caregiver is why the patient needs a ventilatory support. So if you look at overall concept of respiratory failure, there are primarily two basic respiratory failure, and then there are 3 and 4 which are additional respiratory failure, which are subsets. So the basic two types of respiratory failure are the hypoxic respiratory failure and hypercapnic respiratory failure. Hypoxic respiratory failure means inability to oxygenate the blood or the deficiency of oxygen in the blood, hypoxemia. Hypercapnic respiratory failure means increased carbon dioxide levels in the blood, and this happens because of failure of ventilation. So mechanical ventilation is a useful modality for patients who are unable to sustain the level of ventilation which is required to maintain the gas exchange. Importantly, two important functions. One is the oxygenation of the red blood cells, and second is the removal of carbon dioxide from the body. So it's a technique in which energy is supplied in a predetermined way to augment or replace the patient's muscles in performing the work of breathing. So these are the three important concepts when somebody is thinking of putting a patient on mechanical ventilation. First is the patient developing hypoxia, or is it a problem of carbon dioxide? Or is it a problem of work of breathing? It's inability to breathe. So this is the three important concepts when somebody is initiating mechanical ventilation. In both the type of respiratory failure, the abnormalities can be differentiated, and sometimes you will find patients with both the abnormalities present. Patient is hypoxic along with patient's inability to breathe. That is developing both type of respiratory failure. In hypoxic respiratory failure, the primary abnormality is at the level of alveolar capillary membrane or alveolar capillary interface. Common causes could be the pulmonary edema, contusions, pneumonia, ARDS, or it can be aspirations. In hypercapnic respiratory failure, it could be the abnormalities may lie during the ventilation pathway. That may be a central cause, or depressed drive because of oversedation or because of overuse of opioids, or it could be because of the pump itself, that is the thoracic abnormalities, the cage, the impaired ventilation, multiple rib fractures, or it may be the development of effusion or empyema. So the causes may be varied for both type of respiratory failure. If you think about physiology of mechanical ventilation, what exactly is mechanical ventilation doing is it's providing a positive pressure during inspiration. So the initiation of a breath, the termination of a breath is either controlled by the machine or partially controlled by the machine, or in some modes it's totally determined by the patient, but support is provided by the machine. Okay, so the level of ventilative support may vary from a full support in where the work of breathing is essentially done by the machine, or in other case, it could be because of a partial support where the machine is partially supporting the work of breathing of the patient. So before thinking further about mechanical ventilation, this is basically for the residents, registrars, they should be familiar with the equation of motion. Equation of motion is nothing. It's basically a combination of three variables, which is the pressure, volume, and the flow of gas. And this is important so that whatever breath is being delivered by the machine reaches to the lung. So there is a physical formula where the pressure is determined by the volume divided over the compliance, added with resistance multiplied by flow. So this gives us a relationship between how does the volume changes along with the resistance and the pressure. So this is equation of motion. Typical breath, if you look at how doing, if patient is spontaneously breathing or a mechanical ventilator is giving the breath, how does it change? Pressure changes within the lung. So in this you can see, so this is what a normal spontaneous breath happens. Initially, there's a negative pressure generation, and then there is a breath, positive pressure. So this is a natural breath. On the other hand, a mechanical ventilator is giving a positive breath. Okay, it starts with the positive rise in the pressures, then it reaches a plateau, and again it remains above the baseline if there is an addition of a PEEP, and then it against the next breath. So there are multiple phases of a single breath. One is the initiation of the breath, one is the trigger, the initiation, the limit, and then there is cycling. Cycling means change of a phase variable from say from inspiration to expiration, so these are the various phases of a single breath, which is provided by the mechanical ventilator. So these are the phase variables. One must be aware how does the inspiration changes from expiration, what are the triggers, and how does the breath is stopped. So a change from expiration to inspiration is again determined by all these three variables along with time, that is the flow, volume, and the pressure. The inspirative phase, change from inspiration to expiration, and finally again the expiration. So these are the four components of a single breath or four distinct phases. A phase variable is a trigger. What causes the breath to trigger? That is from expiration to inspiration. Limit is what regulates the gas blood flow during the breath. How much the pressure may increase. There's a cap, there's a ceiling effect. So that is called as limit. And what are the variables which determines limit is again the three variables. And then there is a cycling. Cycling is nothing, but it's basically from inspiration to expiration. So modes of mechanical ventilation, most of us who are working in patients with trauma or patients who are critically ill, they are familiar with the mechanical ventilator, but we are also familiar with multiple modes which are there on the machines. Machine may vary from one vendor to another, but the basic modes remain the same. But then there can be the different additional additional modes or combination of modes which are available in specific machines. So one must be familiar what are the basic modes available, what are the advanced modes available, and how to operate these machines. So modes of mechanical ventilation is like this picture, where you can have one basic mode, and then there can be several additional modes, which are nothing but the small changed modes, or the combination modes, or the dual modes with some sort of automation or a closed loop automation. So you will find these additional modes may have variable names in different machines, but as a physician, you must be aware that what actually is being happening with the patient and what actually the machine is doing. So addition of newer modes or newer names, there's no regulations. So you will find a same mode having different names in different machines. So what is a mode? Mode is basically how the breath is being delivered. It's a way of delivering a breath by a specific positive pressure. And a positive pressure breath is basically depend upon three things. That is the trigger, the limit, and the cycle. They are the phase variables. There are four things: pressure, volume, flow, and time. These are the only four variables which vary. So why we say variables? Because they vary. And you can actually control one of them. The other three would become independent. So if I say a volume control mode, then the volume is determined by you or by the machine. A machine is controlling one variable. On the other hand, the pressure, the flow, and the time within the circuit and within the patient chest cavity, they would become independent, and they can vary based on the patient's underlying chest condition. So which type of mode should we start a patient on? There are multiple types of mode. One is a mandatory or controlled mode. Then there are assisted modes. Then there are supported modes. And then there are spontaneous breathing modes. So as I spoken earlier, that a machine can provide a full support or a variable, just a support, a full breath or a supported breath, or it may allow the patient to spontaneously breathe. So based on this different circumstances, a machine can give a controlled breath, assisted breath, supported breath, and a spontaneous breath. So ideally, there are 5 basic breaths. If you look at based on different modes, a patient can have a control mode, assist mode, again assist mode, or a support mode. Just a play of 4-5 variables. One is pressure, flow, volume, time. These are 4 variables, and based on the combinations of all these 4 variables, different breaths are designed. A basic mode is the volume set or pressure set. A volume set or volume control breath means a specific volume of gas would be delivered to the patient, and that's been fixed. On the other hand, the pressure, flow, and time may vary. Whereas in a pressure controlled mode, the amount of pressure which can be applied to the lung is fixed, whereas the volume, flow, and the time that can vary based on the lung characteristics or the compliance and resistance of the lung. So a control mode or a continuous mechanical or a mandatory mode is basically when the patient is paralyzed, completely paralyzed during OR or during initial phase of intubation. What machine delivers is basically a continuous or controlled mode. So this trigger could be pressure trigger, it could be flow trigger. In certain machines, it could be time trigger. In a pressure trigger, machine senses there's a drop in the pressure within the circuit and it starts triggering. Machine is triggered to give a breath. Whereas in a flow triggered, machine senses reduction of a flow in the circuit and it starts giving a positive pressure breath. So just a mechanism how the triggering happens. In the limit variable can be what you have set on the machine. If you are working in a volume control mode, then after a preset amount of volume, the machine would stop giving further volume. So that is, it can be a volume controlled, it can be a pressure controlled, just like a set pressure is achieved and then the machine does not give further breath. So that can be a limit variable. Sometimes in certain modes, it can be time variable as well. So what does it mean? The inspiration stops there, and this must be distinguished by the variable used to end inspiration, which is we call the cycling variable. A cycle variable can, again, it can be pressure, volume, flow, and time. These are only 4 variables in the ventilator. A variable that is measured to terminate inspiration and begin expiration is called cycle variable. And this could be time cycled, it could be a volume cycled, it could be a pressure cycled. So based on the combination of all these 3 things, trigger, limit, and cycle, one can look at whether the ventilator is giving a mandatory breath, is it giving an assisted breath, is it giving a spontaneous breath, or is it giving a supported breath? You can see. So most importantly, when I am looking at the patient, I would look at how the ventilator is doing a cycling. It's easy to do. If the patient himself is terminating the breath, either the patient is in a pressure support mode or patient is in a spontaneous mode. If the ventilator is cycling, it means either it could be assisted mode or a mandatory mode. Mandatory mode means if the patient is completely paralyzed. Assisted, otherwise it would be in assisted mode. So the best way to look at is how the ventilator is cycling and then to determine which type of breath is being delivered to the patient. So this is how the graphics change. These are called time scalars. There are 2 things. One is time scalars, other ones are loops. These are graphics which are displayed on the ventilators, and this as a provide a lot of information to the clinicians who are who's trying to synchronize the patient effort with the machine. So what you need to look at is the flow, pressure, and the volume. Volume would be always on the positive axis, whereas the pressure can be towards the negative axis as well. So as the flow, it can vary from positive to the negative axis. Just look at how does it flow. This is an example of volume ventilation or volume controlled. Volume controlled means a set amount of volume is fixed. It gives you a preset volume, so it's a linear. Whereas pressure and the flow becomes dependent on the lung condition. And once they reach a particular level, the ventilator cycles from inspiration to expiration. So this is a volume ventilation. Then there can be a pressure control ventilation. In a pressure control ventilation, you are setting up the pressure. The pressures are fixed, what you can achieve in the patient lung. So the volume and the flow, they become dependent variable on the lung condition. So you can see the pressure is fixed. This is the flow, inspiration, and then this is the expiration. They can vary. You can see there's a variation in the flow because now these are dependent variables on the lung condition. Assist control, you can see what happens in assist control is there is a effort made by the patient, and this effort is sensed by the ventilator. It starts the breath. And this is how every effort is sensed based on the sensitivity, trigger sensitivity, and the ventilator delivers. So this is assist control. Then, so this is assisted mode. If you see a graphic where there is a small negative deflection in the pressure, so this is the mode is basically assist control. In a pressure targeted mode, again, there would be some negative pressures in the circuit that would be sensed, and it will deliver a pressure control sort of a breath. So this is how you can distinguish between a complete mandatory breath versus assisted breaths. Then there are other modes like synchronized intermittent mandatory ventilation, where the machine is actually giving certain breaths. Then certain breaths are also assisted and others are spontaneous breath. So you can see, you will find graphics in some sort of like this. There was a lot of variation in the breath types which are delivered to the patient. You have one ventilator triggered breath, then there are the spontaneous efforts. These are spontaneous efforts. This is how it happens. These are spontaneous breaths. So machine is allowing patients to have a spontaneous breath. That's why SMV is also called a winning mode. So it can be, again, the SMV can be a pressure targeted or a volume target, or pressure control or a volume control modes. Then there are other winning modes that include the pressure support mode and the CPAP. What happens in a pressure support mode is the breath is triggered. So the ventilator is just doing a partial function. It's just supporting the patient efforts. And the cycling happens by the patient itself. So the cycle, the expiration is determined by the patient itself. The inspiratory time is variable. So this is a pressure support mode. You can see again, there is a negative deflection in the pressure, which is sensed by the ventilator, and the ventilator allows spontaneous breathing during the mechanical ventilation. So this is a weaning mode.
Dr. Kapil, may I just interrupt?
Yeah. I'm just finishing it now.
Can you sum up? We are short of time. Thank you.
So there are numerous modes now available, and one should be familiar with the 4 variables, specifically the pressure, flow, volume, and time. These can be, again, understand the physiology of the patient, and based on the physiology and the condition, adjust the mode of the ventilators. And what pitfalls? Ventilator can be injurious to the lung also. So one should be very cautious, very careful when delivering mechanical ventilation or attaching some patient to a mechanical ventilator. You should be well versed with the injuries which can be caused on the mechanical ventilation. So step for novices: determine the oxygen required, set the PEEP, decide the mode, try the initial mode, weaning modes. Unsure about the lung compliance, better to use volume controlled. When initiating a ventilative support, a good way to start is to use assist control. You choose an assist control mode, set the tidal volume based on the body weight, ideal body weight, auscultate once you put somebody on a ventilator, monitor the ventilator with an ABG or a clinical condition, and in case of any confusion or help, just call for intensivist. Thanking you.
Thank you, Dr. Kapil. It's a very exhaustive topic, and there are books and books written on this, and he has done a pretty good job in trying to summarize, but you'll have to befriend your anesthesiologist to learn more about mechanical ventilation. You'll have to have a hands-on there. Okay, Dr. Babita, I welcome Dr. Babita, my co-chairperson, and she'll be introducing the next speaker.
Yeah, hello everybody. Firstly, I would like to thank the organizers to invite me as a chairperson. It was really a pleasure to listen to Dr. Kapil. He, in a very easy way, he has dealt with a very difficult topic, that is mechanical ventilation. So now our next speaker is Dr. Richa Agrawal. She's working as additional professor at Jayaprakash Narayan Apex Trauma Center. And it's a pleasure to introduce. She has been our resident, and now she is working in intensive care unit. And she has a lot of publications, around 50 publications in various international journals. She's also ATLS faculty. And she'll be talking about interpretation of ABG. So once we have ventilated the patient, it's very important to know whether we are ventilating the patients properly. And the arterial blood gas analysis will give a lot of information. So Dr. Richa, please go ahead and talk about interpretation of ABG. Maybe it will be useful for surgeons because they're also managing HDUs and various places they're managing the patient on ventilator.
Ma'am, there are people who see the ABG even without ventilator. It's not necessary.
Yeah, definitely. Yes. And it's very important to know about ABG analysis.
Thank you very much, ma'am. Good afternoon to everyone. I hope you can hear me all. Hello, can you hear me?
Yes, we can hear you.
Yeah. Much.
So I'll be starting with the interpretation of arterial blood gas. The moment we start this, the first question which comes to your mind is why ABG? Can't I manage a patient without ABG? Yes, you can, but to a certain extent. ABG supplements the clinical examination, but does not replace it. Mind it, you have to clinically examine the patient and then go ahead with ABG. The clinical manifestations of many patients may get delayed because they are compensating. And so the ABGs, they come very handy in these situations. Many patients, they have multiple disorders and ABGs can give an access to that. They give you objective values. So for example, if the patient is in lactic acidosis, you cannot say what is the lactate. The ABG gives you the precise values and the response to treatment. And it also aids in CPR, that is during the cardiopulmonary resuscitation, when you do not know when there is a sudden cardiac arrest, what is the reason? These come very handy. What are the indications? Normally people think that the ABGs are done only to see the oxygenation, but if that is not correct, you can assess oxygenation, adequacy of ventilation, lactate, various electrolytes, even blood sugars, hemoglobin, hematocrit, an iron gap, and osmolarities. All these can be seen through the ABGs and accessed through the ABGs. Just revising the normal values of ABG as we go ahead and do some examples. Normal pH is between 7.35 to 4.5, PaCO2 35 to 45, and reference is 40. Pa2, minded it is 80 to 100 millimeters of mercury on room air. You have to know what is the fraction of inspired oxygen whenever you're saying about the PaO2. Bicarbonate is 24 plus minus 2. Saturation is 97 to 99%. And base excess is 0 plus minus 2. Now, it is a very interesting concept, base excess, which is coming up these days. I want to tell what is base excess. It is the amount of strong acid or base which is required to restore the plasma pH back to 7.4 at a PaCO2 of 40 millimeters of mercury at 37 degrees Celsius. The normal value is minus 2 to plus 2 millicoulombs per liter. Now, all the variables in the ABG are not measured. Only pH, PaO2, and PaCO2, lactate, and electrolytes, they are measured. Others are derived. So bicarbonate is a derived value. Secondly, as I already said, always comment on the PaO2 in relation to the fraction of inspired oxygen. Normal PF ratio is more than 400. The approximate idea which you can get of PaO2, that is you multiply FiO2 by 5 and get the PaO2 values in the normal lungs. Now, what are the steps for ABG analysis? The first main step is check the validity of the report, whether the report is valid or not. How to check it? This table gives you a fair idea of approximate H ion concentrations according to the pH of the patient. So if you have a pH of 7.35 in the ABG, the approximate H ion concentration is 45. You put that in this formula, multiply it by the bicarbonate in the ABG, divided by the PaCO2, and the value should be equal to 24. If it is not, it means your ABG report is invalid or there is error in the ABG. There is no fun in examining the ABG further. So first check the validity. The second step is check whether the patient is acidic or alkalotic. If pH is less than 7.35, we know that the patient is having acidosis. But what kind of acidosis we can come to know by seeing the PaCO2 and bicarb. If the PaCO2 is more than 45, it is respiratory acidosis. But if the bicarb is less than 22 millicoulombs, it is metabolic acidosis. So this is quite easy. Similarly, when you see alkalosis, see the pH. pH is more than 7.45, it is alkalosis, we know that. See the PaCO2, if it is less than 35, then it is respiratory alkalosis. And if bicarbonate is more than 26, then it is metabolic alkalosis. It is simple till right here, no hard facts involved in that. Now, the next step is to see whether there is an appropriate compensation, or if there is a compensation, whether it is acute or chronic. Now, body has a huge capacity to compensate. Whenever there is an acid-base imbalance, the body tries to compensate. Besides the buffers in the blood, the two main organs are the lung and the kidneys. So whenever there's a metabolic acidosis, there is a patient who will hyperventilate, wash out the CO2, and there's fallen PCO2. When there's the alkalosis, there will be rise in PCO2. Similarly, opposite, when there's a respiratory acidosis, the lungs are not breathing fine. The kidneys, they will try to save bicarbonate in order to bring the pH back. And when there's a respiratory alkalosis, when there is hyperventilation occurring, the kidneys, they will lose bicarbonate and they will fall in bicarbonate. Now, this is just 2 slides. What are the expected changes and how to see what are the expected changes in the acid-base disorders. In metabolic acidosis, it is easy to remember. Remember that CO2 would be 1.5 times the bicarb plus 8, whereas in metabolic alkalosis, the CO2 will also go down. It will be 0.7 into bicarb plus 21. Now, 0.7 is approximately half of 1.5. So it is an easy way to remember. And in plus bicarb is 8. And in the other, it is bicarb is, you're adding 21 to it. This is regarding the metabolic primary disorders. But when you come to respiratory disorders, it is a bit challenging because the kidneys, they take some time to compensate. So it all depends whether it is acute respiratory acidosis or chronic respiratory acidosis. Why I want to know? Because the treatment is different. In acute respiratory acidosis, you want to intervene early. In chronic, the body has already tried to compensate. The patient will remain acidotic and he will be fine for another few hours. So lots of equation here, but easy to remember is this figure. You just have to remember this figure. Whenever there is a respiratory acidosis, it means when the CO2 is rising for every by 10 millimeters of mercury, the bicarbonate rises by 1 in acute conditions and by 4 in chronic conditions. Similarly, in respiratory alkalosis, when the CO2 is going down by 10, the bicarb goes down by 2 in acute conditions, and in a chronic condition, it decreases by 5. And similarly, the pH in acute conditions decreases or increases by 0.08, whereas in chronic conditions, there is less decrease in the pH. And whenever the pH is between 0.03 and 0.08 change, it means it is a partially compensated stage. Now coming to few examples. Before that, there is another important point which I wanted to highlight is whenever there is a metabolic acidosis, we need to know what is the anion gap. It is used to assess the acid-base balance in metabolic acidosis because there are two kinds of metabolic acidosis, high anion gap and normal anion gap. The normal anion gap is 12 plus minus 2, that is 8 to 14, and it has to be corrected for the albumin levels. Whenever there is a high anion gap, then we go to the next step, that is the gap-gap ratio. Now I'll start with the examples. First is a case, 25-year-old man who comes to the ED following a road traffic accident. He is tachypneic, he is tachycardic and hypotensive. The pH is 7.26. How do you start evaluating? First, you see the pH, it is acidosis. Yes, it is acidosis. The CO2 is less and the bicarbonate is less. It is metabolic acidosis. What is the expected PCO2, which I told the formula initially, that you multiply the bicarb by 1.5 times plus add 8. So it comes out to be 26 plus minus 2. The CO2 is 31 here. It is approaching this value, that is 28. So it is a primary metabolic acidosis. Now it is a metabolic acidosis. I want to know the anion gap. Anion gap here is 21. So it is a high anion gap metabolic acidosis with obviously increased lactate. Second example, it is a 45-year-old male, case of perforation peritonitis following trauma. 6th post-op day, has been admitted in your ward, is having a watery diarrhea for 3 days and vomiting. The ABG shows these values. How do you interpret? How do you go stepwise? Now here the pH is again acidotic. Again, bicarb is low. It is a metabolic acidosis. Expected CO2 is around 18 to 24. The PCO2 is 25 here. So it is a primarily metabolic acidosis. But here when I calculate the anion gap, which is sodium plus potassium minus bicarbonate chloride, it is 12.5, which is a normal anion gap metabolic acidosis. Now, why do I want to differentiate between high anion gap and normal anion gap? Because the causes are different. Whenever you're talking about high anion gap acidosis, the most important in the trauma settings would be lactic acidosis, which could be because of hypoperfusion, hemorrhage, or sepsis, and rhabdomyolysis. Then other factors which could be there in patients who have diabetes, like diabetic ketoacidosis, or in starvation ketoacidosis. So these 4 points you need to keep in mind whenever there is a high gap metabolic acidosis, and you need to treat accordingly. Whereas in non-anion gap acidosis, the two important conditions which we encounter are the patients who are having ileostomies and colostomies and high output fistulas, and also patients who have urethral diversions or pancreatic fistulas. So if you have a non-anion gap acidosis, think of these conditions. Next patient is a 54-year-old male, case of road traffic accident. He with head injury on diuretics. He has been on ventilators for a few days. The ABG shows these parameters. Again, if I go by stepwise approach, it is alkalosis. Yes, CO2 is higher, bicarbonate is higher, so it is metabolic alkalosis. Compensation, if I see, The PCO2 is 53, which is near this. So it is a primary metabolic alkalosis. Now, what are the common causes in trauma settings? Patients who are in the ward having vomiting or overzealous NG suction, over diuresis, or patient having severe hypokalemia. So these are the clinical conditions which can lead to metabolic alkalosis. Now coming to another case, which is a 65-year-old male, road traffic accident, unresponsive, bradycardia with respiratory rate of 8. Acidotic, yes. PCO2 is on the higher side, it is respiratory acidosis. I want to know whether it is acute or chronic because my management is going to change otherwise. The CO2 has increased 18. If acute, the pH should be 7.26. Our pH is 7.27. And if chronic, the pH would have been 7.35. So it is an acute respiratory acidosis. But I want to know, is there a metabolic problem too, or only my patient is suffering from acute respiratory acidosis? If I see the bicarbonate, the expected bicarbonate according to this equation should be 25.8 and ours is 26. So there is no additional metabolic disturbance. Coming to the last example, another important example which we see, a 25-year-old female case of polytrauma, tachycardic, crying in pain. And this is the ABG value on room air. If I see pH, it is alkalotic. Respiratory alkalosis is there. CO2 is less. Now acute and chronic, I can differentiate by seeing the pH. This is the acute respiratory alkalosis as seen by the pH, which should be like this. Yes. I want to know whether there is a metabolic problem too. Yes. If I see the bicarbonate has risen only by 20.8, which is expected, and the actual is 20. So there is no additional metabolic disturbance. The only problem is respiratory alkalosis. Now, problem is this, where you have defined through the ABG, that is, it is respiratory acidosis and respiratory alkalosis. Now, what to do? So you should know what are the common causes of respiratory acidosis, which we see day-to-day on day-to-day basis. The first is of respiratory acidosis. The common causes are hypoventilation, airway obstruction, rib fractures. The patients in the ED, they may have respiratory acidosis, which is because of this and which can be treated within a minute. And then spinal cord injury, head injury, and other opiate abuse. Last slide is because the causes of respiratory alkalosis. The patients who have polytrauma, they may be in pain, anxiety, they may be hyperventilating because of that. Then there can be other disorders like hypoxia, fever, or pulmonary edema or pneumonia. And then this can be ventilatory induced. So these are the causes of respiratory alkalosis. So by seeing the ABGs, you can define what is your metabolic condition, see the clinical differential diagnosis, and treat accordingly. Thank you.
Thank you, Dr. Richa, for an excellent presentation. It's a very difficult topic made very, very simple. And I think I can't see any question and answers in the Q&A section. So as we are short of time, I would again like to thank the organizers and Dr. Babita, my co-chairperson, and Dr. Kapil and Dr. Richa for excellent talks on very difficult topics. To cover in 15 minutes is really tough, but very well done. Thank you very much. Thank you so much.
Thank you all chairpersons and speakers to take out the precious time from your busy schedule for this session. Thank you very much. Now, without wasting time, I am going for the next session, which is very important. There's a special scenario for the trauma surgeons. I'm delighted to share that for this session, we are having Professor Manish Singhal. Sir is a head of department for the plastic surgery at AIIMS New Delhi. Welcome, sir. Professor Kamar Azam, sir is a professor of orthopedics and currently heading trauma center at AIIMS Rishikesh. Welcome, sir. Professor Vivek Trikha, sir is a professor at AIIMS in Department of Orthopedics. Welcome, sir. And Dr. Pankaj Kumar Singh, sir is additional professor in neurosurgery at AIIMS New Delhi. Welcome all. Over to Professor Manish Singhal, sir.
Thank you, Narendra. Thank you and welcome to this virtual conference. Thank you, sir. Thank you for accepting our invitation, sir. It's my pleasure to introduce Dr. Sabapathy, sir, and he is my mentor. He is in fact mentor of most of the plastic surgeons of the country, and sir is a renowned hand surgeon. And but in burns, sir has a very recent interest in burns, and he just started a Rotary International supported burn program in his hospital, and you will be very glad to know that
In spite of a private setup, sir is doing exemplary work in burns, and he has agreed to deliver this talk. Burns for trauma surgeons, sir. Over to you, sir.
Yeah. Thank you so much, Manish. Hope you're able to see my screen. And when Manish told me that I have to speak on burns, I was really overjoyed. As Manish said, we are a major trauma unit for the last 30 years. And recently we have forayed into burns. And I found it really is a big challenge to get equally good outcomes in burns. So are you able to see, Manish? Hello?
Sir, we cannot see the screen.
Sir,
we cannot see your screen.
Yeah, okay. Share screen. Yeah, one second. Yeah, one second. Manish, I'll get it. Share screen, I'll get it. Yeah, one second.
Yes, sir, we can now.
Yeah,
Yes, sir.
okay. Yeah,
Okay, sir.
Okay, sir. So thank you so much, Manish. Hope you heard what I said in the first line, that I was overjoyed when you asked me to speak about burns than other physical trauma. Because in the last 30 years, I found this is much more challenging to get equally good outcomes in burns. And I thought I should short 15 minutes talk as to what I should speak. Because burns can come in as a very small burn, or it could become as a disastrously big burn. And each of it has its own issues, but all of them causes a tremendous amount of anxiety in the patients and their families. So if you take the basic principles, I'm only going to finish with this slide, and I'm going to tell about what I felt as important in this last couple of years. So all of us know that burns, major burns, over 15-20%, all of them require admission. And most of them, after that, they require resuscitation. And circumferential burns require a fasciotomy. And in case of electrical burns, they also require fasciotomy. I think these fundamentals all of us know. And burns is like any other trauma. We also know whenever it comes, you also have to go through ATLS protocol. I think that's given. So having said that, we understood this. I think where are the things? How is this burns differ from other forms of trauma, which we are really fighting hard to understand. The thermal trauma is more challenging than other trauma, physical trauma, because the magnitude of the systemic response is always higher. Now you find the fellow comes in 4 pieces, he's got multiple polytrauma, and then we resuscitate them. We find we can take them up for next stage of surgery. We can take them for major surgeries, and they can become all right in about a couple of weeks. Well, it's not so in burns. The magnitude of systemic response the body puts up is much higher, and it lasts longer for longer time. The second thing is resuscitation endpoints are reached much earlier in other forms of trauma. Even in hypovolemic shock, if you're able to control the place of bleeding and all that, so you could reach the resuscitation endpoints, you can reach faster. But whereas in burns, we are not able to reach that. That is one. The next is the cost of care is always higher. And if a complication should happen, it becomes astronomically higher. So it's a very resource intensive, skill intensive, labor intensive, and time intensive specialty. So the stress response in burns, as I said, now how is it different? See, long back now, when we were in physiology, we read this. That is, whenever there is a major injury, I think body responds by this way. That's Cuthbertson's ebb and flow hypothesis. So there is an injury, and then what happens is you have ebb phase that lasts for about 12 to 14 hours. There's a decreased cardiac output, decreased tissue perfusion, reduced oxygen consumption, metabolic rate is low. So that's what happens. But then you get onto a flow phase where there's increase in metabolism, body temperature, everything increases. And when this it reaches normal in course of time, when you do the surgery and then make him all right. Whereas there's a normal phase will go. But whereas if you compare this normal in the case of burns, what happens is that it doesn't reach normal at all. I think it keeps on going. And if it tries to get to normal and then you get a hit infection, episode of infection, then again it goes up. And then you get some raw areas, you get another surgery, then again it goes up. That means it keeps on going for longer and longer. And this hypermetabolism, I think it lasts for a long time. I think it shoots up and lasts longer. So it means these are all starvation and all. I think if you have severe sepsis, it goes there. And is that other polytrauma that we get, skeletal trauma that we get here, but then a major burns get here. So that's one different challenge that we have. And it is shown by the amount of epinephrine levels and cortisol levels. You'll find if that is the normal level, you will find the norepinephrine levels both in the blood and the urine they stay longer. Cortisol levels are longer. So this part of it now we need to remember so that now we can. So how do we treat this metabolism problem is you need to increase the anabolism. That is, you need to exercise, you need to do the surgery faster. And the nutrition is a very, very appropriate thing, and physical therapy. I'll come along them in the talk. And we need to reduce the catabolism. That's you prevented by infection, you prevent hypothermia, you prevent hyperperfusion by resuscitating them well, and you prevent acidosis. The next problem we found that is unlike other forms of trauma, I think all trauma science need to know, is about the nutrition in burns. So all of us know that if you have underfeeding, you get muscles get wasted. There's a poor wound healing and all that. I think all of us know this. Overfeeding causes these problems. But then in burns, there's a tremendous amount of underfeeding. And all of us know what lean body mass means. I think the body or the mass of the body that's not fat. 10% of reduction of lean body mass lead to impaired immunity. And 20% of loss of this impaired wound healing with us with 30% mortality. In 30% loss goes to 50% mortality, and 40% when it goes, all of them die. I think that this is a very important fact. I think in burns, you reach this state very fast. I think unless you take care of this, I think that's one of the causes of death. And protein metabolism again in burns, you find the muscles only break down of muscle proteins to produce more glucose. That again happens. And as much of more loss of muscles that you have, that means we will not be able to use the glucose. As much of 150 grams of skeletal muscle is lost per day in the absence of adequate nutritional support. I think that's the biggest problem. And in the burns unit, we find that one of the other things we have to take as a trauma care is that you need to take care of the nutrition. And the timing of feeding is that you need to do it as early as possible and as continuous as possible. And full feeds can be started as soon as the surgery is over. And even when there is a hemodynamic instability, I think you need to really give rise to the feeding part of it has to be continued. And when the hemodynamic instability comes in, you put a high dose of vasopressors, it gives mesenteric ischemia, and then wait to problem. So that's the reason why we need to really resuscitate them well. The third point where I found difference in burns is with other trauma is infection. In skeletal trauma, or where this extremely soft tissue loss, we always found it easy to control infection, whereas it is found to be very difficult with burns. Why is infection important? Because once the patient survives the hypothalamic phase, the infection and hypermetabolism are the two main reasons for morbidity and mortality. And burn patients all of them are immunocompromised, and hence all efforts should be made to decrease the infection. And the onset of infection retards healing, and graft take is poor, and it converts the partial thickness burns into a full thickness burn. It's so surprising because it's so challenging, because initially when the burns come, I think it's due to heat, all of them are sterile. That means there are no infection, but all infections that happen to burns patients happen in the hospital. I think that's the reason why we need to be very, very careful. And you find if there is a skin loss or in a necrotic tissue there in the shirt, the bacteria double 2 to 3 times per hour and become 10 million in one day. I think that again is a very, very important point. But all of us as trauma surgeons know about the definition of colonization infection. But then what is really required or what really matters in burns is it's not a question of colonization. It's the issue, the amount of infection that happens in the tissue. I think that's what is very unfair. And most of the times when you get the invasive wound infections, I think when it gets into the tissues, I think it becomes a surgical emergency. And then we need to debride it. I think we need to really debride it. We have to resuscitate the patient and put them on the appropriate antibiotic. Now, what has made the difference in burns is, I would say, for the trauma stage, just like you debride a wound normally, I think if you have a physical form of trauma, you debride and cover them early. I think the same thing has happened in burns is that you also excise the burn early and you promptly autograft. If you're not enough of skin to autograft, I think we need to get it from the skin bank so that you do. And these are the things which should be, but then the top in the list is early wound excision is the most important thing. Why surgery is because it has become the standard of care in most of these major burn centers. And I found that if you do early surgery, it reduces the release of inflammatory mediators early. And the chances of for them going into multiple organ failure is much lesser. And multiple random control trials comparing early excision and traditional methods of treatment, they always have favored early surgery. If you're going for a conventional treatment, I think particularly for major burns, I think minor burn doesn't really matter, we found it. But major burns, the consequence is very much because they always going for infection, granulation in tissue, and then once the infection sets in, it always goes into a very bad negative cycle. We find that the burn wound is the source of all evil. So what I would say is that I think we need to change paradigm shift. We have to take place, and as we do all the major trauma that we take, I think we should also do the same way. I think the burn wound needs to be excised. The necrotic cells, the denatured have to go. Once they go, the inflammatory mediators are becoming lesser, and the local and the systemic inflammatory response becomes less, and the patient goes on to a path of good recovery. And you've got a number of articles that come up to say that is the better way of doing it. And a few points now, what we have to establish is we need to understand, once there's a major burn, they've got a high risk of hypothermia. I think that again we need to take care. And if you have a hypothermia, these are the problems that happen, arrhythmias, coagulopathy. I think when the body temperature goes down, the chance of infection is also it becomes much higher. And one special problem that we have is inhalation injury of burns. I'm sure it will be covered up in other places now, so I'm not really getting onto that. This really makes up the mortality higher. The burns can occur with other injuries. I think a series of cases that we had, particularly during the monsoon times, the electric men, they get injured. They fall off, they're shown away by electric shock. Not only they get a burn, but they also have spinal fractures or long bone fractures. So all of us need to really take care about that. You need to go through the ATLS protocol when you see any major burns. So finally, where are we now? I think the burn problem is very high. I think all of us know more than 1 million burns happen every year in India. And most of them are preventable. I think there's a very good article which has happened. I think both Manish Shingla and us may have been co-authors of article which has been done by plastic surgeon from Michigan. It's a nice article which says about the real status of what is the status of burn care in India, as the geospatial mapping is a guide for resource allocation. In that article, they have found about 67 major centers, and the number of beds is hopefully short. But the one thing that is surprising is that, and you'll find that any place in the country is only 3 hours away from a major burn center. I think it's possible to, by in 3 to 4 hours, so you should be able to reach some burn center or some specialist center you're able to reach. That's good. And the emergency progress available within 1 or 2 hours. If it's gave, that means you get a very good repair. And this is what I said in this article we found. I was also very surprised with the findings. Within 2 hours, you should be able to go. And 15% of the people, they have an access to ICU care. And if you see the world, what has really happened, the 50% survival rate has increased from 35% to 80% of burn surface area in the past 20 years. I think from the antibiotic fluid, this is the scale, I think how we reach. From 50% survival, from 55 to 80% it has reached. And the LA50, there's also really has come down. But then we have a long way to go. I think this is an article which has come up from North India. You'll find the number of deaths, number of cases, the number of deaths, almost 100%. And a publication also came from South India. I think almost the same. I think nobody over a period of 60% consistently survives. I think that has been both in North India and South India has been there. Why is the mortality high? I think there may be many reasons for that. But then there is always a silver lining. I think if we shouldn't have been taking every step that has been taken by all of us. I think we need to take to the state. I think what has been proven as the best of care in other centers, I think we need to take. And for that, one of the things is that early referral to a burn center is very important. And people say that people have been assessing, we have been assessing death, standard of care by the death rates. But most important is that the quality of life is their point of how the people have started assessing the burn care. So skin banks are also very needed badly. I think once the skin banks come up, I'm sure our results also will increase a lot. So the way to go, I think, is that if you have a major burn, I think the burn people have got a higher chances of living if they are referred to a major burn center. I think every burn with more than 20%, if it gets to a specialist center, I think there is a trauma surgeon we need to recognize. And as a trauma surgeon, before referral, you only need to know, you need to recognize whether there is a need for emergency surgery in the form of splinting of fractures or other things like other associated injuries, or whether the circulation is impeded to any other part. I think barring these two conditions, I think if they are able to send to a different burn center, I think our results also could improve so much. So thank you so much, Dr. Manish Singhal, for this opportunity.
Thank you, sir. Thank you, sir. Narendra, do we have any questions from the audience or anything, or because sir has to leave for another meeting, or I will ask sir. So can I ask a question, sir?
Yeah, sure, Manish.
Sir, I have seen most of the setups, even the general surgery people also manage burns, and they are also having a nice burn center. And I feel the plastic surgery community is little small to manage burns.
Yes.
So what additional skills a general surgeon or a trauma surgeon should have if he doesn't have a option to refer to a burn center, so that he can at least manage for maybe initial week or something the acute burns? What additional skill they should learn, and from where?
No, I also used to think about this, Manish. You find in the first week of resuscitation, I think that doesn't require any additional skills. I think it requires one good intensive care and somebody who to recognize whether there's an inhalational injury and then ventilate. I think that's the one which is, I'm sure now which will be available in most places. And I think we can go by step. If you find, if you think there are a large area of a full thickness burn, I think early referral, I think that's what is the one, that's the only thing which can really make it as early referral to a burn center is the only thing. So there's a question of scoop and run or stay and play, So you find that if they recognize that the considerable part of the burn is a superficial burn, that means they could manage with it in the same center. And if they could prevent infection, I think they all of them will survive. But then if you think that is a larger burn, which has got a predominant area of full thickness burn, that means that recognition and referral to a bigger center should be fine. Otherwise, it becomes a very big, difficult process to manage.
Okay, sir. Thank you, sir. Thank you. Thank you very much, sir.
Thanks so much.
I think Narendra sir. Thank you, sir. Narendra sir has to leave immediately because he has another talk, international talk. So if you permit, he can leave the session in between.
Right, sir. We have a lot of, but we can address the sir on the mail, and we will get mail to the sir for the queries. And citing the time limitations, I think we can permit sir to leave the meeting.
So thank you so much. Namaskar.
Thank you, sir. Thank you very much.
Bye-bye.
Over to Professor Vivek, sir.
Okay, so good evening, everybody, and let me thank the organizers for inviting me as a chairperson out here. I would like to introduce my good friend and colleague for the last 25 years, Professor Vijay Sharma, who is an expert in trauma surgery in orthopedics, especially in pelviacetabular surgery. He does all these complex surgeries with finesse and with ease, and he's well renowned for his work. He's into research, a lot of international projects in his hand, and he's world famous for his cadaveric pelviacetabular fractures, which he does the workshops every year. So over to you, my friend, Professor Vijay Sharma, for his talk on acute management of pelvic fractures.
Thank you. Respected chairpersons, dear seniors, respected seniors and dear friends. So pelvic fractures are, the most challenging injuries trauma surgeons, orthopedic surgeons, they face in trauma emergency. And it's because of the high mortality and a lot of associated injuries, we know. So many specialties are involved. Me and Vivek, we used to tell in all conferences, successful outcome of a patient with unstable pelvic fractures. It tells us how efficient trauma teamwork is in that hospital. So like this talk is for trauma surgeons, so there's nothing definitive fixation. It's all in the acute management of pelvic trauma patients. So what is the main problem here when the trauma surgeon is posted in trauma team in emergency department? Because there we work as a team, like orthopedic surgeon is there, emergency physician is there, orthopedic surgeon, trauma surgeons are there. So for orthopedic surgeon, it's like it's a type C injury, it's a vertically unstable fracture and it will need fixation. But no, the problem is not that. Problem is very high mortality. Mortality is because of hemorrhage associated, and another thing is associated injuries, other associated injuries, which are rule rather than exception in pelvic fractures. And then don't forget the morbidity, like from skin to subcutaneous tissue to urogenital area to distal neuro, like lumbosacral trunk injuries. So there are a lot of injuries which are associated with pelvic fracture. We don't have to forget them, and we have to start working on them from the beginning. So if you look at this photograph, it's quite scary, and you can see that it's veins, and we have to understand bleeding is 85 to 90% of the cases it's the venous plexus, and 10 to 15% of the cases, around 10. And then obviously the fractures, SI joint disruption is there, fractures are there, a lot of cancellous bone, a lot of bleeding. So these are the sources of bleeding. Am I audible, Dr. Vivek? Okay.
Yeah.
So bleeding is from, and the problem is arterial 10% arterial bleeding. If patients are not, sort of resuscitated by the maneuvers I will tell you in emergency, then you start thinking that maybe bleeding is from some arterial source, and these are the patients who cause problem. So this I have told, and the problem is associated injuries, and problem in orthopedics is orthopedic patients are associated injuries. They are so distracting injuries. They always distract the residents towards themselves. A patient with amputation, patient with compound fractures, patient with long bone fracture. Obviously, even attendants, they want you to look towards those distracting injuries, but the problem is not there. Problem is in the pelvis. And the thing is, if the same patient has a pelvic fracture with intra-abdominal injury, or mortality is more than 30%, and if patient has combination of pelvic fracture with abdominal with head injury, then the mortality rate is more than 60%. So these are quite distracting injuries sometimes, and they try to pull you towards them. Of general trauma. So old age, and if patient comes to ED with I think maybe it has been discussed in massive transfusion protocol, like ABC of MTP, like patient comes with systolic blood pressure less than cardiac, severely displaced fractures, and the requirement is much more higher. So these are the mortality. We are just looking at the mortality part first. And we have to understand that more than 50% of these fractures, they have bleeding outside pelvis. So one on the floor and 4 more. So you try to resuscitate the patient, you try to do the maneuvers. And at the same time, because in our emergencies, we have horizontal resuscitation, we start looking for other sources. Like in the chest, you do chest x-ray or clinical examination. Abdomen, you do fast, and long bone fractures, you can do clinical examination. So when to suspect for a trauma surgery resident, deformity of pelvis, there is leg length difference, and you don't find any long bone fracture. There are abrasions or swelling around the pelvis, like moral lesions. There is scrotal or labial swelling. There, and obviously blood at the meters, bleeding from rectum. And you just have to do the stability part once in emergency, because after that you have to close the pelvis. So these are a few pictures in our emergency where you can see like soft tissue defects, scrotal hematoma, vulval hematoma, and you can see swelling on the front. So these are this is the way patient presents. And this, you can see lateral compression injury. You can see the left side totally internal rotated, and there's no fracture. So there's a high chance patient has got a lateral compression injury. So what to do? The most important thing is don't panic, because obviously life comes before anything else. You have to stabilize the patient. That is the most important thing. And to stabilize patient, there are 3 simple things. Close the pelvis, We'll tell you the maneuver, how we can close the pelvis in the easiest way, and then fill the patient, resusc the patient. Multiple times it is discussed, and then try to find the cause so that you address the cause. So there's three things for the trauma resident: the close the pelvis, resusc the patient, which all of us are very well familiar with, and then try to find the cause. And then once the patient is stabilized, you will start looking to assess other injuries also. So first thing is close the pelvis. So closing the pelvis, now there are a lot of articles that binder or a sheet, simple sheet. You internally rotate both the lower limbs, and you can even tie a bandage just supra patellar area also, just to keep it internally rotated. And then one person can try to stabilize the pelvis, and then binder can be applied, and it can be clamped at 4 points. So it provides very good circumferential initial pelvic stability. And there are articles, you apply binder and then the patient's hemodynamics, it starts improving. So most important thing is it has to be centered over greater trochanter, because earlier we used to see a lot of binders, they were quite distal or they were quite proximal, and they used to act as a abdominal binder rather than pelvic binder. So position of binder is very important. It has to be centered over the greater trochanter. So this is the first thing. So this is the X-ray before application. You can see it is totally opened pelvis. It is a APC type injury type. You can say APC3. I will just share you some classification part also. And once you apply the binder, you can see it is totally closed. Right. So binders, they reduce transfusion requirements, they reduce length of hospital stay and mortality in patients with APC injuries. Now the problem is you apply the binder, you send the patient to orthopedic surgeon, and he will feel there is no injury. It's like APC3 is converted into a stable pelvis. And how to take care of binder? Like every 6 hours, every 5 hours, you have to loosen it. You have to look at the bony prominences. And you have to write down the note so that it is removed whenever patient is stabilized, and preferably within 24 hours of application. Otherwise, there are skin problems with the binder. And after removal of binder, obviously then we'll get scans again, because obviously it will again open up a bit, because it looks quite stable injury. So what are other options of, now we are just looking at first thing, closing the pelvis. So what are the other options? I think in our trauma center, we had this clamp, C clamp. Now you can see that this is applied and pelvis is nicely closed. It is very good for posterior injury, like SI joint disruptions. But the problem is you have to have X-ray beforehand, because if there is a fracture of ilium, these sharp pins, they will enter the true pelvis and they can injure any organ. And number of surgeons look like it has to be applied by orthopedic surgeon only. Another thing is external fixators. Earlier they used to be applied in emergency, but now there are a lot of articles which say the binder, it works much better because it gives circumferential compression to the pelvis. Because fixators, anterior fixators, when you try to close the pelvis anteriorly, there's a high chance that it will open up posteriorly where the bleeding is happening. So isolated external fixators in emergency is not a good idea. So now we can see that only pelvic binder is there to close the pelvis. So this is the indication. There are indications of external fixation. You're doing a laparotomy, you're doing packing. So it should be applied, because you are packing against unstable pelvis. It will keep opening up. So in operation theater also, when you're doing any procedure, orthopedic surgeon should be with you, or you should learn the trick of external fixator. So that the pelvis is closed, or it can be used as adjunct to open reduction internal fixation. So now you have closed the pelvis. Now simultaneously you are building up the patient, you are filling the patient. So crystalloid, there are changes in ATLS protocol, 1 liter crystalloid, and then obviously switching towards the blood. And Tranexia is a new addition in the last 1 gram as early as possible. Then it is the part of filling the patient. So you have closed it, you have filled it, and now you try to find out the cause, like one on the floor, 4 more. And see, as trauma surgeon, orthopedic surgeon, you just get one image of pelvis, that is the pelvis AP view. Dr. Amit, he told me to just tell you a few points about the classification and imaging. So what are the clues on X-ray? So you have to look at iliolumbar ligament avulsion. It is just L5 transverse process avulsion, ischial spine avulsion. and unable to clearly make out sacral foramina, asymmetry of sacral foramina, significant displacement anteriorly. Obviously, it's a ring-like structure. If there is a disruption anteriorly, there is some sort of injury on the posterior part also. And then avulsion of sacrotuberous ligament. So this is a kind of X-ray, and this sacroiliac joint and posterior structures are more important than looking at anterior structures. So another thing is radiographic signs of instability. If you find SI joint disruption, there are articles of fractures, even posterior injuries you can identify on a plain X-ray. So you get CT scans, you get inlet outlet view, so many views just to, because if you want to do a surgery, you want to have complete idea about the disruption. Otherwise, instability pattern, you can just look at AP X-ray, and if you go systematically, you can detect most of the fractures. There's posterior fracture gap rather than impaction. So it's a APC or vertical shear injury. In lateral compression injury, there is always impaction, which is a stable, a stable pattern. And then I've told you about the avulsions. So why CT? Why we get CT? Now you can look AP. In AP X-ray, you can make out there is a fracture of the sacrum. There is something going on the left side of SI joint. But CT is important. Now you get look at the CT, and now you plan further, because now you can see the severe disruption, type C disruption of the pelvis. So classification systems, we use two classification systems. Tile is mainly, it predicts the need for operative intervention. It looks at the stability part. But Young-Burgess classification, it tells you the mechanism of injury and it estimates mortality also. So Tile, it is a stable injury where ring is stable. Partially stable is there is incomplete injury to the posterior structure. Now you can see that on the top image, there is injury to the SI joint, but it is not completely gone. So this is Tile partially stable. And if it is totally gone, you can see on all the images, total SI joint disruption is there. So these are type C disruption according to Tile. Young-Burgess classifies according to the mechanism of injury. Lateral compression injury is the commonest injury. And then again, LC1, LC2, and LC3, depending on the severity of injury. And this is anteroposterior AP compression. These are the injuries which cause hemodynamic instability rather than LC injuries. So APC3, you can see there is disruption anteriorly, there is complete disruption posteriorly. APC2 and APC1, there is symphyseal disruption, but there is no posterior injury. But in APC2, there is posterior injury, but it's not a complete injury. So this is how the severity of injury it goes. Then you find vertical shear, and a lot of times you find combination of injury. There is combination of vertical shear with open book, or there is combination of the APC and one side APC, one side LC. So you find combinations also. So why Young classification became popular? Because it used to tell about morbidity and mortality. You can see mortality is much more higher in vertically unstable patterns and APC3 because of hemodynamic instability. And severe bleeding you can detect, and even bladder injury and urethral injury. So it gives you idea about the morbidity and mortality. So stable pelvic fracture, no one is worried. The problem is when patient is unstable. And so the most important is, because if pelvic fracture looks stable and patient is unstable, then you have to look for other sources of injury. A very stable pelvic fracture will rarely do hemodynamic instability. So the problem is when the fracture is unstable and patient is unstable, then there is likely that the patient is bleeding from the pelvis. So what to do? So when to do pelvic packing, when to do embolization. So I will tell you what literature favors. Or patient has to go to OT or patient has to go for embolization. Soon we are going to have hybrid theater. So both of these things, they can be done under the same roof. Because transferring the patient, then coming back, then if you plan embolization, patient again goes back. So you embolize, patient is still unstable, you can do laparotomy. So everything is going to be done under the same roof. So hybrid theater, we are going to have this. But in the meantime, what exactly we do? So this is the algorithm. So you do close, you have done resuscitation, you find the causes pelvis, and patient stabilizes. So nothing you have to do. Then it is total orthopedic patient, right? So we'll do the CT, we'll do definitive management planning. But if patient does not stabilize, that is a problem. The patient is transient responder at our place, maybe patient will go to CT angio. We'll embolize the patient. Patient still unstable, will go to OT. But if patient is non-responder, patient is non-responding, then and patient is fast positive, there is no ambiguity in that. Fast positive, unstable will patient goes to OT. But if patient is fast negative, unstable patient goes to OT, and we'll do pelvic packing and X-fix. First X-fix, close it, and then do the pelvic packing. There's no point doing a pelvic packing on a totally unstable pelvis. So now packing and angio, there are groups like North Americans and Europeans. So there is a big debate like in country like India, I think still the teaching is second line of defense is pelvic packing. X-fix, pelvic pack, and if still patient is unstable daytime, and if you have facility, then angio. Because time of intervention packing versus angio, 45 minutes. This is article from Injury from West, and it is a recent article, 2010 or 2008 article. Blood transfusion was much less in packing group as compared to embolization group, and mortality was less in packing group. Angiography, it is less invasive, high success rate, it stops arterial bleeding, but pelvic packing, it is quick to perform, does not require any special technology, just a Phenan-Seal incision, you can do the packing. And if still patient is unstable, patient can go for embolization. So these are the patients who benefit from embolization. Persistent hypotension, continued transfusion, like such patients in our center can go. But if you look at other parts of district hospitals and all that, and if you tell them that embolization will be done, they don't have facility of embolization. So it's a wrong teaching for them to tell them and convince them for embolization. So all these stable and unstable and transiently unstable patient would go to operation theater. So these are few slides of embolization. Now coming on to open bony pieces in the rectum, or you find bleeding coming from rectum. You find blood on the urinary meatus, or any skin disruption, you have to examine. And the thing is, now what is the role of trauma surgeon here, or GI surgeon? The colostomy, the site of colostomy. This is the big problem we face, because colostomy is done exactly where we want to give our future incisions for definitive fixation. So colostomy or diversion should be done at a higher place and with consultation with the orthopedic surgeons. So that is another point I want to make here. So these are compound injuries. Sometimes they come very early, and you can thoroughly debride them, close them, even fix them. So this was a child and came within hours. So we have done, we have managed it quickly. Urological injuries, again SPC. Patient, we do a Phenan-Seal, we won't be able to operate upon that patient from the anterior approach. So another advice is try to tunnel the SPC to some other area so that your definitive fixation does not hinder. Nerve injury, careful examination of nerve injuries, lumbosacral plexus damages up to 45% of type C injuries. So this has to be documented when patient is going to the ward or ICU. If patient can be examined, obviously. Patient in extremity or trauma center faces a lot of time, because we have, I think, the maximum number of by any study. So I think patient dying in front of you, you have opened up, you find a retroperitoneum, there is a hematoma, and patient is quite unstable. So obviously laparotomy deal with any intra-abdominal bleeding, and if you're not happy, you can do bilateral interligation and pack and send the patient to ICU. Reboa, Dr. Vivek, I cannot comment because we don't have this facility, but definitely in patients in extremes, severe lower extremity injuries where patient sometimes comes and patient is in arrest. And so there are very few articles, but there are articles where they were able to save 40 to 45% of patients with Reboa, which they claim. But since we don't have this, so I'm not the right person to comment on this. But I think trauma surgeons, they also know about the Reboa. So to summarize, if patient comes alive, so patient should remain alive. I think that is the target of all of us. So we have to quickly see whether the patient is hemodynamically stable or unstable. 3 things in emergencies: close the pelvis, fill the patient, resuscitate the patient, and then try to find out the source of bleeding, whether it is exclusively from pelvis or from some other source. Define fracture pattern, because you will just get one X-ray, and if you read it nicely, you can see it as unstable or stable, and address all potential injuries, injured areas from skin to inside. Call colleagues early. Patient goes to theater and wrongly performed SPC or it makes life difficult for orthopedics people. So don't compromise definitive reconstruction by suprapubic and stoma only after consultation. Thank you.
Thank you, Dr. Vijay. Very important topic, and you actually covered it very nicely. And for the benefit of the postgraduates, the importance of hemorrhage control in the patients with the pelvic fracture. So now I'll request the chairpersons of the next session to begin the next session. And I thank, first of all the chairpersons of this session. And I'll request Dr. Pankaj Singh to please stay for the next session to chair the session. And I'll request Professor V. Sinu. I invite Professor V. Sinu, who is a professor of surgery at All India Institute of Medical Sciences, to chair the next session. Dr. Sinu, please. I can see Dr. Sinu somewhere he has joined. Hello. Okay, in the meantime, I'll request Dr. Qamar Azam to please stay for the next session. Dr. Sinu?
Yeah.
Yeah, sir. Welcome, sir.
Good
Professor
evening.
Sinu, he is a professor of surgery at the All India Institute of Medical Sciences, New Delhi, and is head of Surgery Unit 4. Welcome, sir. And
thank you very much, Subodh.
Yeah.
And
we have,
yeah, in this session, we have 3 talks.
yes. So, sir, we will start. We have Samir live. We have Dr. Chavi live. So first we will have 2 live talks.
Kenneth
And
also
then,
is on live because I saw him.
yeah, he is at 6 o'clock.
Okay.
So
So we will start with.
We'll start with Samir and Chavi, and then we'll see how it goes.
Sure. Thank you.
Yeah, please.
Okay. So
I hand
the
over to
first
you.
speaker for this session is Dr. Samir Mishra, and he will be speaking on legal issues in trauma and emergency care. Samir has a lot of experience in the field of trauma and emergency care. So now I request Samir to take over.
Good evening, sir. At the outset, it is wonderful to be with all of us who are doing this wonderful talk, wonderful technological, excellent thing which has come up. I hope you can see my screen.
No, we can see.
Yes, yeah, we can see you, but not your screen.
Okay, sir. Just a minute.
You have to open your PowerPoint presentation and then go. Yeah, we can see it.
I hope things are going.
You can make it a slideshow.
Yes, sir. Definitely. Is it good now?
Yeah, very good.
Great. Thank you, Subodh sir. Thank you, Dr. Sinu sir. It is wonderful to be with all of you, and I'm humbled by the opportunity given by Trauma 2020 Virtual to me to talk about something which is very interesting, and at the moment it is catching up. People are actually following the litigations. The challenge is that in trauma care, everything is time, and time is the key. We have been talking about golden hour, platinum minutes, and so on. But when you try to do something by the book, it requires time. And that is where people get unsatisfied, and probably then the litigations start. When you see an ambulance jumping a red light, nobody complains about it. But then if you jump a red light, there'll be people who will be pointing fingers. Once the patient is brought by people to our hospital, everything goes fine. But then most of the attendants, they feel that the doctors and the surgeon attending a trauma victim or emergency can do miracles. And that is the time when there is discontent. There is something which is called as unsatisfied customers. But the truth is, the law per se favors the doctors until unless they have committed something very big, something very wrong. So we can talk about the evolution of the law and how it came to be a hurdle in trauma care, or for that matter of fact, medical practices. Or rather, if I would say, the doctors who were seen as gods or demigods started complaining that people are now complaining about our style of working. So if you see, there are two things that are important. There is a hospital and there are doctors, surgeons, nursing staff, paramedics, medics, technicians. And these are the people who are actually working on the patient. And there is something called as the administration, who is also responsible for the infrastructural things that are there. But then if something goes wrong, the administration thinks then we have to find somebody who can be expendable or who can be pointed fingers at. And that is the time when the litigations come. At the moment, the understanding is the legislation, the medical science and the administration are three different fields. For the surgeon and the trauma care persons to understand the things comprehensively, they'll have to bring it all three things together and amalgamate a knowledge of legislation, medical sciences, and administrative skills so that the patient is benefited properly. The Indian judiciary system and medical practices, there were civil jurisdiction, civil courts, consumer protection forums, criminal courts, human rights commission, and medical council. And there are so many other things that are being added up now. But then understanding the medical practice in relation to the Indian judiciary is important for all the practitioners at the moment, especially the people who are working in trauma setups. So there are two types of laws, one which are enacted by the parliament, and the others are the case laws, which have got a decision by the Supreme Court and are subsequently followed by the lower courts, and they're binding on them. And most of our all medical practical laws, medical practice related laws actually fall in this category. So the purpose of law would be to protect one and all without bias, and should be universally applicable and binding, but should have a clear-cut guidelines and limitation. When we are talking to certain judges and certain lawyers, leading lawyers, they say that if we talk about the law regarding the medical practices, it is like finding a perfect wife or husband, which is not going to happen anyway. So you'll have to find a path in between and understand the law for what it is. The Indian Medical Council, way back in the 60s, they gave us so many things: code of medical ethics, patient care relation, patient-physician responsibilities, responsibilities of physician to each other and to the public. They also defined the unethical acts, misconducts, and they also had a sketchy idea about the punishments and the disciplinary action that can be taken against doctors. And that's the time when the courts came in. There is something called as the mandatory clause, which has now come up very nicely. And the people say that the emergency medical condition to the individual has to be offered in any circumstances or to a victim who is brought to the hospital. Now, this has strengthened the trauma care people. Actually, previously they were a bit skeptical about how to approach a trauma victim. But then this clause coming up from high ups from the court, emergency medical conditions are to be treated without fear, without any doubt. The Indian Penal Code defined two things. One was negligence, and they had certain sections about negligence. negligence was again defined into a negligent act. There was a word called as voluntarily hurt that actually brought in certain things. Wrongful confinement and negligent act to spread a disease. These words actually came up, which were defined in different various sections. If I am able to give you an example at the moment, a negligent act likely to spread infection of disease to dangerous to life is also listed in one of the sections. So if I take example from today's scenario, if I am seeing a patient without wearing a mask or protective equipment or a PPE, it amounts to be a negligent act on my side, and thus actually putting the patients in danger. So everything is well defined, but then it has to be followed and inculcated by the practices. The new laws, most of the laws were actually pointing fingers to the doctors, but there is a new law which came out in favor of the doctors. And with the incidences rising of misbehavior to medical persons, doctors, paramedic, nurses, the Supreme Court as well as the whole constitutional system actually defined certain other laws in which the attendants of the patient or other people who actually tend to harm the system of the hospital are to be blamed and to be implicated in different under the different sections. Important law that came up was Consumer Protection Act. As per this, the patients were now treated as consumers, which previously was not very much acceptable by the doctors. But this consumerism thing can actually happen in elective procedures, elective patient-doctor interaction. While as per the law, the patients are now new customers or consumers, but in emergency situation, they cannot be actually categorized as consumers and have to be taken care of by the doctors. Landmark cases, there were so many. And one of the cases said, in case of emergency, the doctor has the full right to decide the mode and the type of treatment that the patient requires, but the doctor should also be aware that should not harm the patient in any manner. Another case law which came from the Supreme Court, which defined or rather distinguished between negligence and deficiency in services, and which was very well taken, because if orthopedic trauma case comes to a private hospital and there is no orthopedician, the responsible person who is taking care of the emergency is going to stabilize the patient and then send the patient or refer the patient to a proper facility. While the deficiency in services is not or cannot be termed as negligence, and this is important for all the medical practitioners, especially working in trauma centers, to understand. The case law from 1989 actually came up with a crux that emergency care is a must and should be provided by all the persons or people working in any kind of emergency situation. They should and must actually advocate the basic first aid and try to stabilize the patient rather than shoving their patients out or closing their doors. So therefore, it is important for every medical person to provide emergency care. This good law, which came as Good Samaritan law, is actually, most of us are very fond of this. This law had seen light from different medical institutions, especially All India Institute of Medical Sciences, New Delhi, where people, a group of doctors, senior fellows, thought until unless the police reaches access inside, the patients or people were not rescued. And there were a good number of grilling things that used to happen to people who had brought the patients. So a good idea came up, the Supreme Court took it in a nice manner. And it was realized that the people who actually bring in patients to trauma centers or emergency setups should not be grilled. They have to be respected, and they have done a wonderful duty to be a good citizen, to bring in a person who is actually in need of medical treatment. Consent for surgery again was a debatable topic, and there was a consent thing which has come up, but then the real consent and the informed consent thing was actually elongated along the consent thing. This has to be understood by most of the people, but the consent actually rarely works in cases where there is a time which is of essence, especially in victims of accidents, especially in emergency situations. And then the court and the law also says that the doctor is a good man and he's probably doing the best in the favor of the patient. Therefore, taking consent in emergency situations is probably not binding. But then if we are taking people to ORs, it is good, always good to take consent. The landmark judgment of Markandeya Kajdu and Justice Singhvi ruled out that the courts and the consumer forums are not experts in medical sciences and must not substitute their own views over their specialist. Now, this was realized by the Supreme Court after a lot of consumer things were coming up in the court of law, and court very, very reluctantly, rather very quickly realized that the bridge of consumer and doctor has to be broken. So they were very kind in saying that the doctor and the specialist medical persons should be respected. Their integrity, their decision has to be accepted by most. So therefore, the law should not be intimidating. It should not let the doctor be so afraid to treat the patients that he himself is just filling the paperwork. But it does not happen that way. Doctor is there, or the emergency person is there to actually help the patient, and it has to be respected by the patient, the attendants, as well as the society. The perfect legislation is still to be found, but then how do we protect ourselves from legal issues? Swiss cheese model, everything, every duty should be overlapped. And if something is missed by me, it can be covered by you. Or if you also miss something, it can be covered by somebody else. So a Swiss cheese model actually reduces the chances of making mistakes or making small petty mistakes, which might actually land you up in court of law. And what we say in medical sciences, do what is written and write what you do. It is a good method to avoid legal issues. In the conclusion, since this is a wonderful conference that has been organized virtually, I took time to devise trauma care laws that can be read as: timing of treatment is most important, replicate what you do, effective domain has to be used. We should have empathy, sympathy with the patient, explain everything to the attendants of the patient. There's not going to be an issue. Use SOPs. SOPs are the standard operating procedures which are there to be used so that people do not land up in court of law. People do not point fingers at doctors. Methodical style of working, affirmative action is always there to protect you. Consent, be advised by the law. If I say that I do not know the law, it does not help me. You'll have to be aware, record whatever you do, empathy to the patients. Every patient is legally liable. Understand this. This is a dictum which has to be understood. Every patient coming to any type of hospital is legally liable. Do all the paperwork, do the best for the patient. Awareness of the law, willingness to do and understand the patient, and following safe practices are going to keep all the trauma care providers at bay from legal issues. Thank you, ladies and gentlemen. And again, I thank the Aztec community to have given me this opportunity to be with you all. Thank you, ladies and gentlemen.
Thank you, Dr. Samir. I think you have done terrific homework. You have really covered the topic really well. And the best part is I liked your last slide. Because see, the law issues all come much later. What we face nowadays routinely is volatile tempers and physical violence right at the place of work. And you have really brought it out, the importance of empathy, professionalism, and ethics. And the most important thing is to do the same thing again and again. Don't try to do something different because a new patient has come. That's what our teacher used to say. If you're operating on a VIP, do the same steps of surgery. Don't make it different. So,
True, sir. True.
So I really thank you. And
Professor Sinu, I will just add a word for Samir. Samir, in addition to being a trauma surgeon and a professor of trauma surgery at KGMU, is also a lawyer. And he did his.
Yeah. That's why I said he has done his homework really well.
Yeah, exactly.
Thank you, Samir. Any questions from anybody? We can take 2 questions. Hello, can you hear me?
Yeah, it's all clear, sir. Any questions are most welcome.
I think we can go on to the next talk.
Yeah, next talk, I request Professor Adarsh Kumar to introduce the next speaker, Dr. Chavi Sani.
Sir, thank you, sir, for giving me this opportunity and to be upgraded as panelist instead of a moderator for the question answer session. Thanks, Stack, for including me as a part of the team. Next speaker, our own Professor Chavi Sahni, who is a professor of anesthesiology and intensive care at Trauma Center. And she has got enormous experience with cadaver and live related donor patients. And she is also the nodal officer of the cadaver transplant program at the Trauma Center AIIMS. So I invite Professor Chavi to give her talk. I think she must have sorted out some technical issues were there. I apologize for being late also because I was also having some technical issues.
Chavi, can you share your screen?
There is a problem.
What's the problem? You are not able to share the screen?
Yeah.
Dr. Samir, have you unshared your screen?
Yeah, I unshared the screen.
Okay, Dr. Chavi, you try now. You open your PowerPoint presentation on the desktop and then share screen.
I think Dr. Chavi has gone offline somehow.
Maybe she wants to log in again. We'll just give her 2 minutes.
Yeah, sure.
It was really enlightening to just catch up with Dr. Samir Mishra for the latter part. I missed your initial part, but it was, as Amit has pointed out, that you are a lawyer also. You have done your LLB degree and has got immense experience. And I could see that these are the topics usually shared by the forensic persons. It's always good to note that some surgeon, trauma surgeon, is sharing his views on this particular the aspect.
Sir, actually, I was taught by the best, and 2 of my teachers, Professor Subodh and Professor Amit, I can see them since you were taught by the best, and that is why you actually come up with good things, sir. Thank you for the compliments, sir. Thank you.
And I
think you should come out with a small monogram, actually, of the very important laws for the residents, which can be included in their blue book, you know.
Yes, sir, true, sir. I'm just going to try that, sir.
And I think recently the government has changed some this relating to Good Samaritan law.
Do we have?
They have specified also something.
So
yes,
do we have Chavi?
Chavi is there.
So can I suggest something that we have recorded a video of Dr. T.K. Manoj, and he could not join, but we have a video. So in the meantime, we can play his video. And we can take the opinion of Dr. Pankaj Singh after the video. He is a neurosurgeon himself. So, and then we can take the talk of Dr. Chavi.
Meanwhile, Subodh, tell Chavi to share slides with the host so that.
Yeah. Okay. I'll do that.
Thank you.
So, can I request Dr. Narendra to share the presentation of Dr. T.K. Manoj?
Sure, sir. I am presenting.
Yeah, please.
Is visible, sir?
Yeah, we can see.
Yes. Right, sir. May I request Dr. Pankaj Singh sir to introduce Dr. T.K. Manoj. Okay, I think sir is somewhere away from the screen. So Dr.
I will do the needful, Dr. Narendra.
Thank you, sir.
Dr. T.K. Manoj is a neurosurgeon. He works at the St. James Hospital, Chalakudi in Kerala, and he's very much interested not only in the actual management, because he's a neurosurgeon, of head injuries, but also an ardent supporter of the concept of trauma surgery. He is a ATLS course director and also ATLS faculty, and has been doing tremendous amount of teaching within the ATLS paradigm. So Naren, you can start his video. He would be speaking on when to get the neurosurgeon involved. That means what are the indications when a trauma surgeon has to sort of call upon a neurosurgeon.
Narendra, you can start.
Naren, have you optimized the video before sharing on the left side? Because the voice is not coming.
I can't see the video also.
Dr. Naren, are you there?
Yes, sir, I am here only. Let me check the video again.
So in the meantime, do we have Dr. Chavi? Do we have Dr. Chavi?
Not right.
No. So virtual virtual MSc.
Dr. Naren, optimize the video and you can play it.
Yes, sir, I am just running. Give me 1 minute.
आप फोन पे रहो मैं अभी आपको बोलूंगा तो वो चला देना पूरा वाला
Are you able to hear, sir?
No, we are only seeing your slide. When to get neurosurgeon involved.
Sir?
Increase the volume.
Yes, sir. Actually, sir, slides are not going. It's like this only video. The slide is remain static and the background sound is there.
It will move. Just forward it.
Amit.
Rising from the scratch on the sky to devastating and life-changing brain injuries. We have learned from our experience that time is life in crime. Time no action can save lives and limbs.
You can.
Stop sharing.
Dr. Narendra, you can stop sharing this because I think some problem with the video. Now we will run Dr. Purva's talk. Dr. Chavi is ready? I think no. So we have one more talk. Dr. Purva Mathur is a professor of lab medicine at Trauma Center AIIMS, New Delhi. So can we have the video of Dr. Purva Mathur?
Good evening, everyone. So in today's time, surgeons have to deal not only with the surgeries, but also with post-surgical complications like sepsis, antibiotics, and antimicrobial resistant. We know that sepsis is a major growing global burden and a major challenge to intensive care clinicians, researchers, guideline committee members, and policymakers. This is because of the high and increasing incidence and great pathophysiological, molecular, genetic, and clinical complexity of sepsis. Sepsis has high short-term mortality, and there is also growing evidence of long-term morbidity and increased long-term mortality in survivors of sepsis both in developed and developing countries. Further improvement in the care of patients with sepsis will actually impact upon global health in a very, very large manner. So we know that post-operative sepsis, which the surgeons have to deal with, is a leading cause of in-hospital mortality. According to the US CDC, 1 in 25 patients experience at least one healthcare associated infections during the hospitalization period. Patients who are admitted with one or who develop sepsis in hospital have an increased risk of death following hospital discharge. So this is a very important factor, that not only during hospitalization but even after hospitalized, the patient is discharged from the hospital, the risk of mortality remains high. Such sepsis associated risk of death is higher than in general population and remains high for up to 5 years following hospital discharge. In one of the last studies, it was found that 43% of severe sepsis survivors were rehospitalized within 90 days, incurring higher costs, especially in the first year after hospital discharge. Because of all these factors, post-operative sepsis has been proposed as a key patient safety indicator, aiming to monitor potentially preventable surgical complications amongst elective surgical patients. This indication was developed after a comprehensive literature review, analysis of ICD-9 CM codes, review by an expert panel, implementation of risk adjustment, and performing empirical analysis. It has been widely used to measure aspects of patient safety and quality and to monitor the impact of quality improvement initiative. So this was one of the largest studies on post-operative sepsis, which was published in 2018, in which more than 144,000 survivors to discharge were followed up. Of these, 1.3% patients had experienced some kind of post-operative sepsis. It was found that their post-discharge mortality rates at day 30, 60, 90, and 1 year were significant patients who did not develop sepsis. Elective surgical patients, post-operative sepsis was independently associated with increased post-discharge mortality up to a year after hospital discharge. This risk was particularly high in the first month, in older age patients, and in the presence of severe or very severe comorbidities. So these are the high-risk patients who can be targeted for intervention in order to reduce post-operative sepsis. So when we see how important sepsis is in terms of duration of stay, morbidity, and mortality, it is very imperative that diagnostics need to be augmented so that early diagnosis of sepsis can be done. So new development in microbiology and biomarkers may shorten the microbiological time to diagnosis and identification of the antimicrobial resistance pattern of the infecting bugs. They should optimize the treatment of infection in critically ill patients also. So recent developments include various molecular techniques using nucleic acid testing and identification by various methods such as ELISA-based hybridization, fluorescence-based real-time detection, liquid or solid phase microarray detection, sequencing, and database recognition. One of the very important innovations in the recent times has been the MALDI-TOF systems, which enable identification of isolated colonies of bacteria and fungi from culture in less than 1 hour. And this has been very usefully and successfully being used in many hospitals to communicate a very rapid report of pathogens which have been identified and isolated in cultures. The other important development have been use of multiplex NAT-based platform for identification of pathogens. So Identification of microbes and their resistance can be done now directly from the sample. So it actually reduces by almost 48 hours the time to report to the clinicians, and it helps in early treatment of these patients. So there can be single or multiplex panels for detection of a wide range of respiratory, gastrointestinal and central nervous system pathogens, which can be bacteria, fungal, viral or microbacterial tuberculosis. We have skin and soft tissue panels now, which when directly applied to tissue specimens like bone, muscle, fascia, synovial fluid, they can be used for early diagnosis of a number of pathogens, and the antimicrobial resistance can be ascertained from the sample directly. We also have panels for Mycobacterium tuberculosis and the AMR genes of Mycobacterium tuberculosis, and a couple of diagnostic assays are available for rapid detection of fungal infections, which target either the cell walls or the Galactomannan of Aspergillus. And now we also have immunochromatography based lateral flow, which are point of care devices for diagnostic fungal infections. Having said that, in recent times, a lot of emphasis is being given to biomarkers, which are kind of surrogate markers for sepsis, which are kind of very rapid and point of care tests to help in early initiation or de-escalation of antimicrobials. So several biomarker guided antibiotic treatment strategy trials in sepsis have been published, which have been mostly based on PCT. So in the ProRata trials, in which 621 patients were enrolled, a PCT guided treatment strategy decreased the duration of an antibiotic course among ICU patients with suspected bacterial infections. But a firm conclusion could not be reached in that study and in several other studies due to insufficient power of clinically relevant differences in mortality and low adherence to the treatment. It's also very important to discriminate or distinguish whether the patient is having sepsis, is there an infection, is there a severe inflammatory syndrome, or is there a cytokine storm, because all of them present similarly, but the treatment are very different, whether to give anti-inflammatory agents or anti-infective agents or to down-regulate the immune response. So the syndromes for which we use antibiotics are insensitive and often non-specific. This is especially true for VAP, but also occurs in other patient populations where infection is difficult to differentiate from non-infectious inflammation. While PCT may be helpful in limiting the duration of antibiotic therapy, we need a better biomarker of infection in the presence of inflammatory response. So it may not always be infection. And in trauma patients, we did a comprehensive study on the profile of CD4 helper lymphocytes, associated biomarkers, and procalcitonin in the prognostication of severely traumatized patients with sepsis. In this study, we enrolled 50 polytrauma patients with sepsis and 50 controls. And we collected peripheral blood samples at sequential time points to understand the profile of CD4 T helper cells and various cytokines. Using multicolored flow cytometry, we studied a range of CD4 cells like Th1, Th2, Th9, Th17, Th22, and T regulatory cells, and we also assessed the profile of 14 serum cytokines, which included interferon gamma, TNF alpha, IL-2, 4, 5, 6, 9, 10, 13, 17, 21, 22, and TGF beta. Apart from that, we also estimated the levels of serum procalcitonin, and we ascertained how these cytokines behaved with clinical progression and clinical outcome. We found that of the 50 patients, 25 were microbiologically cured and 40% had a fatal outcome. Majority of these patients were males and developed sepsis almost 12 days post-trauma. The percentages of Th9, T regulatory and Th3 cells were higher in patients than controls, and a very high and persistent serum PCT may be used as an indicator of poor prognosis. By the day of discharge, the level of CD4 T helper cells and the biomarkers were almost comparable to those in healthy control. So we did find that there was a lot of dysregulated immune response in post-trauma patients, which must be also happening post-surgery. So this is in the microbiologically cured polytrauma patients, the T helper lymphocyte profile and the serum cytokine profile in those who were cured compared to those who had a fatal outcome. So we find that there was a lot of difference in several different subtypes of T helper cells and various cytokines, which could be used as prognostic markers in the mid phase, which are the purple blocks, and in the late phase. We also actually did a huge study on surgical site infections in trauma patients, in which a total of 850 patients were enrolled in our SSI surveillance from June 2018 to December 2019. And this was unique in the terms that we did this post-operative surveillance till day 90 after the patient was discharged from the hospital. So of these, 70% patients were male, and patients in the age group of 30 to 49 constituted 36% of enrolled patients. The median stay of all patients was aged 8 days. A total of 47 patients developed surgical site infection, giving the average prevalence as 5.5%. And the median length of stay of patients who developed SSI was significantly higher. 34% of the patients who were diagnosed were detected during the hospital stay, but remarkably 66% were diagnosed during their post-discharge period. So if we do not include that period, we'll miss out a lot of post-surgical infections. 10.6% patient had wound dehiscence, 42% underwent repeat surgery, and 57% needed only wound. So a total of 50 microbes were isolated from these patients. Staph aureus was the most common isolate, and we found a very high level of antimicrobial resistance in these patients. Then what about antibiotics? If infection and sepsis is so important, how about antibiotics? So currently, the best guess empiric therapy is commenced to cover the likely pathogens, including resistance patterns and switching or de-escalating once identification and sensitivities have been obtained. So the balance between benefit and harm of any antibiotic should always be considered. Long courses of antibiotics have no benefit and can predispose to overgrowth of resistant organisms over normal resistant commensal flora. So it's preferable to have culture sensitivity based treatment. Broad spectrum antibiotics we know can cause collateral damage, including overgrowth of potentially pathogenic bowel flora, and the gut microbiome can change permanently within days and cause these bacteria to become resistant. So we know that there are no new classes of antibiotics in the pipeline. However, we have several new combinations of beta-lactam, beta-lactamases like ceftolozane, tazobactam, ceftazidime, avibactam, and ceftoline, avibactam. We also have a new aminoglycoside, that is plazomicin, which is very good for gram-negative organism. Apart from that, we have novel treatment mechanisms like monoclonal antibodies, peptides, and fast therapies, which are being investigated. But what is to be used is that whatever is available must be used in rational and cautious manner. Some hospitals use inhaled antibiotics for pulmonary infection, which is questionable, but it's a logical approach which can be tried. How about antibiotics in trauma patients? According to the International Committee of the Red Cross, proper use of antibiotics is to be based on different types of injuries. So for extremity wounds, it is good to use cefazolin, which is a first generation cephalosporin. For thoracic wound, again a first generation cephalosporin. If there is penetrating chest injury with esophageal disruption, metronidazole may be added. In abdominal wound, cefazolin with metronidazole is recommended. For maxillofacial and neck wound, again cefazolin. If there is a CNS wound, you can use first generation cephalosporin, and if there is contamination and abdominal cavity is involved, metronidazole may be added. And for penetrating eye wound, levofloxacin is advisable. So what are the principles of prophylactic antibiotics in trauma, and for that matter any prolonged surgery? The most important is the time of administration. Because the amount of bacteria increases exponentially from the time of trauma, 6 hours appears to be a vital period after wound contamination. We can extend the time of antibiotic treatment if there is an unavoidable delay in administering antibiotics when the wound is open. And first, it has been found that first generation cephalosporins, if not administered within 6 hours in pre-hospital, uncomplicated soft tissue grade 1 wounds, it actually increases the risk of infection. Coming to the choice of antibiotics, immediate treatment with broad spectrum intravenous antibiotics should be given in patients with open fractures or extensive soft tissue loss. High dose IV third generation cephalosporin rather than oral first generation drugs are effective in patients with open fracture. The incidence of wound infections in patients with fresh traumatic wounds or lacerations is low after the administration of coamoxiclav, that is augmentin. Cefazolin or vancomycin should be used if the patient cefoxitin or clindamycin and gentamicin antibiotics is bound in 24 hours after wound closure. Patients with penetrating abdominal trauma and concomitant thoracolumbar or sacral fractures receiving prophylactic antibiotics for less than 48 hours actually do not develop spinal infection. So there's no need to worry on that. The routes of antibiotic administrations can be either oral, it can be IV for infections, and there are several devices applied in minor uncomplicated soft tissue. So we know about the Surviving Sepsis campaign, and the guidelines keep modifying, but the main focus of these guidelines really identifies the time frame in which antibiotic treatment has to be initiated has been shortened. And our to initiate as patients affected of sepsis. So what are the ill effects of overuse of antibiotics? Limiting the time to perform a diagnostic was actually encouraged overuse of antibiotics. So this was a study in Netherlands which showed that up to 43% of patients admitted to ICUs because of sepsis were actually unlikely to even have an infection. Another study showed that 29% of patients who were diagnosed with sepsis and received antibiotics in the ED were unlikely to have an underlying bacterial infection. This unnecessary use of antibiotics can have many negative effects: increased rates of C. difficile infections, organ injury, and a disruption of the gut microbiome. On a population level, overuse of antibiotics can increase antibiotic resistance, leading to a further acceleration of this global crisis. Also, it is able to solve. So, is there an evidence for early administration of antibiotics? In 2018, the first and only randomized trial on the subject of early antibiotics for sepsis was conducted. This is the pre-hospital antibiotics against sepsis, which is the FANTASY trial. It evaluated the effects of administration of antibiotics to patients with sepsis in the ambulance rather than in the ED. For this, the emergency medical to recognize patients with sepsis. Patients were randomized to receive either usual supportive care or a dose of 2000 milligrams ceftriaxone in addition to care. The usual group received their first dose of antibiotics resulted in a different time to antibiotic 90 minutes between the intervention and usual care groups. The only difference was the 28-day readmission period, which was in a trial, a short course of prophylactic antibiotic treatment for prevention of post-op infections in clean orthopedic surgeries at our center. We enrolled 197 patients, of which 4 developed surgical site infections. 3 were caused by MRSA and 1 was caused by Acinetobacter baumannii. Of these 4 patients, 2 were in group 1, which was the short course perioperative antimicrobial prophylaxis, and 2 were in group 2, which was the conventional long course treatment. Short course treatment was rupees 150 per patient as compared to 1900 per patient for conventional regimen. We found that there was no significant difference in rates of SSI amongst the 2 groups in our study. Therefore, implementation of a short course perioperative will go a very long way in reducing AMR cost and adverse reaction. Finally, we can talk any length about antibiotics, but antibiotics are not a panacea for bad practices, and that is why infection.
So now I request Professor Adarsh to invite the next speaker.
Yeah. I invite Dr. Chavi Sani and request Dr. Narendra to please give the host command to Dr. Chavi, please, who will be our next speaker. Dr. Chavi is a professor of anesthesiology and intensive care at the Trauma Center AIIMS, and she has got enormous experience of working with cadaver and live-related donor patients, and she is in fact the nodal officer of the cadaver transplant program of the Trauma Center. Dr. Chavi Sani, please.
हमेशा गड़बड़ होती है क्या करूं
Share a screen hoga, I think. Yes, now you can, because Narendra has given you the command.
Ma'am, there is a green box.
Yes.
I pressed that. Desktop one, whiteboard, iPhone. These are the options I'm getting.
Ma'am,
so you have to first open your presentation, yes. Chavi. You have to first open your presentation in the desktop, and then when you will press the green button, you will see your presentation. Then click on your presentation.
Yeah.
The
you will see many windows.
Dr. Subodh, the presentation is open. I press.
You press the green button.
Green button, share screen.
And then you will see many windows.
Yeah.
So out of all the windows, you see your presentation and click on the presentation.
Share.
Actually, there'll be a small icon actually.
Good evening, sir. I can see desktop one, whiteboard, many options are there. I've opened my presentation. I press share screen. Now there are many options, desktop one, whiteboard, share.
So have you opened your presentation and minimized, or it's open?
My presentation is open.
And it's not visible in the windows?
No, it does not.
Achha, never mind. So I'll request if you can speak without slides on this topic. Yeah, I think you can very well speak without slides.
All right.
Yeah.
Good evening. I'll be talking about cadaver organ donation in India, the issues and solutions. So if we talk about the timeline of organ donation and transplantation in India, so it was initially that the first organ transplantation was done in 1965. And after that, it was negligible. The organ donation and transplantation rate was negligible. And it was in 1994. Transplantation of Human Organ and Tissue Act was enacted. Yeah. This is I can see yeah, but how to open it? I'm sorry. Amended in 2009 and 2011. And the National Organ Registry was started in 2005, followed by the formation of NOTO, that is National Organ and Tissue Transplant Organization in 2011, after which there was an increase in the organ donation rate. And it increased from 2011 to 2017. There was around 3 times increase. But still it is quite low, as presently the deceased organ donation rate in India is 0.34, which is quite less as compared to the developed countries. Is it visible now?
Yes, it's visible. Please
Now it
continue.
is visible.
Make it a slideshow.
Yes, sir.
On the top, you will have slideshow. Yes.
Yes, just click
Yeah,
on.
just press on the slideshow.
Double click.
Just go on to the slideshow.
Yes, sir.
No,
Yeah.
Yes, it will come.
Okay. Yeah. Now we can see.
Thank you, sir. So, so I talked about the first kidney transplant in 1961, followed by the Transplantation of Human Organ and Tissues Act. Then the Indian Network for Organ Sharing in 2000, followed by National Organ Registry in 2005. Then NOTO was established in 2011, which acts as an apex body for procurement, allotment, and distribution of organs. And recently in 2019, the National Organ Transplant Program was implemented by the Ministry of Health and Family Welfare. Now, if we look at the transplant scenario, we can see it's very low till about 2011, after which there has been a consistent increase up to 2017, around 3 times increase, but it is quite low, still 0.34 per million population, as compared to Spain, which has a rate of around 35, US 26. Now, this shows us the states which have deceased organ donation activity, and there are just 13 states which are performing these deceased organ donation. And recently, Odisha and Calcutta have started. And Chandigarh is one of the center which is doing these procedures, donation after cardiac death also. Now, this geographic distribution or this mismatch is because of many reasons. It can be because of lack of access to health care system, or the states which have an organ donation system present for a longer time, and then literacy rate. These are some factors which attribute to these difference in the organ donation rate in various states. So this brings us to the challenges. We have some systemic issues, socio-cultural issues, and organizational issues. Now, coming to the systemic or legal issues. Now, actually, brainstem death should be delinked from organ donation. Brainstem death is identified as a cause of death, as a type of death only in the Transplant Act, but not in the Registration of Births and Deaths Act. So that becomes an ethical dilemma for the intensivist who is managing the patient. Again, the robustness of tests for brainstem death has been questioned in Kerala High Court. Recently, the test should be videographed, which infringes on the patient's privacy. Again, the donor pledge form, which is quite valid and elaborate, but there is no legal status of the form. The patient's attendants, the relatives have to sign for the organ donation, despite the donor pledge form present. Then the hierarchy for donor consent is also not present, is not defined as of now. So these are some of the issues. Then again, the delay in organ procurement, transport, and handing over the body can also have a negative impact on organ donation and transplantation, because the certain families, we have a time frame in which the burial and the last rites have to be performed. So this acts as a negative influence. Then again, if we come to the organizational support, lack of adequate number of transplant centers in the country with adequate manpower, transplant coordinators, lack of infrastructure, well-equipped ICUs, good dialysis programs, and then standard protocol for donor management are not present in all the setups. And then there can be a conflict of interest among the stakeholders. So these are some of the challenges. But in our center, we have good infrastructure, trained manpower, and we have the donor management protocol in situ. But despite that, if you look at our conversion rates, they are quite less. Maximum up to 12.5, or in 2017, once it was 28%, the conversion rate. So there are other issues also, other than the organizational and systemic issues. These are the socio-cultural factors. And this was a study, there was a study which was performed in All India Institute of Medical Sciences 2016, where they looked at where they studied the attitude of the lay public from North India, and just to study why we are poor organ donors. And it was found that lack of awareness was the single most common cause in 80% patients, followed by religious beliefs, superstitions in 63%, lack of trust in 40%. And literacy rate also plays a very big role. Now, awareness needs to be tackled at all the levels, whether it is community-based awareness, public or patient awareness, hospital-based awareness, where we take care of the patients as well as the healthcare professionals that also need to be the organ donation and transplantation. So various social media can be used for increasing the awareness, but social media has both positive as well as the negative effect. And then again, celebrity endorsement can also be used for improving the awareness. Awareness programs can be conducted at schools, theaters, hospitals. We in our center are conducting weekly awareness programs in our waiting areas for the organ donation and transplant purpose. Then theaters, street plays, again involvement of relievers. The transplant coordination counseling is required to increase the organ donation rate in our center. Now, this was a study performed in which the authors studied the strategies to improve the donation, and it was found that if the patient is aware and familiar with the organ donation and transplant activities, it has a positive correlation with the attitude parameters. Now, where we can intervene include the health education, improvement in doctor-patient relationship, and conducive legal legislative measures. Now, health education, we can educate the children who can further talk to their family members, who can further impart education. Second, we can also educate the healthcare professionals like the transplant coordinators, the doctors. Only then they will be able to allay the fears or apprehensions of the patients. This can be performed only by well-informed healthcare providers. And then again, we can use the eminent persons in the society like the imams and the Muslims, who can educate or who can inform the other members of the society. And this would improve the doctor-patient relationship or counseling or better such as conducive legislature can help where there is a lack of support in the family for legal transplantation or donation. And now all this we can do by conducting various workshops, CMEs, and moreover, it can also be included in the curriculum because many healthcare professionals and even our graduates are unaware about this process, about the organ donation, transplant programs, and it has already been included in the undergraduate curriculum in 2018. Then another fact, and the brain death declaration has been made mandatory, and discussion about organ donation has been included in end-of-life care. Then training of transplant coordinator and intensivist is being carried out by conducting various workshops, CMEs regularly by NOTO and other organizations as well. Even ORBO that we have at AIIMS are conducting these workshops. Then infrastructure and organizational support. So green corridors, which are required for the transport of the organs, are being these days we have a lot of green transports, green corridors prepared. These are the special road routes. Quickly the street signals are changed manually, and then the traffic is diverted. And this was initially done in Chennai, but now this is done regularly to improve the transportation of the organs. Then further, we need to have greater transparency. We need to take steps to prevent and control organ trading. Now, organ donation and transplant is a byproduct of good trauma and intensive care. So we need to identify the potential donors from the very beginning. We need to widen the donor spectrum by using expanded donor criteria. A higher age group can be taken with comorbidities, but that means better brain donor management of the geriatric population. Now, last but not the least is the opt-out system instead of opt-in system, which is a very controversial system. Actually, in India, we have the opt-in system. That is, you have to give a consent. We have a very high donation rate. We have an opt-out unless and until the donor gives it in writing. So that is a controversy, whether this system is suited for our country, where we have a high illiteracy rate. Now, recently, regarding COVID-19 and organ transplantation, we have to assess the risk-benefit ratio. Unless and until we find that the patient cannot wait or he'll die for lack of transplant, we should avoid surgery as far as possible. And detailed assessment of epidemiology, current trends, surge capacity, impact of COVID-19, as well as the availability of infrastructure should be looked into before going ahead with transplant in this scenario. And then safety of healthcare workers, prevention of transmission of infection from patient to healthcare workers, as well as PPE, universal precaution to account. Prevention of cross-infection from transplant patient to other patients. So it is going to be a slow process, and we have to do it in incremental ways. Thank you.
Thank you very much, Dr. Chavi. I request you to please stop the screen sharing. A quick comment in the interest of time, a quick comment from Dr. Adarsh and then from Professor Sinu. A quick comment and then we'll close the session. Dr. Adarsh, please.
Yeah. Thanks, Dr. Chavi, for nicely elucidating this concept of organ transplant and the way we have progressed from 94 to this to 2020. Yes, there are so many changes in the legislation. Just one comment about the brain death, as you pointed out. But now probably, as far as legal status is concerned, all the brain stem death, when we certify at the first stage, for all legal purpose, that is taken as dead. Right. So for birth and death registration, there is not a problem. The first time of death that can be mentioned as the time of death when we talk about the birth and death registration in India. That's the recent change. Probably I just wanted to just bring it to the knowledge of all. And of course, the opt-out system, what we are just thinking for so many years, we have done many efforts. Even for the cornea donation, we have done many efforts to improve. Somehow we have managed to improve that, but organ transplant, again, I think it's basically the awareness and all, which you have very nicely touched upon and elaborated. I think that will go a long way in improving our organ donation program of our country. Thanks, Dr. Chavi.
Yeah, thank you, Dr. Adarsh. And I don't see any question in the chat box. And last comment from Professor Sinu.
Yeah, thank you, Dr. Chavi. Very nice presentation. In the short time you covered it well. As you said, the important thing is the number of trauma deaths and the number of transplants, the conversion rate. I think we have to focus on that.
Yes, sir.
Involve more of the media and the society and all.
Yes.
Thank you very much. It was a nice.
Thank you, sir.
Thank you very much. And on behalf of the Trauma 2020 team, I thank all the chairpersons, the speakers of this session, and I close this session. Thank you very much. And I hand over to Dr. Amit Gupta for the next special session.
Thank you, Dr. Subodh.
Thank you so much. We would begin. I have already upgraded. Professor Mattox is here. Professor Mishra is about to come to the panelists. Hello, Professor Mattox. Welcome. We'll have a quick tech check with your presentation, and then we'll formally begin the session. We'll have a countdown from the organizers, 5, 4, 3, 2, 1, and then we go live in the hall. Can you just quickly?
Yes, 5, 4, 3, 2, 1.
Yeah, not right now.
Oh, okay.
Yeah. So just share your presentation so that we're sure that you're able to share the presentation. The slideshow? Yeah, the slideshow.
Yes.
Great, great. We are getting it. I'm stopping it.
I am getting it.
Yeah. So,
sir, are we ready?
Yeah, Shubhang, we are still on the hall.
Sir, no, sir. That presentation is going on. I'm just sending you the screenshot.
Okay. Anyway, so we will begin the session very shortly, and you can pin up as I had told you. Professor Mattox, I am shutting your presentation down so that we can introduce you formally, and then I'll ask you, when I ask you to share the presentation, kindly start the presentation then.
Okay.
Is the tech team there? Shubhang, are you there?
Sir, that the thing which we have discussed, the provision is of only one person to pin.
So no, when the this thing is going on, the discussion at that time.
Do you want a grid view, sir?
A grid view.
Done, sir. Done. Sure.
And those who have been mentioned.
Yes, sir. We have the details.
Okay.
The only thing is they have to switch on their videos first.
They're all
done, sir. On discuss, we'll switch into pin as in grid view. With the set name, sir. Not an issue.
Okay. Just prompt us when to go.
We are ready whenever you say we can go.
Okay.
You can start countdown from 3, 2, 1.
So I'm starting.
Yes, sir.
Dear delegates, welcome to this very special session of ISTAC conference. This is the final or the grand finale of the conference this year, the Trauma 2020 virtual. And I have the pleasure of actually introducing and inviting our session speaker, Professor Kenneth L. Mattox. Well, Professor Mattox actually does not need any introduction, but still it is my formal duty to introduce him to the delegates and to everybody here. Professor Kenneth Mattox is a distinguished service professor at the Baylor College of Medicine and Chief of Staff and Surgeon-in-Chief at the Ben-Taub Hospital, where he has worked since 1973. Born in 1938, Professor Mattox earned his undergraduate degree from Wayland College in Plainview, Texas, and medical degree from the Baylor College of Medicine. Dr. Mattox helped develop the internationally renowned Ben-Taub Hospital Emergency Center and its equally respected trauma center. Dr. Mattox is past president of the American Association of Surgery of Trauma and the secretary-treasurer of the Michael E. DeBakey International Surgical Society. Dr. Mattox serves as a consultant to the Center for Biologic Evaluation and Research of the FDA. He has also served on the boards of directors of many institutions and societies like the American Association for Surgery of Trauma, the Southeast Texas Trauma Regional Advisory Council, the American College of Surgeons Board of Governors, the Rotary Club of Houston, the Doctors Club of Houston, Wayland Baptist University, many more. He serves as the chairman of board of the John P. McGovern Museum for Health and Medical Science. He is a reputed innovator in trauma care and is known worldwide. He is the author and editor-in-chief of the Bible of Trauma. We all have learned as trauma surgeons Trauma. And the first edition of this textbook actually came more than 3 decades back, and it's the 9th edition right now, which is an Kindle edition, the electronic edition of the trauma book. He has also authored Top Knife, which is again a must read for all trauma surgeons and general surgeons interested in trauma. For the past 47 years, he has organized the trauma conference on trauma, critical care, and acute care surgery at the Caesar Palace Casino in Las Vegas. It's also favoritely known as the Las Vegas Trauma Conference. And it attracts more than 1,000 surgeons from all over the world every year. So I introduce to you a trauma surgeon, a teacher, a mentor, a writer, innovator, and a motivator. In effect, a man on the mission always. Professor Kenneth Mattox, the stage is yours.
Thank you so very much for that very gracious introduction. I am very grateful. I am most grateful for the friendship of all that are on this electronic conference. We are now in a whole new era where we're able to do things that we were not able to do before. I would like this talk is going to focus on change that has occurred and where we are now, where we are going in the future. Historically, as I have looked back at the past, surgeons have led the way in creating a better way for complex medical problems, whatever they may be. And this conference has underscored the leadership role of surgeons in India and what you have done to this point in time. It should not go unnoticed that the father of surgery is from India, going back to the period of 1500 BC. Each of you who are part of this conference have part of Shashruk's genome and part of his vision and continuance. And it is the changing time that brings us together for the morphing of surgery. Some of that morphing has been created externally because of changes. Some of it is occurring internal. I have nothing to declare. I come to you from the Houston, Texas, the Texas Medical Center, and this is a complex of many hospitals, two medical schools, a number of nursing schools, and the Ben Taub Hospital is seen in the southwest corner as part of this Texas Medical Center and one of its 2 trauma centers. Change is always with us. Change can occur gradually, and those changes I am calling morphing. The morphing of surgery is a continuing evolution of the surgical artisan. Where did we start? Where were we in 1960 and where are we now? And where are we going to be in the future? And what are we going to call ourselves? I chose 1960 because that was the year I started medical school in the Texas Medical Center. First, what is surgery? Surgery is a unique way of problem solving that sometimes involves an operation. It is a diagnosis of a problem, a desire to create a solution, embark on a correction of that problem, checking on the exactness of the solution with loop closure at the end. I will repeat this theme several times. What is a surgeon? A surgeon first is a lady or a gentleman, recognizing how to smell a fine perfume, what year good wines were made, how to recognize fine music, perhaps playing a musical instrument, being involved in the community, having a faith of some sort and a religion and a belief in other beings, a lady or a gentleman. Second, a surgeon is an excellent bedside doctor, knowing the art of medicine, knowing empathy, understanding the family needs. Third, The surgeon is a superb internist and diagnostician, knowing more about digitalis than the cardiologist, knowing more about antibiotics than the infectious disease, knowing more about fluid and electrolyte balance than the metabolic internist. Fourth, a surgeon knows more about anatomy than any other person in medicine, except perhaps a teacher of anatomy. The surgeon understands technology and actually likes to play with the widgets. A surgeon is technically adept. There is no place in surgery for an individual who is all thumbs. A surgeon continues to improve his or her craft and is dedicated to lifelong learning and is a community leader. If you look at this list of what is a surgeon, it describes many of you. It provides the opportunity to say, where are we now? What are the needs now in the world? What are the needs in India? What are the needs in your community? What are the needs in your city? What are the needs in your hospital? This year, we have all struggled with COVID-19, and that's part of our craft as a surgeon. The characteristics of a surgeon are that they are a leader. Every parade has to have someone at the beginning. The surgeon is aware of, has situational awareness. As they walk into the room, they know, is this a crisis? Is this an elective? Do we have time? And I noticed that kind of leadership as I was favorably observing your virtual conference. And I even took a number of notes. The surgeon has data to assess the present treatment. Probably 85% of what we have done historically, even the last 20, 30 years in medicine, is based upon dogma, and the surgeon looks for data, not emotion. Surgeon is an innovator, developing new operations, new approaches, new applications of technology, recognizes opportunities and abandons old dogma. If you left this lecture right now, what I would like to leave with you is that there is no time in the history of medicine, no time in the history of man that has had more opportunities for surgeons and physicians to impact a change. And the rest of my talk is going to be focused on some of the need for that change. This is a trauma conference. What is trauma? Trauma is physical injury, including burns, industrial accidents, motor vehicle crashes, and India is one of the major countries of the world in leading in motor vehicle crash deaths. Interpersonal violence, disaster effects, wars and conflicts, and then drug cartels and terrorist damage that affects society. All of these then now challenge the individual who calls himself a trauma surgeon or by other similar name. How did we get here where we are now? Looking back at history, there are many shamans, many surgeons, many of them from the Middle East, many of them from the war zones, who have contributed to the art, science of trauma, critical care, and acute care surgery. I am using the word TCC-ACS to describe the morph position we have moved from general surgery. In 1922, in the American College of Surgeons, Charles Scudder brought 22 surgeons together and formed the Committee on Fractures, and which has morphed into the Committee on Trauma of the American College of Surgeons, and written many of the documents that lead in the care of the injured patient. This was only 9 years after the American College of Surgeons was formed. What did not exist when I started 1956 in pre-med, 1960 starting in medical school? This next slide was very unusual for me as I put it together for EMS, emergency medicine, ICUs, plastics, spring clamps, CT scans, thoracic surgery, vascular surgery, surgical critical care, Swan-Ganz catheters, volume ventilators, air ambulance, trauma centers, computers, workplace on wheels, the internet, cephalosporins, critical care, ECMO, space travel, and drones did not exist. So during my lifetime, I have witnessed many of the things that you talked about in this wonderful conference that you put on today. Injury is a major public health issue in Houston, in New Delhi, in India, all over the world. Every country worldwide, it's a public health issue. Potential years of life loss is the leading cause of death and health issue for all ages. Not cancer, not heart disease, not stroke, not infectious disease, but injury. It affects the individuals in a society who are the young and are the workers and has a tremendous economic impact. We often do not talk about trauma because we don't have a system to approach it. We all can improve where we are now. There is always, always a better way. The greatest health risk to society is trauma, greater than cancer, heart disease, atherosclerosis, pneumonia, renal failure, cosmetic surgery, and the like. It was the first regional systems public health approach, the approach to trauma, and it still can be built upon. And it's more important than those other areas. What is the trauma surgeon? The trauma surgeon literally, although there are trauma surgeons and surgeons who have been interested in trauma throughout history, is a relatively recent development. It describes a special physician who takes care of the acute care surgical problems, does emergency surgery often in the middle of the night, often which is not trauma. The trauma surgeon was doing critical care long before the medical intensivists developed, managed the early bird respirators, the ultimate volume ventilators, became a surgical hospitalist, was the individual in most communities that was the disaster responder and disaster coordinator, and is the physician that governments look to when there is a military challenge. This has described the general surgeon throughout history. And during the 1970s, 1980s, led by the American College of Surgeons, the word trauma surgeon developed to describe this individual that does all of these things. If you look at this list, there probably is a better descriptor to describe what the trauma surgeon does any day or night that they happen to be on call. It is more than the ATLS course. Curriculums have been developed for each of these areas together. There are even now fellowships in critical care surgery and in acute care surgery. What an individual institution calls this individual is up to them, but the genome of this individual goes all the way back to the founder of surgery from India. The American College of Surgeons described the trauma program that would exist with this leadership and at the hospital level. It's the definition of issues and problems. Construct a organization both professionally and describe an organization at the country level, the city level, the hospital level, and integrated together in a established network and system. Much as the Rotary Club is an international organization that has a network together, the trauma program is such a system with a number of components. It is a recognized discipline, whether or not we use the word trauma, acute care surgery, critical care surgery, it has those skills. It is able to be verified and certified. The American College of Surgeons has a program of verifying level 1, 2, and 3 trauma centers. And many countries have developed a similar system for the governmental authority to recognize and then to check to see that they comply with these criteria. A database is created, and that database is shared with the medical leaders, and then a educational and research program becomes part of this quality loop closure to assure that the public is better served. It's like a board of a major corporation. If you look at this outline, whether it be Xerox, whether it be Apple, whether it be United Airlines, a company uses this kind of approach to produce a product which then serves mankind. This has been summarized in a document by the College of Surgeons Committee on Trauma, and much of what I am talking to you about is in this document, and the components of the current ACS Committee on Trauma programs can be put into a grid for pre-hospital, verification, research, young surgeons, acute care surgery, surgical critical care, rehabilitation, forensic prevention, outreach, special projects. Quite honestly, that's what you put together for your virtual program that you've had the last several hours and the last couple of days. This also involves rural, teleconsultation, ATLS, advocacy, education, pediatrics, and even data registries, military and international. That trauma center can be one of multiple levels. My state, Texas, has developed a level 4 in addition to the 3. Level 1 and 2 especially receive big, bad trauma from the region. Networking with those hospitals that are not part of a trauma program to improve both communications and to improve the outcome of those patients, surgical patients with complex problems. It is extremely cost effective. It does save lives. It reduces complications, decreases length of stay. There should be one level 1 trauma center for about every million population. And once a trauma network is in place, it affects all aspects of the hospital care, from the laboratory to the imaging, even to psychiatry and to pediatrics. There have been recent changes in medicine, surgery, education. The Accrediting Council for Graduate Medical Education during the 1990s till now have increased regulations. They have altered resident work hours. They have mandated certain rest. They have created attitude changes. And this then prompted departments and individuals to change the way they think. When I was a resident, I had 3 rotations where I went into the hospital for 3 months, never leaving the hospital, never going home. and often spending the entire week without any sleep. You cannot do that today. You just cannot do that today. And that has caused us to create silos of care initially. That is, we had a surgical intensive care unit, we had the emergency department, we had the operating room, we had the orthopedic department, we had urology, we had plastic surgery, we had neurosurgery, and we had general surgery. And so those changes that have occurred at the national level caused us to begin to create new terminology, and that then required new training programs. So some of these areas of change in this period of time, I've already stated: new specialties. We had to have faculty in-house. Quality metrics were developed by reviewing agencies. Less independence for the training resident. Clinical practice guidelines that sometimes were good, sometimes were based upon no data, but then became a cookbook that we had to follow. And some of those were listed in some of the lectures which were given to you. Order sets were created that were pulled down from a menu on an electronic medical record, so that the resident, even the faculty, even consultants had to abide by those prescribed artificial intelligence driven order sets. Did it improve care? We didn't really ask those questions. We followed the rules. And even today, we follow those rules and practice guidelines, often to the detriment of the patient. I talked earlier about dogma. If you look at the East practice guidelines, military practice guidelines, the hospital practice guidelines, we find that almost 85% of them do not ever alter decision-making. Just as an example, the laboratory tests done in the emergency room and the CT scans that are done at will, probably 95%, never ever, according to the notes in the chart, never ever alter decision-making over some of the initial findings on physical exam. As a research project, looking at these dogma are a very easy, quick way for someone to develop a reputation and even get a Nobel Prize for making a major observation. Those observations are there right now to be made by each of you. Artificial intelligence is coming, and it will impact the way that things are done. We have a computer program now that treats sepsis. It treats it poorly. We have spent millions of dollars on this software program and the analysis. We've had it in place for 5 years. We have not altered one iota the mortality rate. We have altered our compliance with the bundle, but we have not altered using this artificial intelligence, our deaths from sepsis. We have now a computer program for artificial intelligence that determines whether or not the reading of X-rays is correct, or the following of X-ray recommendations is done by the primary care physician. I'm not sure that's the way medicine ought to go. We now have the internet. We have the availability to find information very quickly. We have downplayed the history of surgery. Perhaps we ought to reanalyze that. We have also decreased technical skills. There are surgeons that all of us know who absolutely have wonderful hands. We have surgeons that should have become pediatric immunological psychiatric psychologists because they really don't like to operate. I've heard surgeons say in the last year, if I don't have to go to the operating room again for the rest of my life, I will love to just practice critical care or even analyze quality assurance and utilization review. A surgeon must have technical skills, must be seen as the person who, using their hands, using a knife, is the go-to doctor for that particular problem. There have been technical changes in extracorporeal support, ECMO, minimally invasive hybrid and robotic surgery. We have discovered new operations and approaches, and we apply those to the super sick patient. There are new techniques in oncologic surgery, and there are innumerable new widgets. Some of those widgets have come out of even the artificial intelligence that occurs in our watches, things like a wearable technology to warn a patient when they are about to fall. There are changes in pre-hospital transport and the ambulance services, the dispatch services, even air ambulance services. It's not just an ambulance and attendant, but specialized training during transport. Perhaps we have focused too much on some areas. Quite honestly, I think we have overemphasized resuscitation to the point of over-resuscitating, and we focus too much on blood pressure, not just central nervous status and the presence of a peripheral pulse. This has resulted in a higher mortality during COVID when we have tried fluid challenge and resuscitate, often fluid overloading the COVID patient, just like we overload the blunt trauma chest injured patient, creating ARDS initially in Korea. The ambulance is much like a mobile ICU. It might include air ambulance, although there is question about whether air ambulance has really impacted outcomes or not. It also requires supervision and revision, and drone ambulances in the United Arab Emirates is already being developed, even without attendants at time. I've even seen a mock-up of a very large drone ambulance with the possibility of a Da Vinci device inside, whereas 1,000 miles away, someone may even operate with a technician inserting the probes and the operation done at some great distance. There have been changes in the quality review with TQIP, and time doesn't allow me to go into great detail, but TQIP has had great change on the availability of comparison results, and it addresses a number of areas. Trauma research has a change. Control of truncal bleeding using even intra-aortic occluding balloons has been done, as well as a number of clamps. We're looking at control of inflammation, traumatic brain injury, advanced rehabilitation, and many others at the clinical level. Trauma economics likewise are changing. A lot of money is spent on trauma, but in the absence of a trauma system, more money is spent. With trauma system, there is a reduction in all cost areas, duplications are reduced, efficiency is demonstrated, and of course the outcomes are better. So I am saying to you, both the College of Surgeons, the trauma organizations, Joint Commission, the ACGME recognizes that the combined morphed surgeon with trauma, critical care, and acute care surgery skills is a recognized set of disciplines and knowledge base. And this is the morphed comment I would like to leave with you as we talk about TCC-ACS. It is a specialized body of knowledge that requires special skills. Not just any surgeon is capable of filling this role. It's most often not elective. It's linked to surgical critical care and has a significant impact on improving society. Some new skills include stopping bleeding with belly foam, farmed blood from stem cells, regenerative surgery, tissue, organs, and the use of suspended animation perhaps in the future, and as well as I've already mentioned, use of drones with robotic surgery capability. The systems, therefore, are changing. It's an integrative, collaborative network, just like the internet, where EMS, emergency center, operating room, surgical ICU, referral centers, quality review with loop closure, military and disaster medicine, all is encompassed, led, supervised, visioned for visionary concepts by this surgeon of the present and the future. There's a role there for you. It brings local, regional, national, and international surgeons together, just like today. It creates a standardized approach that's not cookbook. It improves results, utilizing emerging virtual technology and the internet, and allows sharing of resources. I sensed this even during the Gulf Wars years ago, when someone I had trained was in Afghanistan. Into the chest was something they'd never seen before, and they wanted me to tell them what to do. I said, it sure would be nice to be able to be there with you and see. They took out their cell phone, turned on the lights, put the cell phone into the chest, and it was indeed telemedicine. Telemedicine may be as simple as a cell phone that works. And the College of Surgeons has put together an optimization quality book on regional trauma systems as well. There is also impact on other areas. General surgery as we knew it is disappearing. Trauma care is much what general surgery used to be. And this area we're talking about is an excellent trauma base for general surgery. Already, we are naming our faculty at the Ben Taub that work in general surgery, trauma, critical care, acute care surgeons. And our protocols for our M&M likewise talk about the acute care surgery service that does all of that emergency surgery, the nighttime surgery, the critical care, and the trauma. The cancer service, surgical oncology, the thoracic and vascular services are at the Ben Taub are separate, and they serve as consultants to TCC ACS. There is a discussion about where should burns, neurosurgery, vascular, thoracic, orthopedics, surgical infectious disease, and plastic reconstructive be in this new paradigm. That's still under evolution and still yet needs to be developed. That may be a local phenomenon. I talked a little bit about disaster. Time doesn't let us go into great detail, but I have discovered that the best results that are occurring in America hospitals from COVID are occurring when that COVID patient is admitted to the surgical ICU and cared for by the TCC ACS surgeon, when even compared to the pulmonary intensivist. And that data is just now beginning to come out. And of course, military medicine has been linked to this surgeon throughout history. Time doesn't allow me to go into a great detail on information I had on those slides. Finally, trauma education, trauma critical care ACS education is there through a number of courses, both locally and regionally and internationally. This helps us in our communication with each other, as well as having a lot of textbooks to read. You are aware of the international programs, both for ATLS in all over the world, as well as ACS Global and the programs that together we have International Injury Care Committee. A number of you are on that committee and have had conferences in your country and in your city. A new structure within the Committee on Trauma of ACS. So this new surgeon, this new TCC ACS surgeon of the future is what general surgery used to be before all of these changes forced the change that we now have made. There's a wide range of skills up to and including interventional radiology in a surgical hybrid suite. It does, in my view, must include vascular and thoracic competencies. The vascular and thoracic surgeon of today are not trained well in acute care surgery and in trauma. It has critical care skills. Indeed, this is the most respected physician in the community. It is the physician that you, the nurses of your hospital, your politicians in your area, when there's a complex case, go to because they know they're going to get best of care. It is that person, the go-to physician of the community, that each of you should aspire to be. As I look to the future to be the most promising career, the greatest opportunities available, it is in this area. However, I wish to say to you, the person who finds themselves there has a special genome. This surgeon is not for everybody. It is not for the weak. It is not for the timid. It is not for the short-sighted. It is not for the follower. It is not for the person who is insecure. It is not for the person who does not like to tie knots and does not like to find themselves in the operating room. It is for the visionary. The morphed individual has a unique genome, is competent with the most complex of medical and surgical problems, knows anatomy and physiology better than anyone in the community, can be trusted with your family, is that go-to physician. The physician, surgeon of the future, that's a brave, visionary leader aspired to be, are literally in this virtual conference room right now. Take advantage of this opportunity. Margaret Mead said, "Never doubt what a small group of thoughtful, committed citizens can do to change the world." You put together this conference as this small group of thoughtful, committed, dedicated leaders, because that's the only thing that has ever made a difference. So in summary, go to the heart of danger, and there you'll find safety. I wish to be there with you as we change the world with the changes that need to be made in our genome, in our approach, in our hospital, in our education, in our curriculum, and indeed in the outcome of our patients. Thank you for letting me share these thoughts with you.
Thank you.
Excellent.
Thank you, Professor.
That was, I think, it was such an inspirational and it was simply awesome talk. And I think, no doubt, the community of trained trauma surgeons and critical care, trauma and critical care surgeons is very small right now in India, but we have made a beginning. I'm sure with your guidance And your message of a comprehensive physician cum surgeon would become a reality in India also very soon. We are trying that. I'll just introduce the panel of the day who would like to discuss certain things with you. Along with us is Professor Mahesh Mishra. Professor Mishra was the director of the All India Institute of Medical Sciences, formerly, and also the chief of the Trauma Center, the Apex Trauma Center in New Delhi in India. Professor Mishra was instrumental in bringing the ATLS course to India as a small beginning, because that was very, very essential. As you can say, that was the beginning part of bringing some sort of a sensitization about trauma in India. He's been looked at as a mentor for all of us, a guiding force in the trauma care scenario in India. I also have with me Professor Subodh Kumar. Professor Subodh Kumar is the professor of surgery along with me, my colleague at the Apex Trauma Center, trauma and critical care surgeon. He is also the vice president of the Indian Society for Trauma and Acute Care. I also have along with me Professor Sushma Sagar. Professor Sushma Sagar again is the professor of trauma surgery and critical care and is the joint secretary of the Indian Society for Trauma and Acute Care. I would begin with Professor Mishra, his comments on the talk which Professor Mattox just gave, and any questions he would like to have.
Thank you very much, Dr. Amit, Professor Subodh Kumar, Professor Sushma Sagar, to get Professor Kenneth Mattox, the father of trauma, concept of trauma, trauma surgery in globally. We have grown under his shadow around the globe over last 40 years. We have been hearing since Professor Kenneth, when I took up trauma care fellowship in UK in 1988, my colleagues were laughing. What is this trauma you are going for? Because at that time, cancer was in forefront and most surgeons were devoting themselves to cancer surgery, cancer specialization. I say the difference today is that in 1988, we were losing 60,000 young lives on our roads in India. Today, we are losing more than 200,000 lives in India on our roads. You know that. Disability adjusted life year lost because of trauma, you have very well outlined and focused. It's a disease of the young. And what I liked most in your presentation, that you characterized the surgeon and particularly the trauma surgeon. That trauma surgeon has to be a leader. There is no doubt what you have said on the top. Also, trauma surgeons have to make quick decisions. So that's what you said. We have to have situational awareness and we cannot turn our back on anything and we have to be aware all around. I entirely agree with you and this has been my philosophy. We also use data and wherever I go, I ask people, do you maintain your diary? Do you maintain your logbook? And people say no. Even in COVID times, I have been asking those who are caring for COVID in critical care units, in other areas, do you maintain that how many patients you saw, how many recovered, how many required oxygen, how many went on ventilator, or how many were harmed because of your ventilatory support? Then you said surgeon is an innovator. Yes, we do need to innovate when the patient is bleeding. We have to innovate. And we always grasp the opportunities. You very well articulated that. And naturally, we have to abandon dogma all the time as a surgeon and as a trauma surgeon more so. So that is, you outlined, I think, for young surgeons who have not been familiar with your stature. You have your book. We have been reading your book for last 30 years. First time I saw that in UK in 1988. And it could not have been a better finale for this virtual meeting, Trauma 2020, where you graced and you gave your wisdom to all of us. Thank you so much, Professor Kenneth. And you look still very young. I don't see that you have retired or you have abandoned. You look very young to me. And we have to be young here and young here. So that's what. Thank you. Thank you so much. Thank you so much.
Namaste. Namaste, is namaste a good word?
In COVID times, President Trump said, this is the way to go. Because handshake was not allowed in COVID times, to keep a distance. So this has come global. So this is namaste.
Namaste.
Thank you so much, Professor Kenneth Mattox. It was an enjoyable, thoroughly enjoyable discourse from you. And we enjoyed every minute, every second of your talk. Thank you so much.
Thank you, Professor Mishra, for those kind words. And let me tell all the audience that although Professor Mattox was visible to you in the hall only at around 6:10 p.m., but he was there around the other side of the globe. Is still very early, but he was online at about 4 or 3:50 a.m. In Texas. And it was just amazing to see that he was there as an attendee and patiently hearing all the deliberations which were going on. It was really heartening to see. And I think he always loves to lead from the front. And therefore, that is why he was here to inspire all of us so early. Thank you, Dr. Kenneth. Dr. Subodh would also like to say something.
Thank you, Dr. Amit. And it was really eye-opener, and it was really wonderful talk, and it was very inspiring talk, and it will, I'm sure it will give a boost to the young body surgeons and the postgraduates to take up this specialty, because we used to wonder, and I think because more and more patients of trauma are being managed non-operatively nowadays. So there was a fear in the mind of young body surgeons, their surgical skills will go away, and how will they keep their surgical skills intact? So with the inclusion of the non-traumatic acute care surgery in the curriculum, and it started with the United States, I think it will attract more and more surgeons to take up this specialty. And it was really a marvelous talk, and we all will be benefited with your talk. Thank you very much.
Thank you. And to Dr. Mishra, I wanted to show you, here's my diary. It's always in my pocket. It's a small size, so it fits into a small pocket. And my last entry was at 2 a.m. this morning.
That's right. I think all young surgeons and whosoever is watching you and listening you must learn this, maintaining a diary. It's so important for all of us. Thank you so much.
Yeah, Dr. Sushma is also there on the panel. Dr. Sushma is a leading lady trauma surgeon in India. I would request her to also comment something.
Thank you, Dr. Amit, and Sir Mattox. It's a pleasure. It's a pleasure, and the more pleasure was going through this journey from 1960 till date, and so beautifully you've explained that you're coming from an era when there were no ventilators, when there was no space travel, and today now we are talking each other in front of the screen. It was really wonderful, and I'm sure that this talk of yours will definitely arise the fire among the surgeons who are still wishing to take up trauma as their career choice. And I would like to tell you that MCH as a super specialty branch, trauma surgery came to India in 2016, and we've had about 10 batches who have entered in this specialty. 4 centers of the country, people are taking up trauma as a super specialty branch, and 4 batches have passed out, and they're working as a faculty at various leading institutes of the country. And today having you with us really have boosted our morale, and I'm really thankful, and I'm feeling so privileged to have you among us. At the same time, I would like to also announce the results of the session today. During this conference, we've had about 9 sessions wherein we had various topics were covered, including chest trauma, abdominal trauma, and this time we also had session on acute care surgery. So we had 2 very prominent sessions by the prominent speakers of the country on acute care surgery, who talked about early cholecystectomy and early appendectomy and pneumoperitoneum and all these topics, apart from the trauma surgery. And then today you saw the talks on amputation, ventilation, and on the organ donation. So we had about 160. We had about 147 presentation this time. Can you see the slide? About 147 abstracts were received, and out of those 147 abstracts, we selected about 16 for the oral paper presentation, wherein they were judged by the trauma surgeons. And during this oral paper presentation, the third prize goes to Dr. Vikram VS. He's a resident in the Department of Surgery at AIIMS Bhubaneswar. His topic was RCT or new methods to reduce SSI in peritonitis cases undergoing emergency mesh laparostomy. And he gets a cash prize of rupees 3,000. The second prize goes to Dr. Ruchi Pathak Kaul, who's a PhD scholar in the Division of Trauma Surgery and Critical Care. Our topic was 3D assisted outflow pattern to strengthen the rehabilitation limb of trauma, and she gets a cash prize of rupees 6,000. The first prize goes to Dr. Soumya Ghoshal, who's an MCH trauma surgeon. He's already completed his MCH, and his topic was on outcome correlation of initial ABG analysis in isolated thoracic trauma, and he gets a cash prize of rupees 10,000. We also had an interactive poster presentation wherein people presented their posters in front of the judges. Out of that, the third prize goes to Dr. Joseph Denny, who's an MCH trainee in the Division of Trauma Surgery, and his topic was on comparison of trauma system following relocation of level 1 trauma center during COVID pandemic. He gets a cash prize of rupees 2,000. The prize is also shared by Dr. Kevin Khatri, who's a resident at AIIMS Bhatinda. His topic was on cemented galar replacement versus stem cemented hemiarthroplasty in unstable intertrochanteric fractures in octogenarian. The second prize goes to Dr. Purvam P. Jivarajan, who's a resident at Dr. D.Y. Patil Medical College Hospital, Pune. His topic was on vacuum-assisted closure following wound healing in large wounds, and he gets a cash prize of rupees 3,000. The first prize goes to Dr. Vijayan Purushottam, who's an MCH trainee resident in the Division of Trauma Surgery. His topic was, he presented a 5-year data on soft tissue management at level 1 trauma center in urban India, and he gets a cash prize of rupees 5,000. There were about 30 posters which were on display, and out of those 30 e-poster, the consolation prize goes to Dr. Ashima Mishra, who's a junior resident in the Department of Medicine, Vimsar, Burla. Her topic was deficits in lightning and electricity injuries, a retrospective analysis. And her poster gets a cash prize of rupees 2,000. There were case reports also, about 29 case reports were on display. And in those case reports, one was very outstanding by Dr. Santosh Sairubal Nagesh, and he's a resident at JJM Medical College, Davangere. His topic was a rare cause of acute abdomen in pediatric age. And he talked about wandering spleen with torsion and its management. He gets a cash prize of rupees 2,000. Thank you.
Congratulations to everyone, and well done. It was very well done, I must say. All these papers, posters, outstanding.
Thank you.
Dr. Schussman,
thank you so much.
How many of the recipients of prizes were women? I did not count 50%. Next time, I want to see 50% are women.
Yes, sir.
At least
yes,
50% being women.
Yes. Probably, sir, your talk will take them to take up this specialty. So maybe next time we'll have more women surgeons here.
We have more women applicants to the beta program than we do men. And we're more than 50% are women. I wanted to tell you that NASA is planning with other countries of the world, but mainly NASA and the US financing the trip to Mars. There will be either 5 or 7 occupants of the 25-month mission to Mars on board that capsule. 7, probably 5 members. One of those will be a physician, and one of those will be an assistant, like a nurse or a PA. It's already been decided that the genome for that physician will be a general surgeon with skills in trauma, critical care, and acute care surgery, because they may have a gallbladder, they may have a kidney stone, they may have a fractured femur. It may be that they will use some telecommunication, but from halfway to Mars back to Earth, it is 30 minutes. You say, hey, I have a problem. Can you help me? You put the phone down and you wait 30 minutes. So there's going to have to be innovative ways to be the doctor for the Mars mission. And I project that somebody on this conference today could well be that physician and aspire to set their footprint on Mars as being the doctor to the Mars mission, because they were the trauma, critical care, acute care surgeon.
Thank you.
Thank you, Professor Kenneth. I think it's been an enlightening session altogether. As Professor Mishra said, a grand finale to this year's conference, although virtual. But still, I have a hope, and I was, chatting with you on WhatsApp that is the Las Vegas conference going to be there? And you said yes, it's going to be there live, and probably next year we all would be there, not virtually, but along with you in the Las Vegas conference, and probably the year next we can invite you, or maybe next year we can invite you in person to India to see our colorful country. It's been a pleasure, having all the panelists there, Dr. Subodh, Dr. Sushma, Dr. Mishra, and yourself along with me. And thank you so much. I think I would not like to, continue it further, because I know you've been around for more than 3.5 hours. And it's been a tiring day for you. It's just begun, for that matter, in Texas. But with that, I would again thank all the delegates, thank all the participants who are there up late in the evening. Oh yes, I'm sorry. I've been reminded that there is another result to be declared, and that is about the trauma quiz. I think if Dr. Mohit is there, he can open his camera. And Dr. Mohit was the quiz master, sir. And there was a quiz, a wonderful quiz which had many unusual questions about celebrities and trauma, about many other things. I think Dr. Mohit would tell you more about it and then finally give the results. I'm extremely sorry, I just forgot that part.
Mohit, please start. Mohit, please unmute yourself.
Please unmute. Could you open your presentation of the quiz and show Dr. Mattox some of your mind bender questions, because they were really
sure, sir, I'll do that.
Some of them. Yeah.
Give me a minute, sir. I'll just open it.
Quickly, in 2 minutes, just a celebrity will.
Here it is.
some sneak peek into the questions. Yeah.
Yeah, quick one. Slideshow.
Slideshow.
Hope that the screen is visible now, sir.
Yes.
Yes, it is.
So this is how we started. And me, along with my friend, Dr. Harshit, who is an MCH trainee in trauma surgery and critical care. Then we had these 30 questions. We started with paying homage to the COVID warriors. So we had a recent report in the Lancet regarding a trauma surgeon who lost his life recently. And this is how we went and we started the things. Following this, we had few sections, the first section was trauma and celebrities. And then we had this the Indian politician who lost his life to trauma. Then we had this famous cricketer who lost his life because of a vascular injury when the ball hit him in the neck. And then how we just again added something as to how this has changed the design of the helmet following this catastrophe. We had again few celebrities who were victim of trauma and how their inspiring stories as how they overcame the trauma and they became famous personalities. We had few questions on injury prevention, right from the use of 3-point seat belts when they first started to how the motorcycle helmet was made by a doctor. This was followed by some of the Indian Bollywood actors who were part of the road safety campaigns in India, and this is how we went. So there were a total of 30 questions. We have many participants, and then when this quiz was on, we had 32 participants, and now I'll just share the results with you. So of all the participants, the first participant, the winner of the trauma quiz is Dr. Soumya Ghoshal. He's a senior resident and has done MC's trauma surgery and critical care from JPN-ATC and AIIMS New Delhi. He scored 28 questions out of 30 correct, and then he wins rupees 5,000 as the first prize. We had a tie in the runner-up, and then we had two participants who scored the same. Number one is Dr. Nishtha. She is a PG third year in surgery, UCMS in GTB Hospital in New Delhi. She scored 26 out of 30. And then Dr. Supreet Grewal, who is senior resident again, and she is doing MCS trauma surgery and critical care from JPN-ATC and AIIMS New Delhi. She also scored the same, and both of them, they will receive a cash prize of 3,000. I congratulate all the winners. Thank you so much, sir.
Thank you so much, Mohit, for declaring the results of the quiz. It was the first time we had organized such a quiz at the trauma conference. And now it's time to say goodbyes, and I would finally thank once again Professor Maddox for his involvement in the conference.
Next year conference.
And
the next year's conference, if physical, would be held at AIIMS Rishikesh for all the delegates. And also, if it is virtual, we can have some midterm conference in the middle. So we will keep you informed. We will keep you, abreast with whatever is happening with the Indian Society for Trauma and Acute Care. With a lot of thanks to Professor Maddox and Professor Mishra for having joined. I would say goodbye to all of you. Thank you.
When the vaccine comes out, get the vaccine. Get the first one. It doesn't make any difference. It will be out very, very, very soon.
Thank you very much. Thank you, everyone. Thank you all the participants and delegates.
I would also like to, Dr. Subodh would like to request all of you who are listening to please volunteer for the vaccine trial, for which recruitment is on at AIIMS itself right now. So kindly go in large numbers and contribute towards this cause. Thank you so much.
So thank you very much, all the delegates and participants for attending this conference and make it a success. Thank you very much.
Thank you, sir.